Good afternoon, everyone. You are in the Senate Finance Committee. Thank you. You're in the Senate Finance Committee. Today is Tuesday, February 20th. We are going to hear, I think, a dozen bills today. The first bill will have 36 witnesses, and we have a rule: if you have more than 30 witnesses, other than the sponsor, everyone else gets 1 minute. So I ask that you respect that. And then on the other bills, the sponsor will get as much time as they need, and everyone else will get 2 minutes. So that's our rule for today. This is the order of the bills: Senate Bill 453, Senate Bill 739, Senate Bill 167, Senate Bill 594, Senate Bill 714, Senate Bill 599, Senate Bill 718, Senate Bill 996, Senate Bill 408, Senate Bill 716, Senate Bill 427, and Senate Bill 506. So that's our dozen bills for the day. I'm going to bring up our first bill, Senate Bill 453. Secretary Herrera-Scott, thank you for being here. And also her panel is Deborah Bennett, Eric Lukey, Mark Grant, and June Chung. And our sponsor is, it's the administration. So thank you, Madam Secretary. You can begin whenever you're ready.
Good afternoon, Chair Beidel and committee members. Thank you for having us today. I'm Laura Herrera-Scott, Secretary of Health for the record, and I'm proud here to testify in support of Senate Bill 453, which would create an assistant outpatient treatment program in Maryland. This program would target a small subset of individuals with serious mental illness who are unable to voluntarily seek care due to a lack of insight into their mental condition. I would like to share an example from a policy paper put forth by the National Council on Mental Wellbeing that illustrates what happens when individuals with serious mental illness are unable to engage in ongoing treatment. And though this is just an example, this is at least what the department deals with every day as part of our competency evaluations. Mr. Y is a 24-year-old man who was arrested at a convenience store on a Friday afternoon for eating multiple bananas without paying for them. When the clerk demanded payment, he refused and became increasingly argumentative, so the clerk called the police. Police officers found a disheveled young man standing in a corner clutching a banana that he pointed at the officers as if it were a weapon. He remained uncooperative and illogical, yelling that the store clerk and the police were in the plot and out to get him. He became combative when police attempted to handcuff him and had a blunt of marijuana in his possession. When the officers reviewed his record, they noted 2 recent previous calls, one for a similar incident and another for vagrancy. On both occasions, he was given warnings. This time, he was arrested and taken to the local jail, where he remained agitated, uncooperative, and disorganized during the booking process and during a night in jail. Screaming so loudly, he had to be moved into a solitary cell, where he spent the weekend crying and yelling that he was being tortured. When taken before the judge on Monday morning, he was agitated then, more than the previous day, and was hoarsely shouting nearly incomprehensible things about the judge and the public defender conspiring against him with demons. The judge was concerned that he was not competent to stand trial on charges including theft, resisting arrest, assaulting an officer with a banana, and marijuana possession in order to competency evaluation. Mr. Y remained in jail for several months, waiting for the completion of the evaluations. 6 months later, 2 evaluators determined that Mr. Y was not competent to stand trial. The following month, the judge adjudicated him incompetent and ordered the State Human Services Agency to send Mr. Y to a state psychiatric facility for restoration of competency. Since there were no available beds at the restoration facility, Mr. Y remained in jail an additional 6 months until a bed became available. AOT is designed to support people like Mr. Y, individuals with significant mental health needs who are not dangerous. Unfortunately, the experience of Mr. Y is far too common in Maryland. The absence of AOT has perpetuated the criminalization of mental illness, stripping individuals of their civil liberties and their dignity. In many instances, interactions with the law enforcement and time in custody are further traumatizing. National and state data that demonstrates that individuals with mental health conditions are overrepresented in the state's psychiatric hospitals, prisons, and jails, as well as the state's homeless population. In Maryland, it is estimated that nearly 40% of people in jail had a current mental health disorder, and 1 in 4 suffered serious mental illness. MDH operates 5 adult psychiatric hospitals. The vast majority of individuals in these facilities have court involvement and have been found to be incompetent to stand trial and not criminally responsible due to the nature of their illness. Roughly 15% of the individuals in our hospitals are just like Mr. Y. They committed misdemeanor crimes and wound up in jail where their mental health further deteriorated. This bill would help break the cycle between homelessness, frequent hospitalizations, contact with law enforcement, and ultimately incarceration for people with serious mental illness. While AOT can result in court-ordered treatment, the amendments offered today will afford individuals the opportunity to engage in mental health treatment on a voluntary basis. A court hearing would only be scheduled if the individual has not agreed to participate in treatment. In practice, states with similar AOT provisions demonstrate that the majority of individuals agree to enter into treatment on a voluntary basis. In California, the AOT program has demonstrated high voluntary participation. 75% of total individuals referred for an assessment who were located for services participated voluntarily. The governor's proposed budget demonstrates the administration's commitment to Maryland with serious mental illness and provide resources to ensure that AOT program is effective. And with that, we ask for a favorable response to SB 453. Thank you.
Thank you, Madam Secretary. Who would like to go next?
Yes, good afternoon, Madam Chair, Vice Chair, and committee members. My name is Deborah Bennett. I am a member of the Maryland Commission on Behavioral Healthcare Treatment and Access, a volunteer Maryland ambassador of Treatment Advocacy Center, a NAMI Prince George's County member, but most importantly, I am the mother and a former caregiver. I'm asking you to support SB 453 because it saves lives. My beloved son, Ben, tragically died at age 35 from an anoxic brain injury on December the 8th, 2023. 4 days prior to his death, he was found unconscious on a Baltimore City street and admitted as a John Doe to the same hospital that he had discharged from only a week earlier after a 30-day voluntary admission. Ben was one to always agree to voluntary outpatient services. In fact, he had started at least 11, and prior to his discharge from his last hospitalization on November the 27th, he agreed to 3 additional outpatient treatment services. 7 days later, he was deceased. I received notices from Medicare last Thursday and found out that he had gone to the ER 2 additional times the last week of his life. I ask that you pass SB 453 so that my son's life was not in vain. Thank you.
Thank you, Ms. Bennett. We'll have questions at the end of the panel. Thank you.
Madam Chair, members of the committee, for the record, Eric Ludke, Chief Legislative Officer to the Governor. I'm not here today actually as Chief Legislative Officer, but also as a family member. It turns out we just discovered Ms. Bennett's son and my brother have the same condition, a condition which leads to people being in and out of hospitals, in and out of interactions with the police, leads to a constant struggle to help our loved ones get the care that they need. For my part, I haven't seen my brother in more than a year. I don't know today if he's alive or dead. I live in fear of a phone call from the police like I got a couple of years ago on Christmas Eve when he wasn't agreeing to leave the Rockville Library and I had to go to de-escalate a situation with the police. AOT is not a panacea. It will not solve every behavioral health challenge that we have in the state. It is an additional tool that we need in our toolbox for certain specific, seriously challenged cases. So I'd ask for a favorable report from the committee.
Thank you.
Madam Chair, Vice Chair Kosmeyer, members of the Finance Committee, thank you for this opportunity to be here, to also ask for your support and to be here on behalf of the administration. I want to acknowledge and thank the co-sponsors for this bill, that this is a bipartisan issue, that this is an issue that affects people regardless of your race, gender, political affiliation, your age, your ethnicity. This is an issue that affects all people. Right now, what we have is we only have involuntary inpatient commitment, right? Where you have to reach a level of dangerousness. This is a very extreme standard that needs to be reached in order to actually get assistance. What AOT can do is it can prevent people from escalating to that level and to that degree. So what does it mean that 47 other states have AOT laws on their books? It means that those 47 other states have another option. We only have this involuntary inpatient commitment. And what AOT can do is bring another option to the toolbox to address our behavioral health crisis. So thank you very much.
Grant?
Thank you, Madam Chair, Madam Vice Chair, committee members. I'm Marie Grant, Assistant Secretary for Health Policy at the Maryland Department of Health. I wanted to share with you all a little bit. You'll be hearing from lots of folks today. The department and the administration have been doing a lot of work with stakeholders on amendments to make sure that we are making this an option that is available, but that is appropriately tailored to folks who have serious and persistent mental illness. A couple of changes I just want to highlight that we'll be offering to you all for your consideration. There are a couple of changes regarding emergency evaluations in the bill about transportation and admittance. We are going to be offering changes to those provisions. We're going to be offering changes that tighten definitions, that give counties a longer timeline to come into compliance until July 1, 2026, that allow for voluntary agreement to an AOT order, and that make changes to the reporting at the end to make sure that we are accurately capturing and reporting out who is participating in AOT programs. So thank you for your time.
Thank you to this panel. And I know it's a really difficult issue, but y'all did really well in your 1 minute, and I appreciate you respecting that. I have 4 questions. I'm going to start with Senator Lamb.
Thank you, Madam Chair. And thank you for bringing this bill forward. This bill is obviously really important. So I'll just start with the fact that AOT is the single issue that my office has probably had the most number of meetings on with advocates over the years. And there's a perception out there that I think folks think that we don't care about AOT as a tool to be able to help folks in Maryland with mental illness. So I want to just preface this by saying that I strongly believe that our state is failing the sickest residents that we have every single year. I'm just trying to figure out where AOT fits in as a tool for usage here to address these mental health needs. How many people do you believe would be eligible for AOT here in the state? And can you share what that number is estimated to be?
So I don't know the number per se. I can tell you that right now on our waiting list, about 15% are Mr. Y that are on our waiting list is sitting in jail waiting for a competency evaluation or waiting for a bed. So they're actually going to time out of their charges. And the exact person that comes to mind was a very similar issue where they stole a Mountain Dew, and that started a whole cascade of events that has them in the system. So I can tell you what's on our waiting list and who's in our system today, but that's what we know of from arrests. We don't have any sense of the number because of homelessness and or the number of patients that are potentially pinging between the emergency rooms and outpatient centers. We think overall it won't be a big number because not everyone will meet the requirements for AOT. They might need inpatient care or other or outpatient crisis services, but we don't have an exact number right now.
So not a big number being dozens or hundreds?
So more than dozens, less than 1,000. So it's really hard to say at this point until we offer the services in the state.
Okay, so hundreds somewhere in that range.
One
Hundreds would be less than 1,000.
Right, but I don't even think it'll be more than a couple of hundred based on the numbers that we know of today. But again, there's a lot of people we don't know that are under the bar right now, not getting services.
So the current budget, when I look at this, includes $3 million for the program. If you divide that by the number of counties and jurisdictions here, that comes out to be about 120,000 per county coming out of this program. Based on some of the research that my office has done, it suggests that each program likely needs quite a bit more money than that to be able to account for the needs, perhaps up to $3 to $4 million for some of the larger counties here in the state. what funding do you envision that would be available to help meet that gap?
So, as Assistant Secretary Grant mentioned, we are extending the time period. So there's more of a glide path for counties to come online. And we're certainly looking at all our dollars at the Behavioral Health Administration. So thinking about the dollars that we get from SAMHSA, other general fund dollars, and with the work that we're doing to expand crisis centers and mobile crisis teams, they will certainly have a role on this. So that's work in development that we will certainly be working towards, using that money for the counties that are ready to go first, but then working with the counties and that are not ready to go forward right now and understanding what their needs are. For some of the regional parts of the state, it might look like more of a regional approach. So for example, the local behavioral health authority on the Eastern Shore is Midshore Health, and they provide services to a few counties because the N is so small, it didn't make sense to have services in every single jurisdiction. So we'll be working with the local behavioral health authorities to map that out.
So the counties will have to help close that gap in the budget needs?
No, that's what I'm saying. We'll be looking at our own behavioral health administration dollars
Okay.
as the counties come online to wrap around with the 3 million that we have in year one.
Okay.
Senator, the $3 million is essentially with the delayed effective date of the bill is really about planning and, sort of developing the program. It's not necessarily about the active running of the program yet.
Do we have any sense of how much so this is planning dollars, basically. Do we have any sense how much the active running of the program will?
So it'll look
Require.
different per jurisdiction based on the morbidity in each of the jurisdictions.
Okay. Obviously, a lot of advocates have come to speak to us in our office, as have some insurance attorneys, and they also shared that even if a judge ordered a service, the carrier could still do their own medical necessity assessment and deny coverage. Would you be open to an amendment to make it clear that a respondent can't be held accountable for paying for any ordered services? So basically saying that, if you have to engage in these services and making sure that they're also not being required to pay for them if they're not able to do so.
So right now, the state's paying for those services today.
Okay. But would you be open to an amendment to clarify that?
We'd be happy to take a look at language, Senator. As the Secretary just said, I think most of these folks are receiving Medicaid services through our public behavioral health system today with no cost sharing, but certainly happy to take a look.
Okay. When we looked at other states in New York, these individuals who were subject to AOT orders were oftentimes disproportionately African-American. And advocates for AOT have shared a study that says that this is because African-Americans are, and quoting from the study, quote, higher likelihood of being poor, higher likelihood of being uninsured, higher likelihood of being treated by the public mental health system rather than by private mental health professionals, end quote. Does this bill do anything to address those structural issues that leave Black Marylanders more likely to be subject to AOT?
Well, I will say department-wide, we're trying to address the structural issues, not just this program. I think in the first year or so, as we were to get going, the demographics that you just described are the demographics that are on our waiting list, and we absolutely have work to do to change that paradigm. We know, even just looking at our claims data for 21, 22, and 23, that people of color are not getting access to the services they need less often than people, that are Caucasian. So this program in and of itself won't solve that issue, but we are actively looking at all our programs and looking by race and ethnicity. So certainly from the Department of Health's perspective, looking to address these issues structurally, not just this particular program, but across all our programs.
Okay.
May I also answer to that? My answer to that too is that the way the bill was designed was that we have reporting. The reporting mechanism is there that is actually collected by the Behavioral Health Administration. So obviously the Department of Health would be tracking that. My other issue, and sort of like that I would like to throw into the mix, is that this is actually less restrictive than being in a state psychiatric hospital. So this would actually alleviate for some of the folks that are already in the state psychiatric hospitals, that this could possibly be another program that could elevate some of those folks out of that system. And actually another statistic that I'd like to point out, which I think is actually quite horrific, is that 70% of the state psychiatric population is Black. That is problematic. And I think that we have to look at those numbers, and that this could be a program that could actually alleviate some of that.
And I appreciate the recognition. I think the secretary mentioned this as well, that, we have very few state psychiatric beds. And we lost a lot under the prior administration, and we haven't recovered that. When the part about the amendment that I mentioned earlier about being able to ensure that individuals that are being compelled to go through AOT are not being compelled also to pay for it. There, for example, are a lot of young individuals that are schizophrenic that are still perhaps in that age range where they're falling under their parents' insurance. So this could still be hitting private insurance and beneficiaries under private insurance as well. So just trying to keep that in mind. With that, let me pass it back to the chair. Thank you.
Thank you, Senator. So next we have Senator Reedy.
Thank you, Madam Chair. I think I have two areas of questions, and I'll try to move it through quickly. First of all, I'm very enthusiastic. I'm a co-sponsor of the bill. We've worked on AOT issues and issues like this for many years in the legislature, and they're thorny, but I think it's an idea whose time's long past to try to find this bridge. I don't know what else to call it, but a bridge to try to figure out how we can address this particular population. Couple questions. First is discussing that, and I don't know if this was an amendment, or if this is how the bill originally was going to be, but the issue of you can agree to mental health treatment with a stipulated voluntary agreement to avoid the hearing, so the hearing is dismissed. I guess my question would be, what's the protections in the bill to avoid someone doing this repeatedly and agreeing to the treatment and then not following through after a period of time? Because this population obviously are folks who, our problem is they don't follow through on their treatment, for a variety of reasons. Is there a safeguard to say you can agree to this, but you have to follow through, or you will go to a hearing? How does that work?
So I think under amendments, we're going to give the opportunity for folks to volunteer once a petition has been filed. And then a treatment plan has been developed that would be reviewed, and a respondent would be given the opportunity to voluntarily come into compliance with the treatment plan. And at that point, the petition, I think, would be dismissed. That all being said, there's still opportunities and protections, because at this point, again, we're in a court setting, it's a court proceeding. There are opportunities for folks to come back at that point. But Senator Reedy, I do just want to emphasize, and I know that folks have different opinions on this, right? We are seeing in other states that it turns out that over half, as the secretary cited, voluntarily agree to a treatment plan once that stage is reached. And but
when they agree to the treatment plan, what's the statistics on them sticking with the treatment plan long term and not? Because if the petition is dismissed, it's dismissed, right? It can't come back without filing a new petition, or am I not right about that?
Well, that issue actually came up in the
Yeah.
work group in the HGO subcommittee.
Yeah.
So I think that's actually a good question. And Chief Judge Marcy was there and also
Okay.
sort of filling in.
So
some of
we're
those
working
things.
on,
Yes,
okay,
yes.
great.
And that's definitely something that
Yeah.
we're very open to sort of establishing, because this is a new procedure and a new process that we're setting up. That's definitely something that we're open to sort
Okay.
of like
Yeah.
working out. And I think, again, yes, I think
Because
you're making an
obviously
excellent
we
point.
want to use it as like an incentive to get into treatment, but
Yes.
there are people who will do it. And then I'm not even saying they would do it in a sinister way, but
Right.
for the very reason they're in this situation, they would agree. And then, we don't want it to be, they agree. And then 2-3 months later, we're back in the same situation over and over again.
absolutely. And I think I never want to speak for Judge Morrissey. I won't even try. But I will say there was some discussion about like court proceedings and protections and opportunities in that
Sure.
setting. So we can definitely follow up with you on more
Okay.
on that.
And then the other question I had was, I had some folks approach me about the definitions in the bill. So serious and persistent mental illness. includes a number of things that we agree with. It's good, but it does it or does it not specifically include the risk of self-harm or harm to others if the person, am not in treatment? I think because I think the definition of serious and persistent mental illness, it's I don't want to read like 3 sentences of how it describes it, but it doesn't mention that specific issue of someone who is at risk of self-harm or harm to others if not in treatment. And that was a question raised to me. Is this definition strong enough to be sure we capture the proper population that would be eligible for this?
Yeah, so I think, so there's a couple of changes. One is to the definition of serious and persistent mental illness, and the other, which I think you are talking about, has to do with the criteria that are in a petition in terms of harm to self or harm to others. And, you know, I think this is where a lot of work and discussion has happened, wanting to make sure that we are not, that we're appropriately tailoring this level of response, right? Because I think, as Senator Lamb's questions indicated, this is a serious matter, right? This is a serious option that we want to make sure is not overly inclusive, and that is really tailored to folks who may be of harm. So happy to get into the wording specifically with you.
I guess for me, my frustration, not with any of you, I know we have to be careful because I'm a big civil guy, but it's so frustrating that we're dealing with, if there was a way to, I just want to be sure we can not exclude people who really this could be very good for and helpful for, as it relates to, you know, threatening to harm themselves and harm others. I also understand you want to be careful, not just because somebody makes one comment that they're all of a sudden a part of this group. But anyway, we can talk more offline, I'm sure, but I just wanted to raise those two. But I obviously very supportive of the concept and want to work with everybody involved. So thank you. Thank you, Madam Chair.
Thank you, Senator Klausmeyer.
Thank you, Madam Chair. Madam Secretary, someone had mentioned to me that in California, they have a very similar program that is ours going to be taking on what they have.
So we haven't built out all the details of the program, just as laid out in the bill, and we will be working with jurisdictions that want AOT in their program and defining the criteria. Part of the reason why we wanted to go statewide is we will be looking at other states and the evidence behind the models that they've been using to ensure fidelity of the model when we deploy it here. The reason why we liked California was because of the voluntary the opportunity for voluntary and the outcomes that they have relating to people choosing that voluntary treatment.
Yeah, and so I know they do the treatment plans and the stabilization plans, and then it was mentioned that they have long-term injectables. Do you know anything about them?
So there are long-term injectables. I will tell you that the panel behind that, the next panel, they're all psychiatrists. If one of the psychiatrists can take the long-term injectables, they're better qualified than I am to answer that question. Yes.
Okay. All right. Thank you.
Thank you, Madam Vice Chair. Senator Guile.
Thank you. Thank you, Madam Chair. I just want to echo what Senator Reedy said, very supportive of this bill and happy to co-sponsor it and grateful for the administration for bringing this forward. I did also want to follow up. I also received some concerns about the definition of serious and persistent mental illness, and perhaps either the secretary or assistant secretary, if you could explain. So if somebody is court ordered for AOT and the criteria for serious and persistent mental illness includes that they are actively deteriorating and not stable. What if somebody is, they're start with AOT and then they become stable, but still at risk for immediate relapse? Does that mean that they're then out of AOT? How does that work then? I mean, I think, we want to ensure that folks that are benefiting from the treatment that, may still be at risk for relapse, that they all of a sudden don't meet the qualifications for AOT and then, are, I guess, for lack of a better word, graduated out. So maybe you could tell what kind of, protective parameters that there may be on the program for that.
Well, do you want to, I would just say that kind of specifics are details that would probably be laid out in regulations,
Okay.
not as it relies to the bill. I can tell you, like any chronic illness, though, you don't stop taking your medicine and then all of a sudden are better. So, you know, even if I think about hypertension as an example, you're hypertensive and you're normotensive when you take your medicine. And some people think, well, I'm normal now, I can stop taking my medicine, only
Right.
for their blood pressure to go back up. So I don't treat this or behavioral health conditions in need of medication differently than other chronic medical conditions that we treat in perpetuity.
Okay, thank you. Yeah, I just think that the desperation that so many families feel is that fear of relapse. And so just, so thank you. And thank you, Madam Chair.
And our last question goes to Senator Ellis.
Thank you, Madam Chair. And I'm just kind of like, want to say, you know, my prayers are with the family members, share your experiences, very, very difficult situations. I have a couple questions. So if an individual has a court order to show up for initial appearance, what happens if they don't show up?
Yeah. Yeah, thank you, Senator. I think there are pretty specific procedures outlined in the bill about what needs to happen. And in each case, a respondent is going to be represented by counsel. So I'm not sure specifically if we speak to what happens if they don't attend. We do talk about like entitled to representation all the way along and given an opportunity to present evidence. So I think at once, you know, there's a petition, it becomes a legal proceeding and all the rules of civil procedure still apply. So
Which is,
so in that case, I am not sure if that something stops just because someone doesn't show up. Does that make
Okay.
sense? The petition is still there. I think parties still proceed. And then any rules of civil procedure with people practicing in this space could talk about it more.
okay. So beyond the initial appearance, someone shows up initially and they have a prescribed treatment, and what if they miss an appointment?
So there is the treatment plan and non-compliance and material change procedures within the legislation. And so I think if that circumstance happened, if some sort of material change is needed, there would need to be like a motion and then replies to the motion, and then the court would make a decision on what happens next.
Okay. Okay, third leg of this question is they have a treatment plan and they're off the plan. What happens?
So I think if they are off the plan and they're under a court-ordered treatment plan, then the typical rules of civil procedure would apply. Someone would contact the court and there would be that back and forth through the court system.
Okay, so this individual with a medical issue now would be in the criminal justice system. When you mentioned typical rules of court and
This
stuff
is a
like that.
civil proceeding.
Civil.
Yeah, it's a civil court procedure.
So what does
Senator.
that mean? I mean, as far as the court has an order and someone violated an order, is that contempt of court?
I think it would depend on the case. So there's a certain level, I think, where you have like, it's a case by case basis, but I think you're right. A contempt of court, I think, could be something that could be filed. And you could move for that. But I think this is like a very delicate sort of balance that we're trying to find, and a delicate line that we're trying to walk, right? Like the goal here is for this to be therapeutic and
Right.
to get treatment.
goal.
So
Yeah, so we have a law out there that is not well defined, because you all are experts and you should be telling us exactly what the process is from A to Z with a serious bill like that infringes on potential civil liberties. So if we're not sure in here and we pass something, when it goes out there to all the jurisdictions in Maryland, all the counties and the police departments and the courts, I mean, I mean, anything goes. And so I look at the history of medical issues with African Americans, and Senator Lamb brought that up, and the disparities and the 7% African Americans in these facilities. But we all know about, say, Tuskegee experiment. But those of us who don't know about it is where the government, the US government, withheld treatment for syphilis for African Americans, knowing these men went in for treatment, and for decades withheld treatment from them, caused death, all kind of terrible disabilities with these men who went in for treatment, tricked by the government, the American government, for decades. That was public health policy. But let me bring closer to home right here. In Maryland, the Crownsville Hospital was built as a mental health facility for African Americans. And at first it was just an old plantation, tobacco plantation. And they picked up these African Americans off the street. Hey, you're committed, and go build this facility. And they had to build the facility. And they supposedly needed mental health care, right? But they were used as basically slave labor. Crownsville, there's a book that just came out in 2024 called Madness, Race and Insanity in a Jim Crow Asylum. Crownsville Hospital. The author is Antonia Hilton. Maryland government participated in this abuse of Black people for decades. So how can we pass a bill that you cannot even tell us what the procedures are, and we prescribe it and pass it out there? We're returning to Crownsville and Tuskegee. This is a serious issue. And I'll go beyond African Americans. I'll go to veterans. You know, I'm a veteran, African American, and we have, as a veteran, I spoke to some of my veteran colleagues. We have issues with basically veterans also. So we need solutions. So I don't know if anyone could, I don't know if you heard about the Crownsville, if you heard about that book. I mean, have you take that into consideration when you consider this legislation?
Yes, sir. Absolutely. Tuskegee was an abomination. What happened at Crownsville was an abomination. And they're just two examples of a long and sordid and, you know, bluntly racist history that this administration not only recognizes, but sees a moral obligation to correct. And I think what I would say in response to your extremely valid points, and I've been to Crownsville and have learned a lot about what happened there and what was done to people there, is the horrific events at places like Crownsville and in studies like Tuskegee are indicative of deeper, incredibly deep social problems that still exist, right? And they exist in the provision of healthcare and of behavioral healthcare in particular. This country and the state have failed to provide the same quality of behavioral healthcare to a range of groups, including Black Marylanders, over the years. And one of the consequences of that is over-incarceration. One of the consequences of that is that the first behavioral health treatment too many Marylanders get, and too many Black Marylanders get, is when they come into conflict with the criminal justice system. That's exactly what we're trying to prevent here by creating a civil procedure that will keep people from people's condition from deteriorating to the point that they interact with law enforcement in the first place, that will keep people from getting to the point where inpatient commitment is a real option. This is outpatient treatment.
Right. I understand that. So really one point I make, if I may, Madam Chair, one last point. Okay, yeah, thank you, Madam Chair. So when I asked the initial questions of what if, the three what ifs, I envision law enforcement officer going to enforce court order. And we ain't even talking about the George Floyd murder by law enforcement, which is a very recent history. The distrust in the African-American population of police when they show up at our doorstep. A mom calling the police because her son needs some mental health, cause another mental health crisis in that mother or that father. So we need to look at that and to really consider that. And I'll stop right there, Madam Chair. Thank you.
Thank you, Senator, for all those points. I think they're incredibly important. And I think that you've raised a lot of really important issues that we need to make sure those protections are in this language. I do just want to offer that the structure of this bill is really a it's a care-based bill, not a criminal court-based bill. The idea with engaging the local behavioral health authorities or folks overseen by our local behavioral health authorities in our counties to develop these treatment plans, that there's mandates for what they must look like and they need to evolve with best practices, is to really, to your point, not to hit that situation at all that you're talking about, but to have a care-based approach to make sure that folks are getting the care that they need. So thank you.
And can I just also add, as someone who's also served 2004, 2005, 2008 for OEF, OIF, and as a physician who took a Hippocratic oath to do no harm, this bill is trying to do that. So.
Senator, thank you for sharing your concerns. Do I have any other questions for this panel? I don't see any other lights. Thank you very much.
Thank you, Madam Chair.
Our next panel is Dr. Cynthia Lewis, Dr. Elias Shea, Dr. Rishi Gautam, Dr. Jelena Gemelshend, I won't get that right, and Pegeen Townsend. So if you would all come up, get situated, and when the first person that's ready can begin, just identify yourself, please. One of the members I called, Dr. Jelena, is virtual, so she'll be on and have her turn after all of you. Thank you.
Madam Chair, should I go first or?
You all go and then I'll do the virtual. Thank you.
Thank you very much, Madam Chair, Madam Vice Chair, members of the committee, good afternoon, and thank you for this opportunity. My name is Elias Shea. I'm a psychiatrist and the Regional Medical Director for Psychiatric Services at MedStar Health in Baltimore. I'm speaking in support of the bill to help our patients with psychiatric diseases simply be treated just like everyone else. One of the most disabling symptoms in medicine is called anosognosia because it prevents a person from having awareness of their illness and seeking treatment. For example, in a condition called Anton syndrome, in which the brain is stroked at the back of it, a person goes totally blind, but they have to have total unawareness of their blindness. They insist that they can see even though they're literally walking into walls. This anosognosia condition is rare with blindness, but it exists in 100% of patients who will be helped by this bill. All patients who lose the ability to consent to treatment are protected by law, except for patients with psychiatric disease. So my wife can consent on my behalf for me to have brain surgery, but she cannot consent on my behalf for me to be given a medication for my brain disease just because we call it mental illness. This bill will help prevent such discrimination. Thank you.
Thank you, Doctor. Who would like to go next?
I can. Thank you. Good afternoon, Chair, Vice Chair, committee members. My name is Dr. Rishi Gautam. I'm a psychiatrist and currently head the Department of Psychiatry at LifeBridge Health. I would like to focus my testimony in support of the Senate Bill 453 and broadly focus on two things. One, following up on anosognosia, which is a neuropsychiatric condition debilitating enough to make the person not see the need for treatment. It is seen in people suffering from severe persistent mental illness. This does not apply to all mental health conditions, but rather a very small subset of people who do unfortunately tend to suffer from psychotic and mostly affective bipolar illnesses. This bill helps to save those lives because without it, what we see in hospitals are people suffering and drowning in a quagmire of homelessness, substance use, incarceration, frequent hospitalizations, and ED visits. Maryland truly supports population health, health equity, and ensures people remain in communities. And this is a bill that affords people with severe mental illness the same opportunity. So I support it, and thank you again.
Thank you. Who's next?
Hi. Good afternoon, Madam Chair and committee members. My name is Dr. Cynthia Major Lewis, and I am the Director of Adult Psychiatric Emergency Services at Johns Hopkins Hospital. And I am asking for your support for Senate Bill 453. We had to decrease our testimony, so I will want to just concise and say that I am here as well as my colleagues so we can advocate for those who are not able to advocate for themselves. I feel helpless as an emergency room psychiatrist who sees patients cycling in and out of homelessness, incarceration, involuntary emergency petitions that bring them in against their will to the emergency department, hospitalizations that work when they're in the hospital, but then fail them when they leave and they don't have a tool to catch them to try to keep people in compliance. You know, I'm really concerned that we have a lot of people advocating for people to be able to not receive treatment. And I think a lot of advocates are able to go to home at night, sleep in warm beds, whereas my patients are sleeping on the streets, eating out of trash cans, being brought into the hospital against their will, only to repeat this cycle. So I'm here to answer any questions, and I'm here to advocate for those my patients who I think can advocate for themselves.
Thank you. Peking, you're next.
Thank you, Madam Chair. Peggy Townsend, on behalf of the Maryland Hospital Association, in strong support of this bill. I just want to take a step back and describe how we got here. It was in the 60s and 70s when there was a whole deinstitutionalization movement, which was a good thing. And the promise was we will have the services in the community to take the place of the need for an inpatient stay. Well, society never kept that promise. And so what happened instead, we criminalized mental health issues. And folks ended up in jails or worse. So for those reasons, I think this bill will help us keep that commitment that was made so many decades ago.
Thank you. And next we have, and please forgive me, Dr. Jelena. Thank you.
Thank you. Good afternoon, Chair, Vice Chair, and committee members. My name is Yelena Gimmelstein, MD. I'm an inpatient psychiatrist at LifeBridge, and I am in strong support of Senate Bill 453. I think it will particularly help us with the care of severely mentally ill patients who do well with the structure and support within the hospital, but unfortunately decompensate in the community because they don't have the same levels of support. They stop taking their medications and they come in very decompensated. A lot of times their lives are in danger or they put other people's lives in danger. And I think this bill will help us break this cycle. So I'm in strong support.
Thank you, Doctor. Do I have any questions for this panel? I do have Senator Washington.
Thank you, Madam. Thank you, Madam Chair. Thank you for the bill, and the previous panel also thank you for the bill. I have a question about the data collection that's here. Who's responsible for it? I know it says something about the county shall report to a different agency. Can you all speak to that piece at all? The data collection piece? That'll be you. Okay, I see you in the back there. All right, I'll ask that. I'll ask that offline. Yeah. That's it, Madam Chair. Thank you.
And Vice Chair, Madam Vice Chair.
Yes, this question just for one of the psychiatrists because of time, but I had asked about the injectables, the long term. Do you see that happening here in the state of Maryland? I mean, is that a good fix?
I'm sure all of us can address the question because we deal with it on a daily basis. Long-acting injectables are an essential part of our armamentarium and make a substantial difference. Actually, one of my patients was planning to come with me today to testify. We just couldn't arrange the logistics. She had been hospitalized several times, and ultimately she decided to have the injectable and has not been in the hospital for the last 7 years. So this is a very important
Good. Well,
part of
that's
what
good
we
to
do.
know. We have that tool in the toolbox. Thank you.
Any other questions? Thank you to this panel. That ends the sponsor panels, and now we're going to start with other witnesses. Christina Neal, Lisa Daly, Evelyn Burton, Janet Edelman, and Morgan Mills. If you'll come to the table, please, and someone can begin as soon as you're ready. Please begin.
Sorry. Hello, and thank you for giving us this opportunity to address the Senate panel here. And my name is Lisa Daly. I'm the Executive Director for Treatment Advocacy Center. We're headquartered in Arlington, Virginia, but we work on issues related to AOT throughout the country. I am also here as a sibling of somebody who has benefited from AOT in another state where it has existed for many decades. And I basically, want to call attention to a couple of specific points, and then I'm happy to answer any questions that you might have. First of all, I just want to kind of point out that AOT is a tool that helps people receive care in a less restrictive setting, which is something that sometimes gets overlooked. A lot of times when you speak with opponents, what they're really unhappy about is inpatient care. And I always want to point out that if somebody is talking about AOT, you need to make sure that you understand that this is a powerful tool to get people back into their communities, back within their support systems with the appropriate level of care that they need to be able to survive safely within the community. And it's fully consistent with Supreme Court jurisprudence that directs states to find less restrictive places to give care. And I'll end there and then just be happy to answer any questions anyone may have.
Who'd like to go next?
I'll go next. Hi, I'm Christina Neal. Oh, okay. I'm Christina Neal. This is my son, Bertie. My 20-year-old son, Herbert Randall, has had 10 inpatient psychiatric hospitalizations and is now vulnerable and voiceless in a maximum security prison because Maryland does not offer assisted outpatient treatment. In March of 2022, I wrote a testimony hopeful that the bill for assisted outpatient treatment would be passed in order to mandate this treatment and try to save my son's life. Had it passed then, my son might have had a chance and not committed a crime only 4 months later that would change all of our lives forever. A few months after this bill was passed, he had just been released from his last inpatient hospitalization of the University of Maryland. When I was picking him up that bleak January day, he told me he was not planning on filling his prescription or following up with his psychiatrist. He had just turned 18 years old. I realized that I was powerless to help him without the laws of Maryland changing. My grandfather, U.S. Senator Claiborne Pell of Rhode Island, said, "You don't need to be the loudest voice in the room, but be a voice for those with no voice at all. Please be a voice for my son, Bertie. I implore you to vote for assisted outpatient treatment and save countless lives for my children's fate, for my child's fate." Thank you.
Who would like to go next?
Good afternoon. My name is Janet Edelman. I've been helping some people prepare their testimonies to submit here. 20 people gave personal testimony about adverse situations that might have been avoided by AOT. I'll just summarize, hit the highlight. 4 people have died. Out of 20 people that gave personal testimony, 4 people spoke about loved ones who died. AOT can be life-saving. I'd like to talk about the number of people who might be under AOT in Maryland. Looking at New York State statistics, they post daily statistics there. 3,352 people are under active court order in New York State. Based on 2020 census for Maryland and New York State, proportionately, we would have 1,025 people under a mature program, which wouldn't happen for many years. And that's under the current bill as it exists. I don't know what would happen, which is very similar to the New York qualifications. I don't know what would happen under the amended version. Thank you. Please don't amend it to take away, make it so people cannot get care. Thank you.
Thank you. Next.
Hello, my name is Evelyn Burton. I'm the Maryland Advocacy Chair for Schizophrenia and Psychosis Action Alliance. 12 psychiatric hospitalizations, 18 ER visits in 1 year. Total charges $509,000. That's what happened with my relative in Maryland. But the numbers don't tell the suffering, the trauma, the fear caused by the delusions and the homelessness. My loved one refused all the voluntary services Maryland had to offer. He wouldn't engage with the ACT team or take medicine or see a psychiatrist, and accused the peer that I hired to stay with him in his apartment of being a Nazi. Almost was arrested. I gave up on Maryland. I sent him to Arizona. They very quickly put him under an AOT program, and from the time the judge ordered it, he has taken medicine, sees his doctor, thinks his ACT team is his best friends, and is now looking for a job. And after 1 year, though, he did need a renewal because he wasn't quite stabilized. And thank God they allow renewals there. I don't think that the amendments will allow that. And I can answer Senator Ellis's question, if you allow me, about the contempt.
Not right now. We still have another person on the panel.
Oh, okay.
One more.
All right, thank you so much. My name is Morgan Mills. I'm here today on behalf of NAMI Maryland, and I'm very pleased to be offering support on Senate Bill 453. NAMI Maryland advocates on behalf of people living with mental illness and individuals with lived experience. You'll hear from some NAMI Maryland members today who have personal experiences, and from others who have experienced the tragedy of losing loved ones because as Marylanders, AOT was not an option. This is a practice that encourages partnership among the court, participants, providers, and the community to really foster an individual's participation in their treatment plan. This partnership increases treatment adherence because it commits local mental health systems to serve participants, just as it commits participants to adhere to their treatment plans. These folks have an inconsistent history of engaging in treatment, and this bill is to kind of step in and help that. AOT is an important part of the continuum of care that Maryland unfortunately lacks. It's an important tool in the toolbox that would allow us to serve our most vulnerable Marylanders, and for that, we urge a favorable report. Thank you.
Thank you. Now, do I have questions for this panel? Senator Reedy.
Thank you, Madam Chair. Just maybe for Evelyn. Evelyn, thank you for your advocacy. All of you, thank you for being here to talk about the experience that you have had and your relatives have had. You were talking about Arizona. So you sent him to Arizona, did the AOT program, they let him renew. Well, was that the best? Was that something that you think was the most important that he could renew? Or what do you think was what about their program that we're maybe not doing in this bill? Because I know you expressed some concern about some of the amendments. So, I mean, could you just?
Yeah, well, I think that there were just a couple major things. I mean, the key thing is obviously the judge's order, because until then, he wasn't listening to his guardian, he wasn't listening to his doctors, but he listened to that judge. So that's a key component, and it's called the black robe effect. And people just naturally, anyone, have a respect for a judge. And my concern is that, in the Maryland program, if they give them this opportunity to say, okay, I'll just voluntarily agree, then the question is what happens if they don't? And that needs to be really carefully considered. In Arizona, they didn't give him that option. It was up to the judge. My relative said to the judge, I don't think I need this order. I'll take the medicine and I'll see the doctor. But the judge was looking at his history of all these multiple hospitalizations where he didn't do that. And so the judge decided, no, I think we're going to help you out, and this order will help you do it. And he was right. So I think if it's left to the judge's discretion, it's a lot better. And then, of course, the other thing is what the treatment team does. And that's a very, important part of it, because he was assigned a treatment team, which he never accepted before, and they didn't give up on him. I mean, initially, he still, was cycling until they found the right medicine. But the treatment team is under the order, the same as the patient. And they can't, he walked away from some, but they followed him and they made sure that he got the treatment he needed. So that's a very important component, because when the ACT team in Maryland came out to see him and he slammed the door in their face and said, I don't need that. And I called the ACT team and said, well, you're going to go out and try again? They said, no, because he doesn't want the service and we could be liable for harassing him or something.
Okay.
Well, if they're under the court order, then they have the authority to do that.
Thank you.
So I think all of these components are key.
Thank you. Thank you, Madam Chair.
Mrs. Burton, while you're on the subject, and it's nice to see you again.
Thank you. Nice
So
to
when
see
your
you
son
too.
got to Arizona, what happened that got him into the court system, into AOT?
So initially I sent him to an intensive residential treatment program. He wasn't stable enough to be able to participate in that program. And so he ended up going into the hospital. Then he went back and tried again, but he still wasn't stable enough. Well, by the time he went in the hospital the third time, they said, you're just cycling in and out. We think that you would benefit from AOT. So the doctor in the hospital filled out the certification papers and then the court reviews it and he goes before the court and they assigned him a public defender and everything. And that's sort of how it happens. And that's how it happens in most states. Most of the people who go under AOT do it as a step down from the hospital. And that's where most of the certifications happen.
Thank you for sharing that.
Sure.
Senator Ellis.
Yeah, thank you, Madam Chair. And Mr. Burton, I'm happy that you're seeing positive results for your loved one. You wanted to answer directly. I want to make sure I hear from you.
Yeah, I mean, this is a very long and complicated bill, so I don't fault anyone. However, on page 15, section 106A09, it specifically says, failure to comply with an order of assisted outpatient treatment is not grounds for a finding of contempt of court. There is no path to jail through an AOT program. And in terms of what happens if they don't comply with the order, what typically happens is then the treatment team can ask the judge to convene another hearing, which the judge can do at any time. He brings them in. It's a very congenial kind of arrangement. The judge usually says, well, you're not complying with your treatment plan. Is there a problem with the plan? Do we need to change anything? What can we do to help you? And often they can just work out, a change in the treatment plan. Maybe he doesn't like that medication and maybe they need to tweak it some.
Yeah.
And even if the person continues not to comply, then all that happens is the treatment team keeps watching him.
Yeah, thank you, Ms. Burton.
And if they deteriorate, they can petition for hospitalization if they need it.
Should I suggest maybe you should be hired as a consultant by the health department?
I would be glad to.
Thank you.
Senator Guile.
Yeah, thank you, Madam Chair. For Ms. Daly, I know that there has been a lot of concerns raised about constitutional issues of AOT. And AOT is now, in 47 states. I wonder if you could tell us whether there's been any successful constitutional challenges to AOT throughout the country.
Yeah, that's pretty easy to answer. There has never been any court that has struck down AOT substantively as a program that is constitutional. Where you will see challenges are there adequate procedural due process protection? So is the process enough to make sure that the individuals who are being, reviewed for eligibility actually are able to confront witnesses, present their own testimony, et cetera. And occasionally, those challenges still occur, but there's never been any circumstance under which substantively AOT has been found to be unconstitutional. The most recent challenge was way back in the 90s. And for most states, AOT or, whatever they call it in that state, because it's, outpatient civil commitment, mandatory outpatient treatment, et cetera, has existed in many states for, decades and decades and decades. So it's not a new thing. It's just it's a thing that In it properly, people definitely do need to make sure that everybody's rights are protected. And I think that's absolutely appropriate. But as a matter of whether or not it is in a type of treatment that should exist, it's never been found to be unconstitutional on that basis.
Okay, thank you. Thank you, Madam Chair.
Thank you. I don't see any other questions for this panel. Thank you all very much. Next, we have two people that are favorable with amendments, Sarah Sample and Dan Rabbit. Sarah, would you like to start?
Yes, absolutely. Thank you to the chair. Thank you to the members of the committee for having me today. My name is Sarah Sample, and I'm here on behalf of the Maryland Association of Counties. And so we are here in support with amendment on this bill. And this is absolutely a program that the counties have a really great stake in making sure that this works and that this passes. One of the major reasons is because this is shown to help divert individuals away from our local detention centers, where they end up, unfortunately, as an incarcerated individual instead of a patient. So we think this would really help with that diversion. The other thing is, I know it's not a surprise to anybody on this committee, but the mental health transfer backlog that we have in the local detention centers is a really severe issue right now, and it's something that has been getting worse and escalating. So we do think that this could help with some of that. And as far as our amendments go, we just want to make sure that there's clarifications in terms of streamlining the process. And we would like to see that the circuit courts of each county are required to establish these programs. And I don't think that that would preclude any involvement from the local behavioral health authorities or the core service agencies. That was one thing. And the other thing was just making sure that there's funding streamlined for this, and not just for the counties, because we do fund the circuit courts, but also Office of the Public Defender, the judiciary, and all the elements that would really need to come together to make this work. Thank you.
Thank you, Sarah. And Dan.
Good afternoon, Madam Chair, members of the committee. I'm Dan Rabbit, Policy Director at Behavioral Health System Baltimore. BHSB is a local behavioral health authority and a nonprofit. We serve Baltimore City. We support this bill with amendment. We can see that AOT may have an important role to play for a very select few individuals. And so we see that it has a place in our system. The amendments that we offer try to target and narrow the eligibility for AOT beyond what is currently in the bill. Our amendments are in our written testimony, so I'll refer you to there. And we do appreciate that the Maryland Department of Health has offered some amendments that also narrow eligibility, but we would like to see it go a little further. We're concerned that over 1,000 people may be too many people for an AOT program in Maryland, and for the budgetary resources and the experience that the state has. And so we want to make sure that the people who really need it are getting in the program, and other people aren't getting stuck in this cycle who maybe could be served in a less restrictive environment.
Thank you, Dan. Do I have any questions for this panel? Thank you very much for your testimony. Next, I have 6 unfavorables. Hannah Dixon, Nicholas Rosenberg, Kelsey McLean, Courtney Bergen, Katie Rouse, and Jake Carlo. Will you please come to the table? You can start as soon as you're ready, as soon as you're settled. Okay. Thank you.
If it's all right, I'll start. Thank you so much, Madam Chair, Vice Chair, and committee members. I'm Katie Rouse with Honor and of Maryland, asking for an unfavorable report and truly appreciative of the amendments that restore very important protections in the bill. Our statewide peer network serves over 8,000 folks each year, many of whom could meet criteria for AOT. And for more than 3 decades, we've remained fundamentally opposed to involuntary treatment because we know that wellness happens through connection, not coercion. Our major concerns include still 2 broad criteria: the harm of forced treatment, disparities, disability rights, and unclear implementation expectations. Too often, our system deeply scars people in crisis, even when voluntarily seeking care. We all agree that we deserve better. We deserve ongoing wraparound support that is accessible, affordable, and works. But AOT is not the answer. It doesn't create beds in residential programs or expand supportive housing. It doesn't hire more clinicians or train them better. It doesn't make case management more effective or change what services are or aren't available in your area. And it certainly doesn't decrease stigma. But Maryland needs our 21st century services that understand complex trauma, social determinants of health, and equity-first approaches, proactive, voluntary, peer support, respite, inset, and self-directed care. We do deserve better, and we urge an unfavorable vote. Thank you.
Who would like to go next? Somebody go next.
Thank you, Chair, Vice Chair, and committee members for being here today. My name is Hannah Dixon. I am a social worker with bipolar disorder. I am here to express my opposition to Senate Bill 453. I am a person that received voluntary crisis care. Because of this, I was able to pursue my recovery at my own pace and my career in social work. I attribute all of my successes to being given the choice to pursue voluntary treatment. In 2019, I experienced a psychiatric crisis. I went to the hospital to be admitted inpatient, but I was told I did not meet the criteria to be admitted. The clinical director listened attentively to my story and referred me to a facility voluntarily. If I were admitted voluntarily, this would have exacerbated my depressive symptoms and risked my ability to graduate college, which I ultimately did 3 months after. Because I had choice in my treatment decision, I am in recovery, and I will soon be a fully licensed social worker. I urge you to think critically about the potential harm and trauma of expanding coercive forced interventions like AOT when there are voluntary recovery-oriented services available. I was granted choice and credibility with my treatment during a crisis. AOT will take this choice away from people like me and damage trust with their providers and the services they receive. Trust is integral to recovery, and AOT promotes neither trust nor recovery. I urge you to oppose this bill. Thank you for your time.
Thank you, Hannah. Nicholas Rosenberg.
Thank you, Chair, Vice Chair. My name is Nicholas Rosenberg. I am a Master of Social Work student. I'm here today asking for an unfavorable report on SB 453. As it fails to center individuals, it aims to help and leads to unintended harms. I've been working in the mental health field for nearly a decade. My approach has always been client-centered, which means prioritizing autonomy, choice, and empowerment. I have found that the most effective strategy was focusing on building rapport and establishing strong therapeutic bonds. I view using my power to limit choice as an extreme measure always a last resort. For example, physical restraints were only used in a limited scope, duration, and always as a response to imminent safety concerns. All right. The system is already strained far beyond capacity. There are already limited mental health resources and minimal infrastructure to assist those in dire need of treatment and support. AOT is a top-down solution that values the comfort of the public above the well-being of the individual in need of support. For these reasons, we strongly urge the committee to give an unfavorable report on SB 453.
Thank you. Kelsey?
Good afternoon. My name is Kelsey McLean, and I'm a Baltimore resident who experienced involuntary hospitalization. I urge you to oppose Senate Bill 453. I struggle with depression as well as non-suicidal self-injury, which in my case means I cut myself. My self-injurious behavior has never had suicidal intent behind it. In April 2023, I was involuntarily hospitalized because of self-harm after going to an emergency room to get stitches for a cut on my arm. I was experiencing no suicidal ideation, but a doctor wrote in my chart that I was having suicidal thoughts. A social worker later wrote that I was manipulative and that I showed no insight into my behavior. I lost income for the entire week I was hospitalized. An increase in my depression and anxiety symptoms made it difficult to work and negatively impacted my income for months. I also walked away with a $7,000 hospital bill. I still struggle to feel safe in healthcare settings, and it's unlikely I would go to an emergency room now, even if I needed help. Involuntary care can easily go wrong. There can be patients who do not receive the attention they need, stigma around certain diagnoses, and providers without training about mental illness. AOT programs would create an environment where subjecting somebody to forced care is easier and more common, and I ask you to oppose this bill.
Thank you. Courtney Bergen.
Good afternoon. My name is Courtney Bergen. I'm an attorney and Equal Justice Works Fellow at Disability Rights Maryland, but more importantly, I'm an individual who under this bill would be termed with having serious and persistent mental illness. And I respectfully urge you to oppose this bill because under the Americans with Disabilities Act, people like me, people with mental health disabilities, have the right to receive the accommodations necessary to make and communicate medical decisions. Court orders are not accommodations. It's enticing to believe that if we just complied with treatment, we'd be fine, but that's just not the reality. Research demonstrates that AOT is not effective and mental health medications only benefit about 30% of us, leaving the rest of us without other options under this framework. If Maryland had an AOT law when I moved here, I likely wouldn't even be alive today. Forced treatment nearly cost me my life. And sitting here in front of you all in 2019, It's because of you that I got the services I needed. I couldn't get them because I couldn't afford them. So I ask you, I'm not an anomaly, and I want you to know that the disability movement has a motto: nothing about us without us is for us. So I ask you to respectfully oppose this bill so that people like me can have choices in the care we receive.
Thank you. And Jake, you're our final witness.
Thank you. My name is Jake Carlo, and like Courtney, I'm somebody that would be defined as having a serious and persistent mental illness under this bill. I myself have been subjected to forced psychiatric treatment, and it was a significant setback on my own path of recovery. Unfortunately, my friends and family were under the same misapprehension that this bill would write into law, that those with a serious mental illness are often, and perhaps even generally, not capable of choosing what supports they need. I later secured records showing that my forced treatment was based on a misdiagnosis. Not only had my own psychiatrist, who I was working actively with, not been consulted, but doctors had chosen to ignore the information I conveyed directly to them concerning my diagnosis. In other words, the assumption that I lacked insight into my own mental state and was treatment non-compliant directly resulted in harmful care. The state of Maryland needs more supports for people like me, not fewer, but we need the right kind of support. So I urge you to vote against this bill, and thank you for your time.
Thank you. I have some questions. Senator Lamb.
Thank you, Madam Chair. This question's for Ms. Berman from Disability Rights Maryland. You know, I've been looking through this, and the orders that are part of this bill are potentially pretty far-reaching. Is there anything in this bill, for example, that would say that the court could not order, say, electroconvulsive therapy? So like shocking people?
As it is written currently, no. I mean, it would pose other issues certainly, but no.
So someone could have court-ordered shock therapy?
In theory, yes.
You know, I was looking and doing some research on this as well. Recently read a story, I guess this was an AOT court in Ohio, where a judge was pressuring a respondent about not having children. Is there anything in this bill that would prohibit a judge from ordering certain reproductive decisions if a treatment team and the judge thought it was important to the respondent's mental health?
No, and this has actually been an issue that has come up in Maryland recently. I had a case that touched on this with someone who had, trying to pick the right word right now, conditional release orders. But this also is, there's a Massachusetts case on this where even without AOT, a judge was able to order an abortion because they felt that the person taking their antipsychotics was more important than the reproductive choices. So I urge you to look at that decision. I'm happy to send it out if that would be useful.
So a court-ordered abortion?
Yes, so that the person could continue to take their antipsychotic medications.
Okay. The bill talks about how AOT records are supposed to be sealed. Do you think there's sufficient protections in place to ensure that this doesn't impact, for example, an individual's rights to professional licensure or other things like child custody fights?
No, I know that there have been things written in to say that there should be no collateral consequences and that the records will be sealed. However, I just went through the Maryland bar licensure process, and I can tell you that it explicitly said that even if records were sealed or confidential, that I needed to disclose them. So my prior commitment orders, I needed to disclose them. And I can't tell you that I've ever been through a more unpleasant or terrorizing process in my life, perhaps besides the civil commitment and orders and other orders I've been under for forced treatment. I was compared to someone who had committed homicide when I was interviewed for a character in fitness. So I really urge you to think about how the collateral consequences of this bill play out and impact people, even when you try to put protections in that doesn't necessarily prevent the questions from being asked.
Okay, thank you.
Thank you, Senator. And that finishes this panel. Thank you very much. Our next panel is three people that are bringing information, not a position, but information. Dan Martin, Lindsay Below, and Juliana Bokoski. Where do these names? Dan, will you begin as soon as you're settled? Information.
Well, Madam Chair, I will. Well, thank you very much, Madam Chair. Dan Martin with the Mental Health Association of Maryland, and I've been testifying on AOT bills for 18 years now, believe it or not. And this is the first time that I've ever been up here not in opposition. That's not to say I'm supportive of the bill, but I'm not opposed to the bill. Here, information only. So this is a debate that's raged for decades with well-meaning advocates and families and consumers on all sides, with no progress. And last year we had a kind of a breakthrough. At the end of the session last year over in the House, a lot of AOT opponents, legislators spent weeks and weeks and hours going through an AOT bill line by line, and got to a product at the end that was really, I think, as positive as we can get to come to. It was limited in scope to the sickest individuals, attentive to individual civil and legal rights, more patient-centered, with increased transparency and data collection to monitor program and individual outcomes. And the bill is introduced this year. Isn't that bill, but I'm really happy that we've been able to work with the Department of Health, the governor's office, folks over in the House to get to the sponsor amendments that really get us back to that posture. And so, again, the amendments are critical, and thanks for letting me speak.
Thank you, Madam Chair and members of the committee. My name is Juliana Falkowski. I'm an assistant public defender in the mental health division. We represent clients in involuntary admission cases throughout the state at private hospitals. We also represent clients in state hospitals who have been deemed not criminally responsible. It's important to distinguish that this is not mental health court. This is very different because there's no criminal charge in these cases, so jail is not on the table. We really appreciate the amendments that have been offered in the House to clarify that refusal to comply with an AOT order will not result in contempt of court, which would be unconstitutional, and to clarify that it can't be used in an emergency petition proceeding, so in an involuntary admission context. There will continue to be clients who refuse treatment for a variety of reasons. It's important to note that psychiatric medications can cause a variety of side effects, and they certainly impact people's lives in many, many ways. So we are asking to just be part of this conversation, and we're happy to answer questions going forward. Thank you.
Thank you.
Hi, my name is Lindsay Baylog. I'm a social worker with the Office of the Public Defender. And I just have a few things I'd like to address in regard to eligibility and data collection. First, this bill needs to explicitly exclude substance use disorder as a primary diagnosis. AOT does not address substance use disorder diagnoses. It's not designed to, and I understand that substance use can be a part of treatment, and it should be, but it cannot be, this bill will not be helpful to those where it's a primary diagnosis. I'm also concerned that this bill does not enumerate the kinds of treatment services that individuals in AOT should all be entitled to. Right now, it just entitles an individual in AOT to a psychiatrist, which to me sounds like a bill that's advocating for forced medication. And I do not think that that's going to be the most helpful way. As you've heard from others, we really need wraparound services that are far more extensive than that everyone in this receiving this is entitled to. Last, I want to talk about data collection. My understanding is that we've already expanded some of the data that would be collected, but we also need to include diagnostic information and information about the cost of the infrastructure in terms of utilizing the AOT process, whether it's legal or behavioral services. The evidence about AOT success and efficacy is murky at best. If we're going to spend $3 million on this, then we better be making sure it works, and we better be making sure we know who it's helping and how. Thank you.
Lindsay, thank you. We have a question from Senator Lamb.
Thank you. This is directed to the representatives from the Office of Public Defender. OPD obviously represents people who have serious illnesses, mental illnesses every single day. Are some of those clients ordered by judges to engage in treatment, and do the clients still struggle when they engage in these services, even when they're ordered by a judge?
Yeah, so I can speak to that, Senator. Thank you. So we're talking about two different contexts. So certainly our clients struggle to adhere to treatment in the context of an inpatient setting, even so in the most restrictive environment, and even outpatient on conditional release, conditions can be onerous and difficult to adhere to. It requires flexibility with their treatment team. It requires communication. And for our most needy clients, it requires, constant communication about how the treatment can adapt to their needs. So that's why we're really in favor of more self-directed models of care, more client-centered approaches. Thank Thank you.
Okay. And obviously, folks from the public defender's office are in courts every single day. I know the advocates have brought up the fact that in other states, the black robe effect, where having a judge present has a real impact on a mentally ill client's level of engagement in these services. What's your experience been with this, and have you seen any evidence of the black robe effect?
Well, just to be clear, the black robe effect is this idea that because there's a judge who has authority, who's sitting in a court of law, telling someone what they need to be doing, that therefore that person must comply with it. They have no choice but to comply with this order. So that's the idea of what the black robe effect is. Now, whether it's effective or not, whether it works, depends on how an individual views authority figures and whether or not they are amenable to being forced into treatment. So it's not something that is uniformly effective. And really with AOT, there are no consequences to not complying with an AOT order. And if there were, that would render AOT as a bill unconstitutional. So there's quite a bit of research that has examined, like just around the country, whether or not the black robe effect is the actual reason for improved outcomes in areas that have implemented AOT. And what we find is that areas that have increased accessibility to services along with their AOT programming, have invested heavily in wraparound services that don't just include a psychiatrist, but also include access to social workers, therapists, substance use counseling, peer supports, vocational educational services. Those are the areas where we see improved outcomes. Those are the communities that are experiencing, reductions in hospitalizations and reductions in incarceration. So the evidence doesn't suggest actually that the black robe effect alone really has any impact on outcomes. Okay. Does that answer your question? Yes. Last question for you. So some of the proponents have said that these orders aren't enforceably effective, that they're not effectively enforceable. If one of your clients received an AOT order from a judge, for example, and potentially a treatment regimen that might include a medication, do you think that the client would believe that there was force behind that order, and that if they didn't take that medication, that there would be significant consequences for them?
So we have an ethical obligation to explain to our clients the consequences of not complying with an order. And the consequences in an AOT case, as this bill is written, are not contempt. There's no way that the court can enforce its order, but the consequence could be, and there always is a consequence, that for a client who's living in the community, they could be subject to an emergency petition at any time. So that doesn't go away. That is always an option for petitioners who are looking to get help for a client, for one of our clients, but it is really just a matter of the client is going to have to make the decision of whether or not they want to risk that, whether they want to continue to try to live in the community and be subject to an emergency petition at any time and not comply with an order or not.
Because the bill says that there is no contempt of court that's permissible if they do not comply.
That's correct, Senator, but there still is the coercive effect of an emergency petition.
Right. Okay. Thank you.
Senator, and I think the last question is from Senator Ellis.
Yeah. Thank you, Madam Chair. Real quick question, ladies. Since you're in the Public Defender's Office and you're here, but excellent testimony. Do you think if this bill passes, you'll have more clients to represent?
Yes, Senator. We do expect that our mental health division will have significantly more clients, and these cases are very complex. I believe our deputy public defender is signed up to testify on this bill, so I would like to leave that question for him, if that's okay.
Okay, thank you.
Thank you.
Thank you, Madam Chair.
Thank you, Senator. So that ends this panel. Thank you all for your testimony.
Thank
Next,
you.
we're going to go virtually, Laura Pugliano.
Hi there. My name is Laura Pugliano. I was the caregiver of my son who was desperately ill with schizophrenia for 7 years. I had to emergency petition him a few times, and he passed away, unfortunately, but now I work with families who are in these tough situations. I've run a support group for 7 years. I have about 120 families in it. And when your child is too sick to know that he's even sick, you have to have some way to bring him to care and keep him in care. It can take months to regain competency after decompensation, and parents have no recourse. You can talk about coercion, or you can talk about saving his life. When you compare the costs of going to court a few times and medication versus jail, incarceration, death, all you have to do to see that some people are too sick to ask for help by themselves is go into any major city and look at the people in the gutters.
Laura,
I know
thank
for a
you.
fact- Okay, thank you.
Laura, thank you. And thank you for your work with the families.
Thank you. I appreciate it.
Saba Mohammed.
Thank you, Madam Chair, for the opportunity to testify in support of SB 453. I serve as Senior Legislative and Policy Counsel for the Treatment Advocacy Center. I'm a former public defender, and I am a family member to a loved one whose entire mental health experience has been carceral. I've written extensively on the use of AOT to break racial barriers to treatment. Overrepresentation of BIPOC individuals in AOT reflects American systemic racism, not inherent racism in AOT. Those disparities must be addressed, but they are not an excuse for failing to make AOT available. We must take every single opportunity we can to prevent people with mental illness from being pushed into our criminal system. As a former public defender, I represented clients who lacked the competency to participate in their own defense and in their own wellness. They were not criminals. They were trapped in a cycle of incarceration. They needed treatment. AOT helps to break that cycle. I'm asking you to vote favorably for SB 453.
Thank you for your testimony. Next, we have John Cooper.
Hello, I am a member of NAMI Montgomery County and also representing NAMI Maryland. I am a parent of an adult child who has had symptoms in the range of bipolar to schizophrenia for many years. That child is doing much better now thanks to things like NAMI. But in terms of having a quicker effect, it would have been helpful to have something like AOT for the outpatient phase of care. So indeed, the black robe effect, which I think my child would respond to, could have some impact on their decision about compliance versus non-compliance, which we had for many years until relatively recently. So I do support AOT. Thank you.
Thank you for your testimony. And the last favorable is Maria Donnelly.
Hi, my name is Maria Donnelly. I am a parent of a 24-year-old son with severe mental illness. If he had assisted treatment, he would not be in hospital jail, which is where he is right now. He was never in any kind of trouble. He went to hospitals telling them he was hospitalized several times. But on the last time he told them he had schizophrenic thoughts, psychotic thoughts, and homicidal thoughts. They continued to let him go on the street. I know he would have taken the help, but he went into a schizophrenic cycle so bad that he was arrested. Now he's in the hospital. He gained his competency back 6 months later. We are all broken. This poor boy is in the hospital alone without his family. The community was shaken and terrified. But had he been made and helped to get treatment, he wouldn't be in this situation. He desperately needed someone to get him the help that he needed because he didn't know enough to get it himself. He was so out of his mind. So I ask you to consider this so that you'll save other people's lives like his and our family. We're so broken over it. So thank you for your consideration. And I encourage you all that this is not taking away his rights. This is helping him live with a severe mental illness and live with his family again, which I hope that he'll be able to do one day.
Thank you, Maria.
Thank you.
Next we have three more virtuals unfavorable. Melinda Morgan. There she is. There we go. Hi, Melinda.
Hi, thank you, committee. My name is Mindy Morgan, here to oppose Senate Bill 453. I'm a mother, clinical social worker, and administrator with over 20 years in the field of mental health. I'm 44 and was diagnosed bipolar at 21, hospitalized 3 times. All 3 of my kids struggle with mental health diagnoses. And in my last hospital stay, I was held against my will when I was not at risk. As a result of this forced treatment, I just did what it took to get out, and now I fear hospitals. As a result, I will no longer access any hospital for mental health care, and this may one day put my life at risk. The people I trusted helped me get into right care. People don't change with force, they change with trust. Our systems are broken. Evidence-based practices are on lengthy waits because of underfunding and availability issues despite their success rates. AOT is not evidence-based. We need to increase availability of voluntary evidence-based practices. In other states, many AOT positions are dismissed. Large numbers of people are pulled into court to defend themselves against these petitions. This is a waste of resources, an unnecessary traumatization of so many. So please, let's stop focusing on those with mental health issues. We aren't the problem. Let's instead fund effective programs that are not accessible, like ACT teams, RAP, first episode psychosis, respite. Please use our tax dollars wisely on what we know works. Thank you for your time.
Thank you. And Lauren Tenney.
Hello, thank you for my testimony today. I'm asking you to put out an unfavorable report on this legislation, including any of the amendments that may have been discussed in the bill today. Involuntary outpatient commitment in relation to race, ethnicity, class, gender, sexuality, disability, age, and veteran status presents great ethical concerns for the protection of life, liberty, and the pursuit of happiness. There ought to be a total moratorium on any type of involuntary outpatient commitment laws until the current data that is not available as reported to the Center for Mental Health Services is explored. There are clear human rights concerns. The deceptive psychiatry narrative is consistently not addressed. There is not any shred of biological evidence for any psychiatric diagnosis, and yet tremendous biological evidence for the damage that psychiatric treatment does. The racial disparities, thank you for bringing up Antonia Hilton's book Madness today. These are real things. The underlying point is that involuntary outpatient commitment laws cannot exist without human rights violations, and the ways in which they are carried out is not in the Schwartz report that was referenced before that said that people of African descent are more likely to be in services. What they also specifically said was whether you saw this as programs that assisted people or further oppressed groups that were already experiencing oppression was determined on the way that you see psychiatry. And psychiatric treatment—
Lauren, please finish.
Thank you.
Please finish.
Psychological treatment has no biological evidence. I ask you to put in an unfavorable report on any involuntary outpatient commitment laws.
Kimberly Brenninkmeyer.
Hi, my name is Kimberly Brennickmeyer. I'm a psychologist practicing in Baltimore. I have over 20 years of experience treating the very individuals AOT is targeting. I strongly oppose Senate Bill 453 as it will put many of my clients at risk of being subjected to forced treatment. I want to use this time to share the reality of what forced treatment does to individuals. In my professional experience, involuntary treatment causes far more harm than any potential benefit, and in fact, it has caused the most harm to my clients in contrast to any other life experience or trauma reported. Forcing people out of their lives and into treatment without consent completely derails their lives in ways that are not recoverable. Clients often get stuck in involuntary treatment due to valid concerns being labeled as anosognosia and noncompliance. My clients have lost opportunities to have families of their own, to pursue job opportunities, to have financial independence, and to establish stable housing. And this is due to the psychological harm and the logistical harm that forced treatment has caused. Instead of forced treatment, we need to create sustainable engagement in mental health treatment. The relationship has to be built on trust, compassion, understanding, mutual respect, especially of every individual's right to personal agency and autonomy. I strongly urge this committee to issue an unfavorable report on Senate Bill 453. Thank you.
Thank you, Kimberly. And that ends the hearing on Senate Bill 453. Thank you all for your testimony. Next we have, I see Senator Hester's here, and we're going to hear Senate Bill 739. Senator, do you have a panel?
I have 2 people.
You have two people. Senator, who are your people?
So we should have Hannah Abrams from the AG's office. And then Christine McComas should be online.
Okay, Hannah is favorable with amendment, but if you want her as part of your panel, that's fine.
Yeah.
Okay,
It's a friendly amendment.
okay, thank you.
Thank you, Chair Vital, Vice Chair Klausmeyer, and members of the Finance Committee for your consideration of Senate Bill 739. This will establish the Algorithmic Addiction Fund, a special non-lapsing fund to research, prevent, and intervene and treat addictions that have been manufactured by social media companies. This is partially a response to the current lawsuit against Meta, in which Maryland and dozens of other states argue that the company has violated the Federal Children's Online Privacy Protection Act. Maryland attorneys allege that Meta has repeatedly misled the public about the dangers of social media platforms, concealing the ways in which the platform exploits and manipulates children and teenagers, enabling the mental health crisis among our youth. This committee knows these issues all too well, having heard the Data Privacy Act and the Maryland Kids Code. So I will be brief. In 2023, the U.S. Surgeon General released an advisory regarding social media and youth mental health. And there are three major points that you've probably already heard. First, there's an exceptionally high use of social media among minors. Second, social media used by minors has been linked to poor mental health. And third, social media used by minors has been linked to addiction. The Surgeon General's report urged researchers and policymakers to address this impact of social media among our youth. So how does this bill help? It does two things. First, it establishes the Algorithmic Addiction Fund as a special non-lapsing fund held by the state treasurer and administered by the Department of Health. It will include the civil penalties received from the state in future judgment against or settlement with technology companies, social media conglomerates, or social media companies. The fund can also be used to receive money from other sources. As the Meta settlement may take a few years, we cannot wait to take action. And this broad fund will also allow the state to apply for grants, such as ones offered by the Substance Abuse and Mental Health Services Administration, or receive other fees. For example, if the committee was to pass an iGaming platform, there might be fees from that which would go into this fund. Second, it requires the Secretary of Health to establish goals, objectives, and indicators aimed at meeting the Surgeon General's call to action. This includes conducting a needs assessment to determine where resources are needed most across the state of Maryland. And second, improving and strengthening access to services proven to treat the mental and physical health impacts associated specifically with algorithmic addiction. This bill is not unlike other restitution funds created in the past. It's modeled after the Opioid Restitution Fund, created and funded by the state's legal settlements with prescription opioid manufacturers and distributors. And also it's similar to the Cigarette Restitution Fund. The Algorithmic Addiction Fund outlined in Senate Bill 739 takes a crucial step towards enhancing the well-being of Marylanders, specifically our youth. It's critical that we take proactive measures to ensure we are addressing and combating one of the most prominent public health threats of our time. And this is something that I'm very proud that the committee is already digging into in several other priority bills. But I do encourage a favorable report on this bill as well. Thank you so much.
Thank you, Senator. So who would you like next?
Hannah, please.
Hannah, please.
Madam Chair, Madam Vice Chair, committee members, my name is Hannah Abrams, and I'm here on behalf of the Consumer Protection Division of the Office of the Attorney General. Thank you for letting me speak today. As we have heard, social media companies use algorithms to maximize the amount of time we spend on their platforms. Higher engagement means a higher number of impressions on advertisements. So by keeping us addicted, social media platforms make more money. Research has shown that this increased use leads to higher levels of anxiety and depression, particularly in young users. Popular social media platforms also disseminate videos and messages relating to body image and diet that impact body image and disordered eating, with young women particularly at risk. Senate Bill 739 establishes the Algorithmic Addiction Fund to address these harms. It directs monies collected from cases involving the misuse of algorithms into a fund that would support the treatment and prevention of algorithmic addiction and other mental health harms. The division submitted a friendly amendment that would narrow the source of the funds to only penalties collected. Restitution is often a component of settlements and judgments, and the division wanted to ensure that funds collected for the purpose of restitution go directly to impacted consumers. In addition, the amendment ties the source of the money more closely to the harm the fund is intended to remedy, specifically mental health harms resulting from harmful algorithms. As drafted, Senate Bill 739 would have swept in any money collected from any judgment involving a technology or social media company. The amendment narrows the settlements to cases involving the misuse of algorithms that result in mental health consequences, particularly in children. We ask the committee to issue a favorable report for Senate Bill 739 with the amendments offered. Thank you.
Thank you, Hannah. And we have Christine McComas on this panel.
Good afternoon. My name is Christine McComas. My daughter, Grace McComas, was a joyful child from birth and was a well-adjusted and well-loved teen. It's been 12 years since we lost Grace related to cyberbullying, and I've been actively involved in educating and advocating for child internet protections ever since then. When Grace died, smartphones and social media were new, and there was no understanding of how damaging their misuse could be. In 2013, Maryland's Grace's Law was made, yet none of us were aware of how entrenched social media would become in the lives of our children. By 2019, when Grace's Law 2.0 was passed, we'd learned about the dangers of the criminal misuse of social media, but it wasn't until 2021 when Facebook whistleblower Frances Haugen came forward, and we learned that platforms are intentionally designed to addict users. Late last year, Arturo Bejar, a long-term Facebook and Instagram engineer and safety specialist, appeared before Congress to share that he had warned Meta management of unwanted sexual advances, sexual harassment, and misogyny that were happening to children on the platform, which could easily be remedied, but they chose to take no action. On the very same day that Senator Katie Hester introduced this bill, I was on Capitol Hill with Arturo Bejar and other bereaved parents sitting just behind Mark Zuckerberg from Meta and the CEOs of TikTok, Twitter, Snapchat, and Discord as the Senate Judiciary Committee called them to account for the harms to children that their warped business models have wrought. I'm heartened to learn of this plan to establish this fund, but I think it's important to note, however, that purposeful online addiction is just one problem posed by big tech's greed and algorithms. There are many grievous harms to children that stem from how they keep them online longer. Too many to list during my 2 minutes, but all are stomach turning and have taken the lives of multitudes of children. For this reason, I'd like to suggest that the title of the fund be changed to better reflect the harms, something like Algorithmic Protection Fund, to prevent, mitigate, and educate about online harms to children. Thank you.
Thank you, Christine. I know that you've been relentless in your work and we appreciate it. Thank you. Do I have any questions? I do have Senator Reedy. Any other questions? Senator Reedy, go ahead.
Thank you, Madam Chair, and thank you for the bill. And I just had a question for Hannah. I'm going to look at the amendments, and it makes sense, obviously, to tailor it more narrowly. You talked about this having to have something to do with algorithmic addiction to youth would be for the purpose of this fund. For youth, for mental health that affect mental health. Is that how it would narrow the bill?
The amendments that we introduced were to narrow it to civil penalties, not just any revenue, and also to narrow it to the improper use of algorithms, not just any funds from technology or social media companies.
Okay, but you said something about, and maybe I misunderstood you, but you said something about algorithms that affect mental health.
I think that's what we've seen as the primary.
That's primarily what the lawsuits are about, correct? Yeah. Nationwide. Okay, because I was wondering, we also have seen social media companies that are using the algorithm in a lot of other ways to influence people's viewing habits, behavior, and there's concerns about it, because there's also the argument of, well, it's a service of figuring that out. But this would be pretty narrowly tailored to mental health, to the lawsuits surrounding targeting people for their.
The amendment doesn't specifically address that, but that's obviously up to Senator Hester and the committee.
I'll look at it a little more closely, but I mean, overall,
we would support that.
We want to be in position, obviously, to capture funds that come from these kind of lawsuits. Thank you very much.
Direct it from the harm to the remedy.
Right. Thank you very much.
I don't see any other questions for this panel. Thank you, Senator Hester.
Thank you so much.
We have one more favorable, Rita Montoya. Rita, are you here?
Yes, thank you. Senator.
Good afternoon. My name is Rita Montoya, and I urge you to issue a favorable report on SB 739. I am the mother of 2 children, ages 8 and 9. Children need education to promote digital and media literacy and prevent algorithmic addiction. While parents and guardians are a child's first teachers and we have a responsibility to educate our children, many of us did not grow up with social media and the internet, and we cannot teach them what we do not know. As a parent, I often borrow language used by my children's educators to maintain consistency for my children and to educate myself. Like active shooter, fire, and earthquake education, teachers are primed for and well-versed in explaining scary situations to children in age-appropriate ways, provided they have the resources and funding to do so. And I would like to emphasize that point. Children must understand the lack of autonomy taking place when they use social media platforms so they can make informed choices while they are using them. Recently, a simple 30-second conversation with my child about Rock Band summer camp, where my phone was not open to any social media platform, but simply sitting on the armrest of my chair, inactive, resulted in at least 3 different advertisements for Rock Band summer camp when I opened a social media application an hour later. Since signing him up, I have been flooded with advertisements for other music options from camp to lessons. In her book, Unwired, Gaia Bernstein provides a variety of examples of users unknowingly losing their autonomy, including how YouTube, a popular video streaming platform, removes a viewer's stopping signal by playing additional videos automatically after the viewer's selected video ends. As Bernstein points out, these manipulative designs do not allow the viewer an opportunity to reflect and decide whether they want to continue. While education about these techniques is not sufficient, it is a necessary first step. Children deserve the opportunity to learn the tools they need to maintain their power to choose their response, and SB 739 provides exactly that. Thank you.
Thank you, Rita. Do I have any questions for this witness? Thank you very much.
Thank you.
Next, we have 2 people that are favorable with amendments, Bill Kress and Brett Linginger. Maybe not, maybe just Brett. You only get 2 minutes, Brett, you don't get 4.
That's fair. It'll be quick. Thank you, Madam Chair and Madam Vice Chair, members of the committee. Brett Leininger here testifying on behalf of eBay in support of the bill with a clarifying amendment to define what the term social media is. It's referenced on page 2, line 30. We are an e-commerce platform and just don't want to be unintentionally swept up into the bill. There is some language that we can share from the state of Utah that clearly defines what social media is and includes a specific reference to e-commerce platform.
Please share that with us.
Will do.
Do we have any questions? Thank you very much.
Thank you.
That ends the hearing on Senate Bill 739. Next, we have Senate Bill 167. Senator Croza is here. Who would you like to bring up as your panel, Senator Croza? Robin Elliott.
Oh, I think.
Tell me who else is with you, please.
We have one more. And there's one more down here.
Hi, I know Dr. Jennifer Grover is with you. Who else?
And we'll go in order. So after I present, Robin will go, and then would you just go down the line?
Yeah, that's good. Okay. Thank you.
For the record, Senator Mary Beth Carrozza, representing District 38, Maryland's Coast. And I want to thank you, Chair Vidal and Vice Chair Klausmeyer, and the very distinguished members of the Senate Finance Committee for this opportunity to present Senate Bill 167, the Physician Assistant Modernization Act of 2024, and to respectfully ask for your support of this bill, which would modernize the law regarding the working relationship between physicians and physicians' assistants to better reflect current practice and to improve access to quality health care. For the past 3 years, I have been working with physicians' assistants and physicians from across the state on passage of legislation that would provide improved access to quality care to Marylanders, especially in the context of the existing healthcare shortage, and particularly in rural areas like my own district, which includes Worcester County, which goes from the Delaware line to the Virginia line, more than half of Wycomico County, with the largest number of agriculture sales in the state, and all of Somerset County, including Smith Island, where you need a boat to serve the residents. As way of background, the first year I introduced the bill in 2022, many of the major issues for the updated collaborative agreement between the physicians and physicians' assistants had not been worked out. I withdrew the bill that year, but with the understanding that the PAs and the doctors would work through the issues so it would be ready to go for introduction and passage in 2023. Last session, again with Chair Ken Kerr as the House lead sponsor, we made significant progress on the key issues, but we simply ran out of time. This session, we picked up where we left off. Negotiations and meetings were held during the interim. I pre-filed Senate Bill 167 as negotiated at the end of 2023 and kept the chair apprised of the progress we made before the bill introduction and of our continued ongoing progress leading up to today's hearing. We understand that MedChi and a couple of other key provider groups are supporting SB 167 with amendments, and we are also working through the fiscal note with the Maryland Department of Health, as officials there have already acknowledged that their assumptions are faulty. Physician workforce shortages challenge the long-term viability of a strong medical network and the ability to achieve the goals of improving the quality of care, improving health of populations, and reducing per capita healthcare costs. I know this committee is well aware that the United States is facing a projected workforce shortage between 37,800 and 124,000 physicians. For Maryland, Maryland is 16% below the national average for the number of physicians available for clinical practice. And that will only increase as far as the level of care to our constituents. Maryland hospitals are already struggling to maintain adequate coverage in the emergency room and to support many of the medical specialties, especially in Southern Maryland, Western Maryland, and the Eastern Shore. And as way of background to my colleagues, this workforce shortage is similar to the workforce shortage that actually created the physician assistant profession in the 60s, when the first class of physician's assistants graduated from Duke University Medical Center in 1967. It can take up to a decade to properly educate and train a physician, whereas most graduate level physician assistant programs are completed within 3 years. We need to take action now to ensure our caregivers can meet our needs. Medicine is now a team sport, and we need to build and train strong supportive structures that better utilize our physician assistants. The Physician Assistant Modernization Act would enable physician assistants to work collaboratively with the medical team and make contributions that they are currently restricted from doing. SB 167 would change the delegation agreement to a collaborative agreement, which is consistent with the education and expanded roles of the physician's assistants that have taken on due to the limited staffing and the COVID-19 pandemic. While scope of practice has been expanded, there are guardrails in place: education, requirements, licensing, collaboration, and identified out-of-scope practices. Madam Chair and Vice Chair and members, in the course of working on this legislation for the past 3 years, the need for the legislation for access to quality health care has only increased, especially in rural areas. When I talk to practicing physician assistants and future physician assistants in my district, they have trained and are training to be a crucial part of Maryland's healthcare solution when it comes to increasing access and quality care. And as you know, in some areas, many patients rely on PAs as their primary healthcare providers. with Senate Bill 167, we can enhance the healthcare delivery system and ensure that patients receive the quality care they need across the entire state of Maryland. I thank you for your kind attention, allowing me to share the background of the bill, and I respectfully request a favorable report on SB 167. Thank you, Madam Chair. And if my panel could go before questions.
Well, can I just ask, you know, I've really paid a lot of attention to this bill. So how, do you think there's still outstanding issues? I see like 8 people forward with amendments. Do you still have outstanding issues?
We are close. The fact that they have come in favorable with amendments is we believe a remarkable point to be. And are there a couple more that we need to work through? There may be. I'll defer to Miss Elliott, but we are I am excited about being here and the fact that we have worked so hard to have favorable reports with amendments.
I know that you have, Senator. We'll finish the rest of the panel. Thank you.
Thank you, Madam Chair.
Chair Beidle, members of the Senate Finance Committee, Robin Elliott representing the Maryland Academy of Physician Assistants. What this bill does is essentially try to realign the way physician assistant practice is regulated. As Maryland's system stands now, and it's very unique, there is nothing quite like it in the rest of the country. It has pushed PAs primarily into hospital-based and ambulatory surgery center practices. But PAs, it's the profession, as Senator Carrozza mentioned, their roots are in primary care and community-based care. The main challenge is that there is sort of a double layer of review for anything considered an advanced duty. And that means that FQHCs, local health departments, small primary care practices sometimes have to wait 2 to 3 months before a PA is cleared to fully practice. And because of that, then there is another delay in getting recognized by insurance panels. And you all hear a lot about that issue on other bills. So this bill cleans that up. And we are very close. And I want to thank all the colleagues who are going to come behind us with amendments. We have been talking very frequently. I think that we are very close to working out all of those issues so that we can come to you with what I expect will be pretty close to consensus amendments. There may be a few things that you all may need to make policy decisions on, but we want to minimize those and make your job easier. And I think everyone else feels the same way. So thank you so much for working on this bill. I know many of you, this is your 3rd year, and really appreciate your support.
Thank you, Robin. Who's next?
Okay. Good afternoon, Madam Chair and the committee. My name is Nicole Wooten, and I am the interim department chair and program director for the University of Maryland Eastern Shore's Physician Assistant Program. The mission of the program is to produce future healthcare providers to work in diverse, underserved rural communities like the Eastern Shore. In addition to being an underserved rural community, the Eastern Shore is considered to be a health personnel shortage area. 75% of our students are from diverse backgrounds, and 50% of our students are from the local area on the Eastern Shore as well as Maryland. Unfortunately, currently there are administrative barriers that are in place, such as needing delegation agreements as well as supervising physicians that are preventing our graduates from being hired on the Eastern Shore and being utilized to their full potential as in other areas such as Virginia and Delaware, which further exacerbates the health shortages in the medical profession. And it is critical that legislators support our efforts to remove these barriers to aid in closing the gaps and in aiding in access and equality to care. Thank you.
Thank you. Dr. Grover, are you next? Thank you.
Thank you. Thank you, Madam Chair, Vice Chair, and distinguished senators on this committee. As Senator Carrozza said, this is our third attempt, and we have really worked out a lot of our issues so far. So I'm currently the legislative director for the Maryland Academy of PAs. I'm a previous president, and I am faculty member teaching in a PA program. So currently, there's 16% of PAs that are practicing in primary care. And as Senator Carrozza pointed out, that PAs are being relegated to hospital and large health systems due to the administrative burdens that are placed on small community health centers. And additionally, federally qualified healthcare centers, although they prefer the PA model of education, are limited in how they can actually hire PAs to work in these facilities. So as Ms. Wooten pointed out, these restrictive practices are forcing our graduates to go to other states when we have a healthcare shortage here in the state. As you know, ED wait times were the worst in the country. This is plagued because of the lack of access to primary care. And although there have been significant efforts by this committee and others to increase access through loan repayment options, through access to healthcare, without removing the administrative burdens, we are severely limited in the amount of PAs that can practice in these facilities. So although these policies they won't go as far unless we can pass this legislation and make it happen. And this is the year to do that. Thank you.
Thank you. Who would like to go next?
Madam Chair and members of the Finance Committee, my name is Sherry Hendricks, and I'm a physician assistant here today to support Senate Bill 167. As the Assistant Dean and Program Director of a PA program in Maryland's largest public university, I was thrilled when the state provided extra funding for my program to produce more PAs, with the desire to keep them in Maryland upon graduation as the state faces its tremendous healthcare provider shortage. With the generosity of the state, I have grown our program an additional 50%, that's 50%, to accept 60 students annually rather than 40. The problem is, once my students graduate, it takes months and months, up to 6 months, of dealing with frustrating red tape to attain a license to practice as a PA in Maryland because of the current law. We PAs feel hamstrung. Many of my graduates who desire to practice medicine here quickly get their licenses in neighboring states and in the District of Columbia, where this problem does not exist. I know how this law also adversely affects the Board of Physicians. I was the secretary of the PAC, the Physician Assistant Advisory Committee, for 3 years. I knew when I served back in 2010 that the Maryland law that affects how PAs practice medicine is full of roadblocks and hoops to constantly jump through just to attain licensure and to practice medicine. It was stifling then, and it stifles today. Graduates with student loan debt need to earn an income right away. Many of my graduates have jobs lined up well before graduation, only to be caught up in the state's current law and play the waiting game. The impact on my program, on my students, on my graduates, as me as a PA, but especially on the citizens of Maryland who seek our care is tremendous. I know you can help. Thank you.
Thank you. And you must be Vince Lewis. Yes. Thank you.
Madam Chair and members of the Finance Committee, my name is Vincent Lewis, and I'm here to support Senate Bill 167. I'm a physician assistant in Salisbury, Maryland. I've been a PA for the last 16 years, and I was born and raised on the Eastern Shore, District 37. In 2017, I decided to try to do something a little bit different. I wanted to open up my own practice. So I reached out to a high school friend that I grew up with. His dad was a physician, and he still is in primary care in Salisbury. I was already working primary care, and I had seen some people leave my practice to try to do their own thing, and they weren't treated real well. They were nurse practitioners, but I reached out to this friend and I asked him, I said, man, I really got an idea and I want to know if you'll help me. This was the same doctor that wrote my reference letter to get into PA school. He was the medical director of the PA school at UMES where I attended. And he said, you know what, Vince, whatever you need, I got you. So through a lot of lawyers and accountants and the Board of Physicians, I opened up a practice, Lewis Primary Care. And we have over 2,000 patients. And my biggest worry and why I'm here is because my supervising physician is almost 70 years old. And he has 3 PAs at his practice. His partner died of a heart attack in 2019 in an airplane. He supervises 4 of us. If something happens to him, where are our 8,000 to 10,000 patients going to go? We have very, very few resources. This law is going to open access to the patients on the Eastern Shore. It's going to prevent a crisis, and you guys and girls are the people here that can do that. I promise you it can be prevented, and this will help.
Thank you. There's one more favorable. Is Jennifer Witten in the room? Jennifer, you want to come up and let's let you testify, and then we can have questions for all the favorable. You can come to the podium. Doesn't matter.
That's fine.
Yeah.
And I'll be really short. Good afternoon, Madam Chair and committee members. Here, Jennifer Witten, in support of this legislation. I think I shared last week with the committee for LifeBridge Health, in particular, we have a number of urgent care centers throughout the state of Maryland. And as you're hearing about kind of the ED overcrowding and really just thinking about smart ways we can advance community access to a number of services, this makes a lot of sense. Our urgent care centers are staffed by PAs and nurse practitioners for the most part. One of the particular points of the bill, I think there's some discussion around how we can ensure dispensing is appropriate. So appreciate some of the work done in that space. So with that, I'd ask for a favorable report from the committee.
Thank you, Jennifer. So we have a question from Senator Lamb.
Thank you, Madam Chair. Obviously addressing some of the workforce issues that we continue to see here in the state. And I know Chair Beidel and myself have been on the state's commission to study the healthcare workforce shortage. Utilization of PAs and physician assistants are essential to addressing kind of our workforce needs. I think one thing that does get missed in the conversation of this is that currently physicians assistants are allowed to do much more, I think, than advanced practice nurses. Because with a few exceptions, PAs can perform almost any medical act. Under this bill, are there any limitations to medical acts that PAs can do?
One person answer a question. It's not going to be the whole witness table. So pick the best one.
Senator Lamb, the bill does specify that it has to be within the experience, education of the PA. It has to be agreed upon between the physician and the PA under the collaborative practice agreement. And it has to be within the scope of the practice. So there are limitations on what a PA could be doing.
Those limitations are all just entirely decided by whoever the physician overseeing them is?
No, under the law, the PA would have to have appropriate education, training, and experience. And so each PA is going to be different. And so both the physician and the PA, when they work out that collaborative practice arrangement, need to make sure that what's in the collaborative practice arrangement is within the education, experience, and practice of the PA.
So as a physician, the primary limit to my scope of practice is similar to what you were just saying, the personal education, training, experience, and the capacity of the practice location. Under the bill, as you mentioned, it seems like it's the same for physician's assistants as well. Am I missing something here, or is there any difference between what a physician's assistant can do and what a physician can do? Because it sounds like the limitations in what you're describing are basically the same.
There are 2 additional layers, and in practicality, 3. So the 2 additional layers are the physician, the collaborative arrangement, and then the practicality of where physician assistants are engaged in more advanced work. It's under the hospital and ambulatory surgery centers where there are credentialing requirements and other mechanisms that limit what any kind of practitioner, not just PAs, could do. So this is structurally different than a physician because it has to be under a collaborative practice agreement agreed upon by the physician.
Okay, and we were talking about, I guess, some limitations that you were citing there, but one of the reasons that the current law allows PAs to have such a broad scope of practice is because the board has a process for approving PAs to do some of the more advanced duties that are there. I agree that the current advanced duty practice has a lot of issues, but are you willing to accept some form of advanced duty approval, at least to put some guardrails in place in the process?
So we're currently very much in discussion with the Board of Physicians. I just want to acknowledge how wonderful the Board of Physician team has been in figuring out how we can move closer. And so we do expect to be able to come back to you quite soon with hopefully a consensus with the Board of Physicians on that. And be happy to provide, of course, the detail of what we've agreed upon as soon as we do that.
Okay, and last question. The bill says that PAs can't practice independently, but I'm not really sure how much different having a collaborative agreement in place is that much different than the current nurse practitioners law, which requires independent nurse practitioners to consult when needed. Can you explain exactly how this is different than the independent practice of NPs?
Absolutely. So the in the advanced practice nursing, which of course, for the most part, we do not have collaborative arrangements anymore. This would specifically, what's envisioned is that the PA and the physician assistant would enter into a collaborative agreement that would be registered with the Board of Physicians. And then that the expectation would be that the physician and the PA at the practice level keep a very detailed explanation of what that agreement is. It would not be filed with the board out of acknowledgement that this is a living document. And of course, a practice can shift suddenly. There could be a physician that leaves or an NP that leaves, and that the PA and the physician would work together to update that detailed document at the practice level. One thing that's important to note, there are some true barriers also that this bill's 30 pages, so we couldn't get to everything. But one of the things I'll mention is that the current law requires a physician to sign every prescription issued by a PA. This has created a nightmare of paperwork for the PA, the physician, and there are lots of instances where the patient goes to pick up a prescription and is not able to get it. So there are other things embedded in this bill, because it's 30 pages we haven't talked about, but also clean up this practice and make it a lot more streamlined.
Okay. I mean, I would be curious to see what can be worked out with the Board of Physicians, because right now the Board of Physicians is the independent check to make sure that these practices that, or the scope that the PAs have doesn't go too far. But right now, I think in reading how this bill looks, it would leave that interpretation of who has enough training, experiences they have entirely to kind of the physician that's overseeing the PA, with taking the board of physicians out of it.
We are happy to make a beeline for your office as soon as we've kind of reached the details of some agreement. But I would say that the physician assistants appreciate the role of the board. I think no one wants, whether it is physician assistants or nurses or any of the other professions, they want to make sure that the board has the appropriate regulatory framework.
Thank you.
Senator Washington.
Thank you, Madam Chair. I just wanted to take a moment of personal privilege to recognize my classroom, my high school classmate, Nicole Wooten, who's here with us today. And thank you for all your hard work that you've done and all the work you're doing over at the Maryland, at the Eastern Shore. Question for you, will this bill help with the shortage of physicians?
Hi, Alon. Oh, Senator Washington. Thank you for your question. Yes, this bill will help with the shortage. You said the shortage of physicians. It will help with the shortage of providers because, as you know, there is a shortage of physicians across the country, and the problem is getting worse. So therefore, having physician assistants will help fill the gap with the healthcare providers, especially on the Eastern Shore, where we are having even further healthcare shortages. But however, with these barriers that we have in place, it's difficult for our graduates to be able to get jobs when they graduate. And that is the goal, to produce more providers to fill those gaps with healthcare provider shortages.
Thank you very much.
Thank you.
Thank you, Senator. Senator Kramer.
Yeah, thank you, Madam Chair. My curiosity was just raised because I heard the good senator indicate that you all were classmates, and I'm looking at this exceedingly young woman there, which then begs the question, how many years was the senator held back that you all were classmates? So thank you, Madam Chair.
Thank you, Senator. So I don't see any other questions for this panel. I really appreciate your work. I know how hard you've worked on this. And I really, really hope that we can get this bill passed this year. I'm pretty familiar with that issue on the Eastern Shore because we have a weekend house there. And I always say we would never move there permanently because of the lack of health care. So I hope we can help you with that. But thank you all very much.
Thank you, Madam Chair.
Next, we're going to call up a panel of favorable with amendments. So Michael Tran, Matthew Dudzik, William Kress, I don't know if he's back yet, Brett Linginger, Dan Shattuck, Danielle Varanian, Felicia Bowler, Felicia. And I'm also going to call Steve Wise. He's the last favorable with amendment. So Steve, you can stand at the podium or wait until it's your turn to stand at the podium, but that'll be everybody that's favorable with amendment. So who would like to start?
Or to start. Good afternoon, Madam Chair, Madam Vice Chair, and committee members. My name is Michael Tran, Health Policy Analyst at the Maryland Board of Physicians. The board would like to thank Senator Carrozza for sponsoring SB 167. We are in support of the intent of the legislation. However, the board has concerns that the bill as written may compromise patient standard of care and limit the board's ability to act as a proper regulatory oversight body. The committee has the board's written testimony, so for time, I'll just go over the main points. In Maryland, PAs currently practice under delegation agreements and outline that delegates medical acts and proper supervision to do so. SB 167 suggests replacing this model with a collaboration agreement. a move that the board stands behind. However, the collaborative model SB 167 proposes removes the function of delegation, fundamentally changing a PA's role from a physician extender to a practitioner that may make independent medical decisions. The board suggests reintroducing delegation so that a physician may act as the proper lead in a patient care team setting. The board's written testimony does outline the distinctions between core duties and advanced duties under current law. Given those distinctions, the board must emphasize the importance of maintaining a degree of oversight within advanced duty approval process. The board recognizes that the flaws exist within the current system, and proposed amendments aim to remedy those flaws. One of these amendments suggests maintaining the advanced duty approval process with exceptions for PAs working in regulated settings and with external credentialing processes. With prior board approval or with significant clinical experience and settings where there are regulatory oversights. A move that the board believes would reduce more than 66% of advanced duty approval requests coming into the board, alleviating unnecessary administrative burdens for both the PA and the board. The board supports SB 167 and the efforts to eliminate administrative burdens and duplicative requirements. However, to ensure patient quality of care and allow the board to fulfill its duty as a proper regulatory and oversight body, the board is requesting a favorable report with amendments.
Thank you. Matthew?
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. I'm Matt Dudzik with the Maryland Board of Physicians. Again, you have our written testimony, so I don't want to just echo what my colleague has said. I just did want to describe what the board's amendments would look like in practice. So right now, when you have an advanced duty that needs to be approved by the board, when we're talking about advanced duties, we're talking about duties that need some on-the-job training. So these are duties that you don't know, that you're not prepared to do immediately out of PA school. And so that is the area where the board does have an approval process in place. And we fully acknowledge that there are issues with the current process. And we are very happy to see some of these issues be addressed. However, we do think that some approval is important, that there does need to be some sort of check and balance that exists beyond just at the practice level, so that somebody can make sure that it is qualified staff that are performing these services. The board's amendments would propose removing that advanced duty approval process for a broad number of practitioners. Number one, if they are working in a regulated setting that has its own credentialing. I know the board has talked about hospital settings and ambulatory surgical centers. We've also spoken with the sponsors of the bill and the stakeholders. If there are other settings that meet those qualifications, you know, the board is willing to discuss expanding it into those areas as well. We're also proposing eliminating the approval process for anybody who's already been approved. Right now, the approval is based on the delegation agreement. So if you enter into a new delegation agreement, you must be approved again. We fully recognize that is extra red tape that's not necessary. And then our final proposal would be to remove the process for experienced PAs. So looking to what other states do, we're looking at 10,000 hours, which represents about 5 years of experience. The idea would be that you would only need any sort of approval if you're working in a private practice setting in your first 5 years of practice, and it's something you have never been approved before. We think this will cut down on a significant number of the advanced duty approval requests, and with the other changes that the bill makes, will really make a very measurable difference in getting these folks working as quickly as possible.
Sounds like you're getting close.
I hope so.
Thank you. Daniel?
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of the Maryland Society of Anesthesiologists. We're here in support with amendment. As introduced, the bill, as my two colleagues to the left described, makes changes to the advanced duties process, the approval process for advanced duties. Currently, the administration of general anesthesia and neuraxial anesthesia, which is like your spinals and your epidurals, are considered an advanced duty. Historically in the state, there have been, I think, only one that I know of, PA, who's ever been approved to administer general anesthesia or neuraxial anesthesia. So as we look at this bill and the changes that are being made, we've talked to the stakeholders. It's our understanding that that's not an area that the PAs necessarily want to get involved in traditionally. Again, they haven't. So we're putting forward some language that would limit, or actually, state that they cannot administer general anesthesia or neuraxial anesthesia. Just to clarify that important part, the administration of anesthesia, when you go into those levels of really deep anesthesia, you need to have training, qualifications, experience. And I think this is a good way to approach the topic and just clarify who does what in the state of Maryland. So with that, we're happy to keep working with the stakeholders to finalize language and come to an agreement and hopefully have a completed bill. Thank you.
Thank you. And next we have Brett.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. Brett Leininger on behalf of the Maryland Association of Nurse Anesthetists, also in support with the amendment, just echoing what Mr. Shattuck just said.
Thank you. Who's next?
Danielle Varanian. Good afternoon, Madam Chair, members of the committee. My name is Danielle Varanian, and I'm an attorney who represents the Maryland Radiological Society. We are favorable with this bill with amendments because as written, the bill currently includes language that would allow physicians' assistants to order, perform, and interpret diagnostic studies. And to Senator Lamb's earlier point, the way that the bill is currently written, the physician no longer determines the scope of the physician assistant. The physician assistant determines the scope. They practice in this bill, they practice within their scope. And there's a significant concern of the radiologists that physicians' assistants would be interpreting diagnostic images, and they do not have the requisite education, training, and experience to do that. We have proposed amendments or language for amendments that we believe was agreed upon last year that would address this issue. So it would allow the physician's assistants to order, perform, and interpret laboratory tests, and to use the diagnostic findings in their treatment of the patients. So provided that we can get some consensus on those amendments, we would be favorable. Thank you.
And next we have Felicia.
Good afternoon, Madam Chair, Vice Chair, and committee members. My name is Dr. Felicia Boulard-Renoir. I'm here with Danielle Varanian on behalf of Maryland Radiologic Society, presenting favorable with amendments. As a former physician assistant myself, and now a current fourth-year University of Maryland radiology resident, I feel that I am uniquely positioned to speak on the topic of physician assistants interpreting radiologic imaging studies, which is the sole purpose of my testimony today. While PAs play a crucial role in healthcare delivery, there are significant disparities between the depth of training provided in medical school/residency programs and that offered in PA school. The interpretation of radiologic imaging studies demands a comprehensive understanding of anatomy, pathology, imaging modalities, and clinical correlation. Medical school and residency training provide an immersive and rigorous education where individuals spend years mastering these intricacies under the guidance of experienced radiologists. In contrast, PA programs, while valuable for general medical knowledge and clinical skills, typically do not offer the same depth and duration of radiologic-specific education. The abbreviated nature of PA training may not adequately prepare individuals to interpret radiologic imaging with the same level of proficiency and accuracy as radiologists. Moreover, radiology residency programs involve extensive hands-on experience and exposure to a wide range of cases, allowing residents to refine their diagnostic skills under the supervision of a board-certified radiologist. This structured training is essential for developing the expertise necessary to provide accurate interpretations and make informed clinical decisions based on imaging findings. Allowing PAs to interpret radiologic imaging studies without the comprehensive training and oversight provided by radiology residency programs poses a potential risk to patient care. Misinterpretation of imaging studies can lead to delayed or incorrect diagnoses, unnecessary interventions, and possible patient harm. In the interest of patient safety and quality of care, it is imperative that the final interpretation of radiologic images remains within the scope of practice of qualified and extensively trained radiologists.
Thank you. And Mr. Wise?
Thank you, Madam Chair, members of the committee. I'm Steve Wise. I'm here today on behalf of MedChi and the Maryland Academy of Family Physicians. I'm going to take my time to talk for 1 minute about what's happened and the next minute about probably what needs to happen to get this across the finish line. I think that I've attended as many meetings on this subject as anybody involved here and maybe more. And I would say that number's in the 10 to 15 range over the last couple sessions, just with the PAs. So much so that at the end of March last year, we had a draft of this bill that MedChi, the family physicians, and other affiliated medical specialties were ready to support, and in part because it addressed in a way that was acceptable to the radiologists that issue that was just described. That bill did not make it across the finish line, but I offer that to you to say it was close as far as we were concerned to be in the right path. In the summer, there were some changes made to that bill. And your very able counsel prepared a list of differences that we went over in a meeting that described the differences between that bill that we were ready to support and the bill as it was introduced this year. I get now to and I thank your counsel for that work. What needs to happen? I think we need to have some very focused meetings on the amendment language. We have to figure out this advanced duty piece, which is very important. And I think with that, and I do believe that the language can be worked out. I mean, we know what the issues are, and we just need to sit down and have that meeting. And I think we can get there. I'm happy to answer questions about some of the other things that have come up, but I just thought the committee should know where we are procedurally.
Mr. Wise, thank you, because I know I pulled you into this, and
Yes.
I really appreciate. This is not my bill, but it's certainly my priority, and I appreciate your work. And I need all of you to get together and get this resolved. It's an important issue in our rural communities in the Eastern Shore and Western Maryland, and you're this close. And I really need for you to get this finished. So thank you for your efforts, but let's get it done. Senator Ellis, Senator Ellis.
Thank you, Madam Chair. You echoed my comments. Let me add Southern Maryland, because in Southern Maryland, just in nurses alone, we have like a 30+% shortage of nurses currently in our healthcare facilities. But I'll direct my question to one person, Dr. Bolinawa. Okay, and so seemed like you were for the bill, and you talked about the lack of expertise for PAs. Is that just, is this something that could be learned? Or you just basically want to protect the turf of your new profession versus your old? How would you describe that?
So I do believe that my position is unique, having been a physician assistant in practice for about 6 years in the emergency room as well as urgent care, and now being in residency and being in my 4th year. So I do have conflicting interests, but I do think that I am for and against certain things. In general, I am in support of PAs advancing their scope of practice. I think it is necessary for the current times that we are in, but with specific respect to certain duties that relate to subspecialty training, it becomes a little more complex. For physician assistants, I believe that a lot of our clinical skills are taught on the job. That was the case for me working in the emergency room. When it comes to practicing general medicine, I believe that their scope of practice could be comparable to that of a physician in terms of general medicine, but in terms of subspecialty practices, it can become very complex.
Yeah, complex. Yeah, there's complex and complicated, and as long as it's complex, I think that's a good thing, because with experience and training, so PAs, can they take additional schooling to be more specialized?
I went back to school for medicine about 9 years ago, so I would defer that answer to someone who is currently practicing.
Okay, in the interest of time, maybe someone can reach out to me afterwards to answer that question. Thank you, Madam Chair.
Thank you. I have another question, and maybe Matt or Michael, if you can say, give me a couple examples of things that seem to be at issue with advanced practice.
Certainly. So advanced duties, as Senator Lamb pointed out, PAs in Maryland don't have a defined scope of practice other than the practice of medicine. So PAs have theoretically the same scope as a physician, and there are certain exceptions built into the law. But overall, that limiting factor is the advanced duty approval process. There are the way that breaks down is because PAs don't have a residency. Advanced duties are typically things that require some on-the-job training, and some of them are fairly. Some of them come up quite a lot. There's a lot of, for instance, there's some cosmetic medical procedures that fall under advanced duties. Trying to think of some good examples. Arthrocentesis, which is common in like orthopedic practices, that's considered an advanced duty. And the board has no issue with PAs performing these. Typically for something like that, we would ask for practice logs showing that you've done this with your physician for at least 10 times. So we're not talking about a major barrier for those who do need that approval process. We understand there's some paperwork, there's some administrative burdens in demonstrating that to the board, but most of these advanced duties are things that we're comfortable with PAs doing as long as they've done it a few times with their supervising physician.
Hi, Lorelei, you ready?
Hi, yeah, this is Lorelei Ma. I'm a radiologist practicing in Baltimore. And thank you, Chairwoman and members of the committee, for allowing me to be here today virtually. I am a past president of MedChi. I am also a past president of the Maryland Radiological Society, and I'm speaking on behalf of the Maryland Radiological Society today in favor with amendments of Senate Bill 167. We're now in the third year of working on this bill, and I believe both parties have, in spirit, agreed to many changes, and I look forward to actually seeing bill drafts showing those changes that we've talked so much about. I actually headed up a work group because I want to work with the PAs to get there, right, to get to that finish line. In particular, the Maryland Radiological Society is concerned with language that appears overreaching, ordering, performing, and interpreting diagnostic and therapeutic tests and procedures. That's not under what their physician does. This is just anything they feel they can do. This greatly falls outside the scope and training of physician's assistants compared to physicians. To be able to perform radiologic and anesthesia procedures without licensure, as has been stated in one of the bill drafts, initially really can have devastating consequences. I'm going to just tell you one story just to highlight this. It was at one of our local hospitals a number of years ago. A PA who was a very good PA and would take a look at films, actually looked at a film, a line placement before putting in chemotherapy. And this was a good PA. She looked at the line placement and she thought it was in the right place. And she did not wait for the radiology report, which came within 15 minutes. So that chemotherapy line, which is supposed to be in a vein, so it goes to the whole body. So the chemotherapy on that breast cancer patient was supposed to go to the whole body. Unfortunately, it was actually in the artery, and the doctor said, the radiologist said, that's in the artery, but they had already started and got a report, that report in to try to get the person. They already started the chemotherapy, put the full dose. May I speak further?
Yeah, please finish.
Okay, put the full dose into her arm. Unfortunately, that was the only arm she had left that was really usable because she'd had the mastectomy in the other arm. So she had an extensively necrotic, unusable arm. It was a very sad case. And, anyway, it just goes to show it's not that PAs can't do things. And if they're under their referring physician, their overseeing physician, they can do a lot of good for patients, and they can see patients and evaluate patients and do procedures. But, doctors have 12 to 16,000 hours of training, and PAs have 2,000 hours of training. We are vetted in conferences during residency every day. Where is that line? What is that entity? And that's how we get honed in our skills. And this is true for other specialties in medicine as well. And that's why It's a physician-led healthcare team that I think is really important. I want the PAs to get there. I want them to be helping us and to allow us to see more patients, but I just don't want this to be a danger to the public.
Thank you. Do I have any questions for Lorelei? Thank you for your testimony.
Thank you.
That ends the hearing on Senate Bill Senate Bill 167. And now we're going to go to Senate Bill 594, Senator Hershey. Senator Hershey, do you have a panel?
Yes, ma'am.
Okay, would you like to bring them up, please?
Vicky, Casey, Kimberly, right?
Thank you very much, Madam Chair, for the members. For the record, Senator Steve Hershey to present Senate Bill 594. This committee has gone through great lengths to pass policies to ensure a healthier general population. Most importantly, in providing affordable, accessible healthcare insurance. We've created the Health Benefit Exchange. We've created check the box legislation that allowed individuals to check their income tax return and have individuals in the Department of Health take a look at that and see if they qualify for any type of medical coverage that they weren't aware of. And we also have passed the nationally acclaimed reinsurance program. We obviously just heard legislation to try to get more physicians assistants hired, as well as many other bills to deal with the lacking healthcare professionals that we have in the state. However, when it comes to treatment, public healthcare policies tend to be more reactive than proactive. In other words, we treat the symptoms and not the cause. Senate Bill 594 would require Medicaid to cover any FDA-approved medication for the treatment of obesity. With this bill, Maryland would join 16 other states to cover pharmacological therapy or prescription weight loss medicines. Again, this bill only relates to Medicaid enrollees or our most underserved population. Many commercial carriers are already covering these medications because they've recognized the cost benefits of treating the causes rather than the more expensive conditions and complications of obesity. So just some quick information. Obesity is recognized as a disease. Obesity is caused by a range of biologic, genetic, social, behavioral, and environmental factors. Obesity is treatable. Research shows that expected results from weight reduction range from 16 to 23% for the very invasive bariatric surgery, which, by the way, is covered by Medicaid, 5 to 17% for anti-obesity medications, to only 2 to 4% for intensive behavioral therapy. And that's basically programs that are centered along diet, exercise, and changing habits. Obesity is linked to more than 200 weight-related comorbidities, such as cardiovascular disease, hypertension, sleep apnea, depression, asthma, type 2 diabetes, as well as hip and knee osteoarthritis. In viewing healthcare equity, Maryland ranks 22nd in the nation for obesity and overweight. 34% of Marylanders have obesity, and nearly 70% have obesity and overweight. Of that 70%, the African-American population is the most impacted at 42%, followed by Hispanic population at 33%. Finally, the cost of doing nothing is too high. Obesity rates continue to increase. Our state needs to shift from a system of sick care to well care, especially in our most vulnerable population. So I would encourage the committee members to read the number of letters of support in your files, and especially take a look at the November 23 global data report on the impact of obesity on the economy and labor force. With that, Madam Chair, I have a number of experts here on obesity and the treatment of that, and would certainly stand available for any questions. Thank you.
Senator, so who would like to go next?
Who would you like to? Who would go?
I'm happy to go first. Thank you, Senator Hershey. I would like to thank the chair, vice chair, and committee members for this opportunity. My name is Dr. Kimberly Gajuni. I'm a nationally recognized expert in obesity. I'm a practicing obesity medicine physician, and I direct the Johns Hopkins Healthful Eating, Activity, and Weight Program. It just doesn't make sense. Why does my health insurance exclude treatments for obesity, but covers those for diseases that I have because of my weight? This is what I hear from my patients, and I agree, it does not make sense. Senate Bill 594 proposes to cover comprehensive obesity treatment as recommended by leading medical organizations, notably by expanding coverage for anti-obesity medications among Maryland Medical Assistance Program recipients. Losing weight is not a question of willpower. Weight loss triggers the body's complex physiologic pathways to increase hunger, decrease fullness, and slow metabolism. Simply put, people have to fight against their physiology. The science shows that anti-obesity medications address these biologic mechanisms, and in turn, more people achieve and sustain meaningful weight losses with medication, and ultimately meet their health and wellness goals. Perhaps unique to obesity, comprehensive treatment can prevent and improve other conditions. With weight loss, patients experience less pain and are able to be more physically active. Patients have better blood pressure control and may come off hypertension medications. Patients have improved health status and may be at lower risk for hospitalization. But the lack of anti-obesity medication coverage worsens health and healthcare disparities. Other Mid-Atlantic states, such as Pennsylvania, Delaware, Virginia, and New Jersey Medicaid already cover anti-obesity medications. However, my patients must consider whether they can afford to pay out of pocket, impossible for most. Sadly, other patients now hope that they develop diabetes, as this diagnosis may grant them access to diabetes medications that will reduce their weight. This bill presents an opportunity for Maryland to begin to make sense by making comprehensive obesity treatment truly available for program recipients. I respectfully request that the committee give this measure a favorable report. Thank you.
My name is Casey Che. I'm an obesity medicine specialist and a primary care physician at Johns Hopkins, dedicated to serving a diverse population in Baltimore, Maryland. I want to emphasize that obesity is a complex chronic disease that requires comprehensive treatment. For many patients struggling with obesity, lifestyle change alone is not sufficient in achieving meaningful weight loss. That's where anti-obesity medication can come in as an effective adjunct to enhance weight loss efforts. And as a physician, I have seen the transforming power of these medications. So I'd like to offer one example. Miss M in my weight management clinic, she has achieved a 100-pound weight loss, and that was through lifestyle change reinforced by the use of anti-obesity medication. As a result, she had improvement in nearly all her health conditions: prediabetes, high cholesterol, sleep apnea, and fatty liver disease. And we were able to significantly reduce her medication burden and reduce her healthcare costs overall. Unfortunately, these life-changing medications are out of reach for Maryland's most vulnerable. I have another patient in my primary care clinic who has multiple obesity-related complications, but he does not have access to these medications, and his health is not improving. So where he's at now, he has developed severe heart disease that is now requiring surgery. Expanding coverage of anti-obesity medication is an upstream solution to dealing with the downstream problems of obesity that's severe and costly, like heart disease. If you expand coverage of anti-obesity medication, you will improve healthcare outcomes and you'll reduce healthcare costs. Thank you.
I'd like to thank the chair, vice chair, and members of the Senate Finance Committee for the opportunity to speak in support of this bill. Today I come to you as a lifelong Marylander who has also struggled their entire life with obesity. Growing up, my family and I tried many things to address my weight. There wasn't a diet or a fad workout I didn't try growing up, and still I struggled. Whenever I sought help For my weight and health in medical settings, I was given the same advice: follow the food pyramid, exercise more, eat less. But I was already doing those things and they weren't working. It wasn't until 2008 when bariatric surgery became available to me that I saw a real opportunity to meaningfully address my weight. And even then, accessing care was hard. I was made to do many things to prove myself worthy of that intervention, including losing more weight before surgery, more special diets, and a psychological evaluation. Even then, I wasn't sure I'd be approved, even though I truly believed my health depended on it. Thankfully, I was approved. I credit my obesity treatment with helping me become an active participant in my health. This has benefited me in so many ways that I could not fit all of them into my allotted 2 minutes, but I do want to say this. Obesity takes a toll on your life. It contributes to myriad health problems that can prevent you from being your most present and productive self. And it exacerbates the level of discrimination and bias people receive from nearly every corner of society, even from medical professionals. That was true for me, and I was fortunate enough to have health insurance through my job. I can't imagine what the process must be like for my fellow Marylanders who depend on Medicaid to access obesity care. What Marylanders need is a comprehensive medical set of solutions for obesity. Quite literally, obesity can kill, and our lives deserve more than conjectures about willpower and self-control. We deserve for our health problems to be treated like any other health problems with the same standards of care. In closing, I'd like to say that I look forward to working with the state of Maryland to ensure that Maryland Medicaid recipients get access to comprehensive obesity care, and I ask for your support to pass SB 594.
We have a question from Senator Lamb.
Thank you, Madam Chair. Dr. Guzuni, good to see you again. I know we've worked on a lot of things before in the past, and this could be open up to you or any others on the panel. I think the biggest impediment here is probably the fiscal note. Just looking at it, it states that Medicaid expenditures would increase by at least 56 million. I think you touched on this, but if you could just articulate a little bit more clearly where this could be really penny wise, pound foolish, and no pun intended, but the amount of savings that we could have from being able to reduce the symptoms and other implications of further obesity in our community is huge, right? And it could really pay for itself in the long run if we were able to give providers the full ability to use all of the available tools that they have. Because otherwise, short of this, it looks like you're combating obesity with one arm handcuffed behind your back without being able to use weight loss medications that would be covered.
Yeah. Thank you, Senator Lamb, for the question. So I think with looking at the costs, that a lot of times these analyses don't take into account those benefits and cost reductions. And so with treatment, we can see potential for reduced hospitalizations. If we take COVID-19 as an example, individuals with obesity were at much greater risk of hospitalization and poor outcomes. So with a population at a healthier weight, risks of those type of diseases, that's just one example, but also thinking about the other chronic care costs and thinking about cardiovascular disease, diabetes, things even like low back pain, which seems small, but really impacts things like amount of time you go to the doctor, medications, and loss of work, loss of productivity. It's a really a ripple effect. And so just looking at the added cost of the medications without taking into account those other effects is really not doing justice. You know, there have been some economic modeling analyses out of the USC Schaefer Center, which uses Medicare simulation, which I grant you is obviously not this population, but actually shows that you get cost offsets that over the course of a 10-year period would save Medicare potentially billions and billions of dollars by proactively treating obesity with the coverage of these medications. And so it really is a shift in paradigm and thinking about what could we potentially save, and also thinking about the improvements of quality of life. You know, I really appreciate your comments, you know, about the stigmatization that individuals face. This is not just cardiovascular disease and diabetes. It is really much broader than that. And if we're focusing on a culture of wellness, we really need to think in a different paradigm and understanding there are financial risks, there will be bumps in the road, but to continue to do nothing and operate with our really sometimes it feels like two arms behind our back. You know, it is really not doing justice to this population.
Great, thank you. I appreciate the bill. Could have almost mistaken it for Senator Lamb bill.
Senator Mounts.
Thank you, Madam Chair. Dr. Goodzone, is that right?
You can feel free to call me Kim.
Kim, your doctor.
I am, yes.
And then Casey, you're a doctor also? Okay. So I'm trying to understand. So, you're licensed doctor and you're trying to prescribe medication to your patient, and the medication is for obesity, but it's not covered. Why is that? What prevents you from doing that? What's the rationale?
So right now there's a specific coverage exclusion that oftentimes historically obesity has been considered outside your kind of typical health plan. And this is true of not just Medicaid, but Medicare and commercial employer insurance as well. It's a separate carve out that people need to elect to opt in, despite the fact that obesity has been recognized as a chronic disease for, over a decade now by the American Medical Association.
Yeah, obesity is the number one health concern throughout it is the number one health concern, correct?
Yes.
But it's not considered a real health concern for your practice and taking care of your patients.
And so when you are specifically prohibited there is a policy exclusion for any medication that is for weight reduction. And so when I go and try to prescribe a medication, if someone has a specific exclusion, there is no possibility for appeal. There is no possibility for peer-to-peer review. It's just a closed door. And so there are patients that are suffering with advanced morbidity from their obesity that would benefit from weight reduction. And sometimes they're too ill to go to surgery. And so what do? We can offer them lifestyle treatment, which that expansion is why this is so key.
So you can write prescriptions for everything else, but you just can't for the.
Correct.
Thank you.
Any other questions? That ends the hearing for Senate Bill 594. Thank you, Senator. Senator Kramer, Senate Bill 714. And if you have a panel, please bring them up.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Ben Kramer here to introduce Senate Bill 714, sponsored by myself and Senator Hershey. That ought to get some eyebrows to rise. Colleagues, this hopefully is a fairly straightforward, easy bill to digest. Currently, we have a state board of examiners for audiologists, hearing aid dispensers, speech language pathologists, and music therapists. Of those four professions, two of them, hearing aid dispensers and music therapists, the nominations for the board are recommended by the professional associations that represent them. Two of the professionals on the board, audiologists and speech language pathologists, have their nominees brought to the secretary by the board of, what's the name of the board? The Board of Examiners, thank you. So here's what we're looking to do. The Maryland Academy of Audiology asked that I introduce this bill to bring them in line with two of the other professions that are, represented by the State Board of Examiners for their nominees, and have those nominees come from the Maryland Academy of Audiology, which represents the audiologists here in the state. Quite frankly, there appears to have been some problems with the board making these recommendations, that positions have not been filled when there were vacancies, And so the Academy is anxious to ensure that when there is a vacancy, the nominees are quickly put forward and the process from that point does not change. The secretary and the governor's offices all will review those nominees. The only change is the professional organization that represents these members will make the nomination, just like 2 of the other 4 professions do now. It's just that simple. And colleagues, I hope we get a favorable report to ensure that these vacancies are quickly filled by the people who know what they're doing. Thank you.
Any questions for the senator? Okay, then we'll go to the panel and is Melissa? Okay.
Melissa.
See Jeff.
I'm actually going to go first.
Oh,
Jennifer.
you want to go first?
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, and committee members. My name is Dr. Jennifer Kincaid. I am a licensed audiologist and currently serve as the president of the Maryland Academy of Audiology, MAA. The MAA was founded in the early 1990s to provide a professional home for audiologists practicing in the state, as their needs were not being met by other associations. The MAA is the only state association that is of, by, and for audiologists and focused exclusively on the profession. While I am a member of the American Speech Language Hearing Association, ASHA, I have never been a member of or received any communication from the Maryland Speech Language Hearing Association, MASHA. In fact, I had never heard of MASHA's existence until we began working on this legislation. The MAA volunteer leadership is comprised entirely of licensed audiologists. The MAA board provides its members with a path to achieve autonomy in a variety of ways. The MAA has been active on legislative and regulatory issues for more than 30 years. The annual MAA convention assists attendees in obtaining the 30 hours of continuing education in the area of licensure, audiology, required to be licensed. And the MAA works to increase public and consumer awareness of hearing and balance disorders across the state. Additionally, the MAA website content is entirely audiology based. The MAA has knowledge of licensed audiologists who are experienced, capable, and willing to volunteer for the Board of Examiners position. Additionally, the MAA can assist non-members who wish to self-nominate for a vacant board audiology seat as demonstrated in past years. The MAA is willing to assume the requirement and submit nominees to the Secretary of Health and Governor for vacant audiology board seats. If MASHA or ASHA is concerned about audiologist representation, they could select one of their own audiologists as one of their recommendations to the board. Thank you for your time and consideration on this important piece of legislation. I ask for a favorable committee report on SB 714.
Okay, then Jana?
Melissa. Say
You're Melissa.
Yes.
And you were?
Jennifer.
Jennifer. Okay, and Jana's not here?
No,
Okay.
Jana's not here.
Okay. All right, Melissa.
Good afternoon, Madam Chair and distinguished members of the Finance Committee. I'm Dr. Melissa Segev, a licensed audiologist and small business owner of one of the largest practices in the state of Maryland. You have my written testimony, but in light of the Board of Examiner letter of opposition, I would like to tell you why you should completely ignore that letter. The board has been crippled by lack of staff, as noted by Dr. Spore's written testimony. That lack of staff also caused dysfunction and delay in seating Jana Brown, now a current board member, from June 30th until late September, losing 3 months of participation. At the recorded board meeting last Thursday, their legislative committee initially voted against the bill because they didn't realize it was to harmonize the audiologists with the other professions on the board who send their recommendations directly to the governor. The board thought that SB 714 meant just the audiologists alone were seeking to send recommendations to the governor. After the committee took the unfavorable vote, they then realized that all other professions send their recommendations directly to the governor. In the full board hearing last Thursday, there was a question and a motion to amend the recommendation to support the audiologists and even add speech pathologists to make the bill fully consistent, and we support that. Amazingly, the Assistant Attorney General stated erroneously that they could not amend the recommendation of the legislative committee before the full committee. And a board staff member said they already uploaded their opposition testimony to the MGA website and it was unlikely they could change it. And that was before the entire board could vote.
The Assistant Attorney General then suggested, after going to the executive session, that they adopted the legislative committee recommendation to oppose. Another member said it was worthy, but they could oppose the bill in 2025. We are here right now to make it consistent. We don't need to wait another year for more dysfunction in the appointment process. Should the committee also wish to add speech pathologists to this bill, there is no objection from the audiologist. Finally, there will be full notice of all vacancies on the board, as the current statute of healthcare occupations 1-215 mandates that the board shall notify of any vacancies to all licensees, not just MAA. And we will proudly be nominating a female who identifies as Native American. So 2 of the 3 seats will be a minority. We kindly ask for favorable report on SB 714.
Okay, thank you. We have one more virtual, then we'll open it up for questions. And that
Great. Can you hear me okay? Perfect. Thank you very much. Madam Chair and committee members, my name is Dr. Alicia Spohr, and I am here in strong support of Senate Bill 714, and am pleased to be working with Senators Kramer and Hershey. My oral testimony is provided. However, in light of the letters from the Maryland Speech Language Hearing Association and the American Speech Language Hearing Association, I'm here to explain why MASHA does not represent audiologists in the state. Last year, MASHA's president, Mary Casper, was asked how many dues-paying Maryland audiologists were members of MASHA. MASHA refused to provide the answer, and to date, this information has not been delivered. This question should be posed to MASHA during their testimony to obtain the actual number, names, and proof that they are dues paying to MASHA and not ASHA, if any. Further, prior to the August 23, 2023, there was no audiology representation on MASHA's board of directors. Dr. Sparks was added after the question was posed to MASHA on audiology membership. Further, Dr. Segev was president of MAA 2 separate times in the last 15 years. When she contacted MASHA to obtain audiology nominations for vacant board seats, MASHA indicated that they had no audiology members. Last week, when I searched on MASHA's website for audiologists, it yielded 0 results, not even their director of audiology. Simply, MASHA does not represent audiology. Further, the state's association's ability to nominate vacant board seats was repealed a few years ago. There's been no attempt by MASHA to add their state organization back into audiology or SLP statute. If MASHA is genuinely concerned about audiologists, they could nominate one of their 3 board seats who could be a dual license member. No other health occupation board has oversight on another profession's nomination, as MASHA is asking for with MAA. The MAA is willing to include MASHA's amendment to allow MASHA to nominate SLPs to vacant board SLP seats to provide full conformity of nominations for all professions on the board. Thank you for your time and consideration on this important piece of legislation. I ask for a favorable committee report on Senate Bill 714.
Are contemplating doing this, but that is a policy decision being driven by the residents of those local governments or those local counties telling their governments, this is a priority for us. This is a policy decision. And whatever other jurisdictions choose as their priorities, that's their business. But why would you stand between those jurisdictions and the residents of those jurisdictions that have disabilities? Why would you stand between them and providing that much needed support? I don't understand that.
So thank you for that question.
Sure.
So first and foremost, I would like to state that Medicaid providers are supposed to accept the Medicaid rate. With having said that, the department has started a rate setting process, I believe a couple of years ago, and I apologize for not knowing off the top of my head. I just started with this position January 10th, but the department has started a rate setting review that basically takes into consideration the rates for those areas that have a higher cost of living. So the department has, through that process, set up rates that sufficiently fund Medicaid providers for these home and community-based services.
Well, when you say sufficiently fund, I can tell you right now, and I haven't looked at it in years, but the developmental disabilities waiting list is still probably massive. And so when you say sufficiently fund, if Montgomery County is supplementing the DD community in Montgomery County, and federal funds are sitting out there ready to flow to Montgomery County, but it's got to be done through your agency in order for it to happen, but you're not doing it. So how can you say it's sufficiently funded when we are leaving in Montgomery County alone $10 million, $100 million over the last decade that Montgomery County's been trying to accomplish this, that doesn't go to Montgomery County. It goes directly to the providers providing these services to the developmental disabilities community.
When I mentioned that the rates are sufficiently funded, when the department goes through its rate setting process, it must share its rate setting process, those rates, and the cost to do those services with the Centers for Medicare and Medicaid Services. CMS looks at our rates with its rate contractor and determines if those rates are sufficient before before CMS will actually approve the waiver application. Again, our rate setting process accommodates for two different rate tables. One is for those jurisdictions that don't have the higher cost of living. The other is for the jurisdictions that have a higher cost of living. We've gone through this process by way of our renewals as well as our amendments. We've shared our rates with the Centers for Medicare and Medicaid Services, and they have been deemed data-driven and sufficient.
Secretary, let me just ask you this basic question. Do you acknowledge, yes or no, that there are millions of federal dollars that could come to Montgomery and Prince George's counties right now to match the supplement that those jurisdictions are providing to their developmental disability community? That should be a simple yes or no. Do you acknowledge there are millions in federal matching dollars that could go to those jurisdictions right now?
In my acknowledgement of yes,
Okay.
it also speaks to our concerns about cost neutrality, as well as healthcare access and equity concerns that are already exacerbated in underserved and underrepresented communities.
Okay, so if I understand correctly, you acknowledge there's tens of millions federal dollars that could be coming to our disabilities communities right now, and you all are not going to help get those federal funds in place so that they can be utilized by this most vulnerable of our residents. Thank you, Madam Chair.
Thank you, Senator. Senator Reedy.
Thank you, Madam Chair. I just want to follow up on that for a moment. And I want to look more closely at this, but I know there could be good reasons why we're not in good position to take matching funds at certain times. You've mentioned cost neutrality, but also equity concerns with different communities. And I know you're new, so I understand at this position. Are you saying that one of the big reasons we wouldn't be taking federal dollars for federal disability dollars is because it might go to the wrong jurisdictions, and it wouldn't go to jurisdictions where there's equity concerns, or like that it's not going to the right jurisdictions to be diverse enough? Or I'm just trying to understand that.
I wouldn't classify it as the wrong jurisdictions, but this bill would require those jurisdictions that may not have the financial resources to provide the supplement to not participate. And so we find in those jurisdictions already that there are health equity concerns. There are specific neighborhoods and populations where there are already underrepresented and underserved participants.
Okay. And I know we actually have some state policies that are being proposed to try to deal with, for example, long-term poverty in different neighborhoods and areas in the state, which I think is a good goal. But if a county could meet a disabled population's need, it seems to me we shouldn't be saying no. We shouldn't be saying no because it's not meeting a need somewhere else. I'll leave it at that, but that is a little bit like concerning. We of course want everybody to be able to take advantage of things equally, but I'd be concerned that we would be turning down money that we could get because maybe some counties can't afford the match and some can. I think that's a concern. We're talking about this population, you know, when we're not talking about like tax credits for starting a business. We're talking about people who need, we all agree, there's a consensus that folks who are disabled, developmentally disabled, we all agree that's a role that we believe government should fill. But I'll leave it at that, but thank you very much.
Yes, and thank you for that, that comment. Again, we are able to demonstrate that our rates are meeting each county's needs. And so what we have done is actually talked with our colleagues at Montgomery County and asked if we could have them come to the table and look at our rate review rate setting process.
No other questions for this panel. And I think that ends the hearing. Thank you.
Thank you.
Thank you.
Senator Lamb, Senate Bill 718. Senator Lamb, you'll bring up your panel.
Yeah, I've with me Senator McKay, Robin Elliott, Nicole Beeson, Mary Kay DeMarco, and Jake Whitaker.
Thank you.
We can just, let's just make sure you're here.
Mr. Greenfield, I have you forward for favorable with amendments, so we'll bring you up after this panel. Thank you.
All right, good afternoon. Thank you, Chair Beidle, members of the committee for allowing me to testify in support of Senate Bill 718. For the record, Clarence Lamb, Senator District 12. The committee has been hearing over and over again about significant healthcare workforce shortages in the state. However, there are shortages for all providers. The shortages of nurses is especially significant because the important role that nurses play to be able to address needs in our healthcare facilities, which we would not be able to address without the intervention of a lot of nurses to make that happen. Decided to introduce this bill after conversations with nursing educators about the high rate of attrition for nursing students. With nursing schools full, we cannot afford to lose a single nurse during their training. Yet attrition rates among nursing students is about 25%, with even higher rates of minority and higher rates for minority and low-income students who are not able to successfully complete their training program. The research shows that attrition rates for nursing students is high because nursing students tend to be older with more family obligations, including childcare and elder care. They also tend to have to work while in school. Many nursing students work their way through school as certified nursing assistants, and while their CNA experience enriches their education, it can also cause logistical challenges for nursing students trying to balance their school and clinical schedules. This bill establishes a Maryland pathway for nursing program within the Maryland Department of Health. The primary goal of this program is to help alleviate the shortage of nursing professionals by increasing the graduation and licensure rates of nursing students. The program also strives to increase diversity within our nursing workforce. This program seeks to accomplish this by funding the wraparound needs for nursing students to complete their schooling. As a starting step, this bill calls for the implementation of a pilot program that will be conducted by the Maryland Department of Health in consultation with a diverse advisory committee. This pilot will help us better learn what funding needs nursing students have and what diverse funding streams we can pull in to fund them. This is not a new bill. I think members of the committee who were here last year will recall that there was similar legislation introduced last year as well. This innovative program has a precedent in Maryland. Just a few months ago, Baltimore County Executive Johnny Olszewski launched the Public Health Pathways Program based on similar principles that are in this bill. We have a representative from Baltimore County to discuss the implementation of that program. We've also heard from the Maryland Department of Health that they are concerned about their capacity to house this program, and we've begun discussions with MHEC, who seems very interested in supporting this program and potentially has the capacity to house it without the need for increased staff. Finally, I've submitted an amendment to include HFAM and leading age on the work group to ensure that we're looking at the staffing needs for nursing homes. This addresses their favorable with amendments testimony. In conclusion, nurses are an absolute crucial part of a successful healthcare system. This bill will attract more students to nursing and support them as they undergo training so they can work in our state to ensure sufficient staffing for all of our patients. Thank you for your time. Pass along to other members of the committee. Happy to take questions at the end.
Thank you, Senator. Jake?
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm Jake Whitaker on behalf of the Maryland Hospital Association, here to testify in support of Senate Bill 718. As you all know, Maryland hospitals, like healthcare providers across the nation, continue to experience workforce shortages, including for our nurses. This bill provides a blueprint to alleviate Maryland's healthcare workforce shortage and diversify the nursing workforce pipeline. Maryland hospitals are engaging in creative and collaborative efforts to grow the workforce, including working with universities and community colleges. And what we found is that over 90% of graduates stay and are employed in their communities after they graduate. But that said, on average, 20% of those nursing students will drop out, many of those dropping out in the first semester. The Maryland Pathway to Nursing program will help address this issue. This program would be a way for students to access wraparound services to help them succeed in those nursing careers. Specifically, this program works to address social drivers and social determinants of health that kind of present barriers to these folks accessing these careers. So this bill would help with things like childcare, tutoring, and transportation assistance services for those seeking these career paths. Additionally, hospitals are partnering with community colleges to establish programs for these high demand positions, as we mentioned earlier. And there is significant interest in these positions, but space is very limited. This legislation will allow the state to build on the success of these programs, incorporate the lessons we've learned, and help Maryland grow our own healthcare workforce. So demand for these careers is only going to increase, and it's going to require a robust healthcare workforce across the care continuum. By some estimates, we've seen that between 2021 and 2035, the demand for RNs is expected to grow by more than 50% in just nursing homes alone. So we really need the state's support and investment now to ensure that we have a healthcare workforce to care for all Marylanders, and we think this bill is the way to do it. I'd like to thank Senator Lamb for his support and sponsorship of this important legislation. And for the aforementioned reasons, we respectfully request a favorable report on Senate 718. Thank you.
Perfect timing, Jake. Thank you. Who would like to go next?
Good afternoon, Madam and Chair and members of the committee. My name is Nicole Beeson, and I stand here as a testament to the transformative power of access to a career in nursing and programs such as the Pathway and the Community College Partnership. It was access to both mentorship and sponsorship that allowed me to pursue my career in nursing, breaking out of the shame and trauma of domestic violence. This journey provided a haven for my healing. It also transformed my life, as well as the life of my 3 children. As a result of my journey, I'm proud to say that 2 of my children have chosen professions in healthcare, one a nurse and one a physical therapist. I think this underscores the profound impact that access to such programs can have on families and the ripple effect of positive change. I now serve as the Chief Nursing Officer at the University of Maryland, St. Joseph Medical Center. I'm also privileged to have led this pilot with partnership with CCBC and the Baltimore County Executive Office. I've witnessed firsthand how this program can change the course of people's lives, shaping individuals into the healthcare professionals they aspire to be. I am in awe of our current Pathway students and the possibility this program could offer, helping to remove barriers such as social determinants of health and other barriers around them, providing individuals from all walks of life an opportunity to pursue careers in nursing. Our pilot has highlighted the resilience and commitment of a diverse group eager to transform their lives. It has the potential to open doors for countless others, creating a diverse and talented workforce that our healthcare system desperately needs. Thank you for your time and your support of this important bill.
Next, Mary Kay.
Yes, thank you, Chair Vidal and Vice Chair Klausmeyer and committee members. I'm Mary Kay DeMarco. I'm the Nursing Program Director at the Community College of Baltimore County and former President of the Maryland Nurses Association. Senate Bill 718 really is the only bill this session designed to help alleviate the nursing shortage in Maryland. The bill supports educational mobility for pre-nursing students to become LPNs, licensed practical nurses, in community colleges in selected areas of the state. You've heard the details and you know the shortage data, particularly from the Maryland Hospital Association. LPNs can be educated in 12 to 18 months, and once licensed, LPNs can bridge to become RNs. I see in my practice, really over 30% of our students are unsuccessful in the first year because they are working adults. They don't have funds for transportation, childcare. They're forced to work full-time. It's very difficult to work full-time and go to nursing school. Stackable credentials are a manageable way for these students to obtain the education to become nurses. Wraparound services are necessary to help with those issues, transportation, childcare. They may seem minor points, but these are major obstacles for the students in our programs. Senate Bill 718 is a win-win. It can help minority students join the nursing profession and help the overall status of nursing in the state of Maryland. I thank you and urge you to have a favorable report.
Thank you, Robin.
Good afternoon, Robin Elliott here on behalf of the Maryland Nurses Association. Just really wanted to make two main points. As Mary Kay DeMarco just mentioned, this is the only bill in addition to a wonderful loan repayment program bill for school nurses that address increasing the number of individuals in the nursing pathway. Really, this idea came from, it was inspired by Baltimore County, and it was also inspired by, you all passed a bill in 2022 to create a commission to study the healthcare workforce shortage. And one of the recommendations is to support these types of programs. So here is this wonderful bill. The second thing I wanted to mention is it is detailed in the bill that the funding for this is braided funding. And the idea is that a community, and there are two communities in the state that would be recognized under this bill. They'd have to be diverse communities. We have Senator McKay and Senator Lamb, very different geographic districts. They would have to braid funding. So we'd be looking at funding from of course, their existing tuition programs. There are workforce development boards. There are healthcare facilities who are investing in this program. So the idea of braided funding is really braided throughout this bill. It's directly mentioned. And with that, we'd be very, very happy to work with the committee on figuring out a way to get this bill passed this session. We know we need more nurses. We do not want to wait for another session in order to establish this kind of program. Thank you very much.
Senator McKay, are you gonna?
If I may.
Yeah, absolutely.
In total respect of your time, I'd like to say me too. And on behalf of my twin, Senator Lamb and I, and in Appalachia, Maryland, this is needed with our nurses. And we're hoping there'll be passage through your committee. So thank you for your time.
Thank you. I have a few questions, and I think I'm going to direct them to Robin, if that's okay. Because with Senator Lamb, as he said, we served on the nursing, well, the healthcare shortage. And I've heard about the St. Joe program, which really has impressed me. But we have a letter from the Department of Health that says they don't really want the program. Not that they don't support it, but that they don't have the expertise. So, Robin, what do you think about MHEC, who already has the scholarship program? Do you think we could talk to them about supporting the program?
Absolutely. And we may have already started that conversation. I've talked to the Department of Health. I know that they're very, very supportive of the concept. As you said, they are just very short-staffed. So one of our colleagues who's been working with us on this bill has already had a conversation with MHEC. Sounds like they're interested. This could be a really good fit. And so that is definitely, I think, something that if the sponsors and the committee are interested in, seems like that's a pathway for the pathway bill.
It really sounds good. Senator Ellis?
And thank you for this bill, Senators. My late mom, she took a similar pathway, LPN, became RN, and her last job, she was in charge of a mental health clinic and did quite well. So reflecting back on a few years ago, in former Triple E, I thought Maryland was phasing out LPNs. There was a move to phase out that. Is that true? Is that a good, correct memory? Some yes, say yes, or.
So you are correct, Senator, that for many years LPNs were not prominent as members of the healthcare team, and they were not prominent in education. CCBC was one of the only schools at the time to have a freestanding program, and it was not robust until recently. The nursing shortage of RNs has now recognized that LPNs are very viable team members, and many schools are increasing their enrollment. And thankfully, the healthcare system is now recognizing the important role LPNs can play in healthcare. I think in addition, they can bridge to an RN role in education if they wish to, rather easily. Many of our programs now offer that bridge. So it's a very it's a dynamic role that is increasing again, and I think it's a well-known good entity. And I just will add, in our program, we teach in our research and ethics course about the Tuskegee syphilis crisis. So glad that you mentioned that atrocity.
Yeah, thank you for that. So, if we don't remember the past, we're kind of on path to repeat it. So, so thank you for that. And I'm glad that the LPN pendulum is spinning back towards recognize the value for LPN. So thank you for that answer. Thank you, Madam Chair.
Thank you, Senator. I don't see any other questions for this panel. Oh, no, I'm sorry. My Vice Chair, Kathy Klassmeyer.
I think I just ask Robin, maybe you might know. Do you remember a couple years ago, Senator Augustine had a bill similar to this? And I'm just wondering if it's still in play. It was to get nurses. It's been probably 2 or 3 years ago.
I don't remember a bill from Senator Augustine on nurses. I'm going to have to go do a search. I'm wondering if it might have been another profession, but my brain is session full, so I can check.
And the only reason I'm saying that is because when he said that, I said, we have all these different methods of getting more nurses. And I suggested to him, and I will suggest to all of you, if you look at if you need funds for this, look at the EARN program, employment advancement right now. And I'm not sure how much money is in there, but it's in the Labor Department, and it may be helpful to you for this. So.
Thank you so much. And we in the bill recognize that the Department of Labor is an important partner for exactly that reason. So there's an advisory committee. They would be a member of that. And we also recognize that a lot of those funds flow through these local workforce investment boards, and they could be major contributors, as they are, I believe, in Baltimore County, to weaving together the funding necessary for these programs.
And just for the record, the EARN program was designed and implemented by Johnny Oshesky and myself. So it's a good Baltimore County bill.
Sounds like a great bill,
Yeah,
and we'd be happy to tap into that and follow your lead.
Thank you. And Mr. Greenfeld, you are favorable with amendment.
Yes, Madam Chair, Madam Vice Chair, I'll be super brief here on behalf of Leading Age Maryland and with a friendly amendment to add us to this very important advisory committee and really appreciate the senators allowing us to do that. And for those reasons, we're favorable with that amendment.
I'm sorry, which us, lifespan or?
Leading age Maryland.
Leading age.
Lifespan's already in the bill, and I understand the senator has added HFAM and Leading Age Maryland as amendments.
Thank you.
Thank you.
Senator Klausmeyer, you have two bills. First one is Senate Bill 996, Advanced Practice Registered Nurses Professional Liability Insurance. And you have a committee, a panel, Ari Plott, George Tolley, and Chris Figueroa.
Thank you, Madam Chair, and it's great to see all of you from this point of view. My wonderful finance friends. Advanced Practice Registered Nurses, Professional Liability, Insurance Coverage Notification Requirements. Senate Bill 996 is straightforward legislation that would simply require practicing advanced practice registered nurses to notify a patient if they are not covered by a professional liability insurance, also known as malpractice insurance. Advanced practice registered nurses are licensed medical professionals who work as nurse practitioners, nurse midwives, nurse anesthetist, and nurse specialist. There is no requirement that advanced practice registered nurses carry malpractice insurance, and Senate Bill 996 does not change this. This legislation is only about ensuring that prospective patients are informed about potential liability concerns involving their healthcare provider. Understanding whether health professionals are appropriately insured can be an important factor for patients who are trying to plan their care. With the growing number of nurse practitioners nationwide, it is important that patients stay informed about whether their provider has liability insurance. This is the same requirement already in place for physicians and will not result in any added cost for patients. In all, this is simply a pro-consumer bill that strengthens patient choice. I ask the committee for a favorable report. Oh, yes.
Thank you. Thank you. Madam Chair, Madam Vice Chair, members of the committee, my name is Chris Figueroa. I'm here on behalf of the Maryland Association for Justice in favor of Senate Bill 996. I want to reiterate that this bill is a disclosure bill, a notification bill, not a bill that a patient would reject midwifery or nurse practitioners, but one to help a patient decide which nurse practitioner or midwife to choose based on information received, making informed decisions. Sometimes the hardest part of making a decision is not, you don't know what you don't know. So what is the problem now? The problem now is that an unsuspecting patient may choose an uninsured nurse practitioner, midwife, and that nurse practitioner or midwife may not be acting within the appropriate standard of care, and injury happens. A claim may be appropriate, and that insurance coverage is what would provide coverage for that injury. So why now? As Madam Vice Chair mentioned, in 2017, the General Assembly passed a law to require this exact type of notification for practicing physicians. And since that time, there's been an increase in the number of nurse practitioners and other advanced practice registered nurses. In fact, the American Association for Nurse Practitioners says that nurse practitioners will be the #1 fastest growing profession over the next decade. And in 2015, the General Assembly passed a law to allow full practice authority for nurse practitioners to work more independently. So that same disclosure from 2017 for practicing physicians should now apply to all advanced practice registered nurses. And for those reasons and the others that you'll hear, we ask a favorable report on Senate Bill 996. Thank you.
Thank you, George.
Thank you very much. Good evening, Madam Chair. Thank you very much,
to the
I
vice
dreamed
chair.
to this day that we'd be on the same panel.
But it's always a pleasure to be on the same panel with you. Members of the Finance Committee, my name is George Tolley. 7 years ago, this body, this committee passed a law, Janet's Law, sponsored by Senator Klaus Meyer, that required doctors who do not have liability insurance to tell their patients so by posting something next to the HIPAA rules up on the wall and by having them sign an acknowledgement in their file, along with everything else that you sign when you start with a healthcare provider. That bill passed unanimously, 140-0 in the House and 46-0 in the Senate. This bill just extends the same rules to nurse practitioners, advanced practice nurses who 7 years ago practiced with a collaborating agreement or a delegation agreement or what have you with a doctor. Today, they're allowed to practice independently. There are about 3% of physicians who have no insurance and they make these disclosures and patients make their choices. With advanced practice nurses, a nurse practitioner opens a family practice office in part of the state, and patients wouldn't necessarily know whether they were going to be protected, whether their children would be protected by liability insurance unless there's a requirement for disclosure. And that's all this bill does, is require the disclosure so that patients can make an informed decision about who to see and go on from there. Why is it the lawyers bringing this bill before you? Because most of the time, it's the lawyers who end up telling patients that the provider they've been seeing didn't have insurance in the first place. This happens. It's happened in my practice. It's happened in other practices that I'm aware of. And so it's a simple bill, and we hope that you'll view it favorably. Thank you very much.
Thank you. Ari?
Thank you, Madam Chair, members of the committee. My name is Ari Plout. I'm here on behalf of the Maryland Association of Justice in support of Senate Bill 996. Thank you, Senator Klausmeier, for sponsoring the bill. I don't want to be repetitive. My colleagues have pretty much mentioned everything that I wanted to state. As stated, this would apply to nurse practitioners, nurse midwives, nurse anesthetists, nurse specialists. Because I know that the term advanced, I didn't know what advanced practice registered nurses, so I just wanted to clarify what that was. We believe that this should only affect a small minority, because most nurses should already be covered, should already have protection. We have reached out to several of the stakeholders. We're not aware of any opposition to this bill. And with that, I'll submit, and we just would ask for a favorable report. Thank you.
Thank you. Do I have any questions for this panel? I see no questions. That ends the hearing on Senate Bill 996. Thank you.
Thank you,
Senator Klausmeier. You have Senate Bill 408. Opioid overdose reversal drugs. I think you have a panel of Eric Galley and Alonzo White.
Oops.
Maybe.
Thank you, Madam Chairman and members of the Finance Committee. It's great to be back again. It's been so long. For Senate Bill 408, Public Health Opioid Overdose Reversal Drugs Standing Orders. For many years, there was only one drug on the market for opioid overdose reversal, naloxone. And just for the record, when I first heard that word naloxone, probably 15 years ago or so, I couldn't even pronounce it, but we all know it now. It's either naloxone or Narcan. At the time when the state standing order was written, it made sense to write naloxone directly into the standing order to receive these products. Last May, the FDA approved a second drug for that purpose. That newly approved drug is called Obesity, which is the first and only nasal rescue medicine specifically indicated for synthetic opioids like fentanyl, as well as non-synthetic opioids. As drugs like fentanyl gets stronger every year. We should keep working to get new tools in our toolbox to fight this problem. We already routinely hear stories about first responders having to give multiple doses of naloxone to revive overdose victims. Senate Bill 408 aims to help with problems by ensuring that people have access to the opioid overdose reversal medicines that best suit their needs or the needs of their community. The FDA approval paved the way for OPVEE to be on the shelves in Maryland as early as last October. It works to reverse opioid overdose and administered just like the nasal version of naloxone. However, to this point, the Maryland Department of Health has not altered the standing order to include OPVEE, which is keeping it from a very large portion of the market. These two products are essentially similar, but each has certain characteristics that might make a person prefer one over the other. A person who is seeking an overdose reversal drug should be able to choose between all products that have been approved by the FDA for this purpose. The intent is not to require that every distribution site must carry equal amounts of both products, nor is the intent to suggest that anybody get in trouble if they aren't stocked up with OPVEE. This legislation is only saying that the state should not preclude this FDA-approved product as an option. While I am aware that the department is looking into this new drug, and as session drew closer, I realized that we may need legislation to ensure that people can have access to this life-saving medicine. Thank you, and I ask for the committee for a favorable report for Senate Bill 408.
Thank you, Madam Vice Chair. Mr. Galley?
Thank you, Madam Chair, members of the committee. Thanks for sticking it out tonight, and thanks to our sponsor for putting this bill in. I'm going to cut way back since the hour is getting late. I'm here today representing Indivior, the company that makes OPVEE, and I will tell you that since they got their FDA approval, 31 states have welcomed them into their systems. Not all of them have standing with orders, but they have various ways of doing it. But 31 states, according to Indivior, are welcoming their product into the market. And I got for you, I believe they were downloaded onto the site, a handful of states, the standing orders. New Jersey has done it, Ohio has done it, North Carolina has done it, Oregon did it by legislation, like we may have to. New Hampshire, Utah, Mississippi. There's a whole list of states that have done this since the FDA approved OPVEE. We would really hope that Maryland would do it as well. It's a very good product. It has been tested, and again, it's FDA approved. And I will also let you know that we were working out back while you guys were working hard in here, and we had a lot of discussions with advocates, some folks who had a little bit of problem with language. We've got some alternative language that we think is going to work. We haven't shown it to our sponsor yet because she's been in here working, but believe we've got a whole couple of opposition that are now neutral, and hopefully you'll hear from them. Otherwise, I'm also going to have you hear from Alonzo White, who is from Indivior, but he is actually a science guy. He's at the end here, and he is here to answer any scientific questions or any other questions that you might have about the product. So thank you very much for sticking around, and we appreciate your time. Thank you.
Thank you. Who do I have next?
Hello, Madam Chair. I'm honored to be here. My name is Stephen Thomas. I'm a professor of health policy and management at the University of Maryland School of Public Health, and I direct the Maryland Center for Health Equity. I'm here as a citizen. You know, as you're aware, in recent years, the opioid epidemic has impacted too many people and families across the state of Maryland, and it's vital that our first responders and healthcare providers and average citizens have the tools they need. As I said in this hearing, and you have my written testimony, and I've been so touched by the conversation in this hearing. Senator Ellis, you commented on someone who had a high school friend here, and I'm realizing that 53 years ago, I graduated from high school, okay? And the power of social media means that somebody's going to give you a birthday celebration. And while I'm sitting in here, I just turned 71. While I'm sitting in here, I get a message from someone I was in high school with. And I want you to hear this. It goes like this. Happy birthday. A lot's going on. Haven't had much time to text. Last week I was in court. They arrested the guy who sold my son a lethal fentanyl. Sad, long story, some justice, but I'm brokenhearted. That I couldn't save him. He passed out in the kitchen. It doesn't matter if you're a nurse for 50 years. It doesn't matter if you worked in healthcare, in the ER for 35 years. It doesn't matter that you know CPR. It doesn't matter when a lethal dose of fentanyl sold on the street. I tried to save him, but I couldn't. My point to you is that every tool in the toolbox should be available because you're asking us citizens to save our loved ones falling out on the streets. Give us all the tools in the toolbox. That's what Senate Bill 408 attempts to do. Thank you.
Thank you, Mr. Thomas. And Alonzo White.
Good evening, Madam Chair and members of the committee. I am here in a responsive capacity, so any questions that you have about the product, I would do my best to answer at this time.
Do I have any questions? Senator Reedy.
Thank you. Just one quick one. Can you, maybe Alonzo or maybe Eric, I was looking through this issue. This is a drug that is not really, it's not really a competitor with Noxalone. I mean, I don't really care if it is a competitor, but it's not really so much a competitor, correct? Because it's more of a specialty. It's a higher dose. Is that fair to say? It's something that would be tailored to certain types of issues or?
Yeah, so the best way to respond to that, it is a similar product as naloxone, but it is a different active ingredient, with nalmefene being the molecule that initiates the opioid reversal. And so there are other enhancements to OPVEE, the nasal spray, that we could talk about, including an absorption enhancer that allows for more of the reversal agent, the nalmefene, to get into the blood, across the blood-brain barrier, to alleviate the agonist actions of the drug of abuse, the synthetic opioids in particular in this modern age. In terms of competition, I can't really speak to that from a scientific standpoint, but any and all overdose situations, whether natural or synthetic, this product can be used to reverse those overdoses per the FDA indication.
Okay. I think Madam Chair is not, let's talk offline. We'll talk offline. Thank you.
Thank you. Do I have any other questions for this panel? That ends the hearing on Senate Bill. No, it does not. Ann Seacott is here for info.
Do you have a virtual?
And well, we have Ann Seacott, and then we have Nilesh Kalyanarama, and then we'll have the virtual.
Oh, okay.
Unless she's on your panel. Was she on your panel?
No, she was virtual.
Okay.
When I was looking, I didn't realize Ian was going to be speaking.
Okay. So Ann Seacott is for information.
Good afternoon, Madam Chair, members of the committee. I'm Ann Seacott, testifying on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We submitted a letter of information. We got feedback on this bill from some of the folks that run overdose response programs. These ORPs are community-based programs. They are shelters for people experiencing homelessness. They are reentry programs that are able to get for free the overdose reversal medications from the state health department in order to distribute in the communities. And we are simply concerned. We want to make sure that what doesn't happen is that they are inadvertently required to have all the formulations, all the brands, and we don't want the state to have to purchase all of the formulations, all of the brands to get to these overdose response programs. The money's running thin. We need to be able to get products out without adding to any administrative logistical burdens for the overdose response programs. And it sounds like an amendment being offered will take care of that.
Do you have any questions for Ann Seacott? I see no questions. Thank you for
Thanks.
being here. And Dr. Calianarama?
Good evening, Chair Vital and Vice Chair Klassmeyer and members of the committee. I'm Dr. Nilesh Kalyana, the Deputy Secretary for Public Health for the Maryland Department of Health. I'm here to testify in opposition to Senate Bill 408. I think you all know that the department supports strongly opioid overdose strategies. One of the cornerstones of our efforts is our overdose response program, which provides free of charge naloxone to a wide range of community and healthcare organizations to be able to put naloxone into people's hands so that they can use it when they need to do it. Years of education, years of distribution means that we have a really well-trod path forward and people know how to use it. And so whenever we think about this program, simplicity is a key to the success of this program. People know what it is and what to use, how to use naloxone. And so while we always welcome new medications, the nalmefene, into the arena, we also want to make sure that that new medication is offering something more or better before we want to start trying to rewrite what our public health standards are. Once again, glad that this medication is out, but there's some recent studies that show that nalmefene is no better than naloxone. And in fact, there's some suggestion that there's more risk of precipitous withdrawal symptoms like vomiting or other withdrawal symptoms while being used. And so from our standpoint, really, requiring the addition of this would complicate our public health response to this without really adding a clear benefit at this point and potentially even creating challenges when using this medication. I think that this medication is probably best in the one-on-one arena between prescribers and their patients, but not at the public health standing order level. And so for that reason that we recommend an unfavorable report on this bill.
Vice Chair Klassmeyer?
Dr. K, I get part of what you're saying, but if this is synthetic and it can just alleviate and really help the fentanyl overdoses, I don't quite understand why we can't use it.
Vice Chair Klassmeyer, it's not that we can't use it. It's more the issue here is that the naloxone also works against works on any opioids, including the fentanyl, including the synthetic opioids. And the question really that we're trying to ask is, what's the value of saying that you can choose which one when there really isn't a basis for choosing? And when we've done all this education and training, if we're going to add, and we see this with any education program, if we're going to add more nuance or more tools, we want to make sure that there's really a yield for that. And right now, at the public health level, we don't really see that there's a yield on that.
No, I'm just curious, but also with the 31 other states utilizing it, I mean, I guess it's a competition, not a competition, but between the OP and the naloxone. I mean, not that I want to get rid of either one of them,
Sure. So we're not opposed to, we're not the only ones. The Maryland Department of Health is not the only ones that put out standing orders, and we're not opposed to if others want to put out a standing order, other, either providers or local health departments want to do that, and so be it. But from our standpoint, we don't think that it's a good idea to require every standing order to include that formulation. And I think the other piece is we did have a chance to meet with Mr. Galley and got a rundown of the medication, and we just didn't see that it was adding value at this time. And as time goes on and there's more studies, if more data comes out, we will certainly reevaluate in that context.
Okay, thank you.
Senator Mounts?
Thanks, Madam Chair. I'll be very brief. So your testimony was that it's okay for the locals to issue a standing order, but the state's not going to do that?
What I'm saying is that I don't think we should require every standing order to include every formulation. Okay. And so, we're not saying nobody can issue that, right? If a small program wants to do it and they want to train their folks and they can manage that, that's fine. But at the statewide level, we have a pretty robust program already. And the question we have is, what's the value add? And right now we don't see it.
Yeah, help me understand, what's a small program?
I can't tell you what a small program is, but if it's a few people, right, doing trainings, that's one thing, and they may make that choice. That is up to them. We're not telling people they can't do it. We're just saying we shouldn't require it.
A local health department would not do it though, correct?
It would be very unlikely, because from the same standpoint that we have, which is there's this established public health pathway.
Mhm.
It's unclear what the what the benefit is at this time, but I can't speak for them.
But this treatment is more effective for fentanyl than Narcan.
I'm not sure that it's more effective. It is with any medication, it's tested for certain conditions, and they went for FDA approval that it's targeted to fentanyl. But we have decades of experience with naloxone, and it's tremendously effective against fentanyl and all other opioids.
I have a hard time enunciating those words. I apologize. But then the last I had heard, there was a call for double dosing because the current dosage wasn't strong enough to treat many of the patients that through EMS could this be an alternative that would not need a double dose?
That's a little bit harder to say. Because you'd have to compare it directly to the nalmefene to whether the naloxone 4 milligram or 8 milligram. I think the issue more is that when you need naloxone, if you need an additional dose or a double dose, it's still effective, right? And I think what we are seeing in the studies is that the higher withdrawal symptoms that may be seen with nalmefene is a challenge, particularly for bystanders in the public to manage. That's hard. And I've seen them and I've worked patients through them. They're not easy.
Okay, thank you.
Do I have any other questions for Dr. K? Thank you. Thank you for being here tonight. Sorry it's so late.
Sorry.
We have Tony Torsch, favorable with amendment virtually. Hello. You need to unmute. Tony, unmute. I know.
Sorry, it's been a long day, and I'm certainly for you all. Thank you. Good afternoon, Madam Chair, Madam Co-Chair, and members of the committee. I am supporting Senate Bill 408 as favorable only with amendments. The Daniel Carl Torsch Foundation is an approved overdose response program entity. As I think somebody was indicating, what's a small program? We are that program. We provide training in the use of naloxone as well as distributing kits. Last year, we distributed a little over 5,000 doses, and we have on record over 200 reversals. So while, of course, we support the consumer having a choice in their healthcare and medications at their pharmacies and private physicians, we do not support the medications that we're speaking of today, such as Claloxo and Opvee. I can only speak on behalf of my organization, but I can assure you that there are very few private entities such as ours, if any, that are going to be offering and providing those types of medications. Myself, I also lost my son. I've been doing this for 12 years now. We've seen great strides in our state. And mainly, I have to point to Senator Klausmeier for really leading the way. For that, I'll always be grateful. The amendment would be to strike any mandates and requirements in this standing order that requires the Maryland Department of Health and approved private entities such as ours to purchase and provide the other types of this FDA-approved naloxone and naloxone type medication. Allowing these other types of like the high dose naloxone, it's going to significantly increase our Medicaid cost. And so really just a simple comparison, the 8 milligram doses cost about 3 times more than the naloxone does. Sorry.
Thank you. Do you have any questions for this witness?
Just say hi, Tony. Well, later.
So if I have no other questions, that ends the hearing on this bill. And now we will go to Senate Bill 716, the Maryland Medical Assistance Program, Maternal Fetal Medicine Services, Senator Hettleman. Senator, are you bringing up your panel?
Yes.
Okay.
Good afternoon, Madam Chair, members of the committee, Madam Vice Chair, when she comes back. My name is Shelley Heddleman. I'm a senator from District 11 in Baltimore County, and I'm happy to be here this afternoon, this evening, I guess we're getting into, to present Senate Bill 716. This is a bill that would match the reimbursement rates for certain maternal fetal medicine to the Medicaid rates and Medicare rates. And I want to talk about why this is really important. We face many challenges, as this committee well knows, to improve maternal and infant health outcomes. According to the March of Dimes, the infant mortality rate is 6 per 1,000 live births in Maryland, and that is higher than the national average. And there is quite a lot of disparity too in that number. The infant mortality rate is 1.5 times higher for Black births than it is for white births. And the maternal mortality rate for Black women is 2.5 times higher than for white women. This is obviously very concerning. There are a number of, in addition to the disparities, or contributing to the disparities, is inadequate prenatal care. And part of that is access to care. And part of that is the availability of specialized physicians that can provide that kind of care. One of the problems that this bill seeks to address is the low reimbursement rates for maternal fetal medical care in the Maryland Medical Assistance Program. And we know that we need more doctors to be able to provide this care, to address the needs that certainly low-income patients have, and the access to the kind of medical care that we all want. The rates addressed by this bill have not been readjusted in over a decade. They cover some of the services needed by some of the most at-risk moms and babies. And we really need to revisit these rates and to be able to improve the kind of care that Marylanders need and expect for their children. So this bill raises Medicaid reimbursement rates and provides for maternal fetal medical care. And we think it will help to broaden access for the thousands of pregnant women insured by Maryland Medical Assistance in this state, improving the health care of these folks. I want to say, before I turn it over to the other panelists, that I am a member of the Budget and Taxation Committee, so I am well aware of the issues with the fiscal note that go with this bill. But I do think it is really important for us to look at, and you'll see from some of the other testimony that's been submitted, the importance for us to really look at these rates and perhaps taking a deep dive into them over the coming months would be an appropriate approach to addressing this really important issue. So thank you.
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of Pediatrics Medical Group. They are a national provider group that provides care in this space for women and children, really across the continuum of care. Here in Maryland, they are located at 11 hospitals across the state. They staff 6 of the neonatal intensive care units, and they have 7 outpatient maternal fetal medicine physician offices. Now, real quick, maternal fetal medicine specialists provide care to women who are at risk for high-risk pregnancies. So that's women maybe with diabetes, high blood pressure, maybe they're carrying twins or triplets. They might have a history of miscarriage or even some genetic preconditions that really need attention and care. And the maternal fetal medicine specialists provide higher level diagnostic testing, a lot of imaging, so forth, that really look at the condition of the mom and the baby over time, and they help manage complications, and they help to address post-birth care, anything that the mom will need, anything that the child will need. So to the bill, nationally, our client, they treat 60 to 70% of their patient population as Medicaid. Here in Maryland, it's often higher, depending where in the state they're located. So looking at the Medicaid rates and looking at access go hand in hand. And as our sponsor stated, some of these rates haven't been addressed in over a decade. So we're really looking to take a deeper dive into this. Maternal mortality rates are high here in Maryland. Infant mortality rates are high in Maryland. And we're really wanting to work with the department, work with legislators like you around the table and the stakeholders to come up with a path forward to really make the state as safe and positive for women, particularly who are covered by Medicaid in the state. So thank you.
Madam Chair, Barbara Brocato and committee members, here in support of Senate Bill 716 and also representing pediatrics. So I just want to say that these tests, and though we have a big fiscal note, and I want to say that we support comments by other stakeholders, that we should look at the best approach to take care of this problem. Rates haven't been increased in over 10 years. That needs to happen to have the workforce necessary to treat these moms and babies. And I'll just talk real quickly because I have my very first grandchild who happened to be born 5 weeks early. She was a lucky one. She was 4 pounds. My daughter had preeclampsia. Her blood pressure was so high and she was carrying so much fluid that she was in the hospital, in and out for a few weeks. Now, when we have these procedural codes covered at a fair rate, we're going to identify those high-risk moms, and we're going to make sure that those babies are they are not as preterm as they otherwise would be, that they're not a 1 pound baby, a 2 pound baby, a 3 pound baby that could be hospitalized for weeks and weeks, if not months. This is important. We ask for your support, and we're here to say that we want to look at the suggestions of the other stakeholders, understand the fiscal impact, move forward with this committee and the health department. And thanks Senator Hedelman for her commitment, and thank this committee for their commitment.
Thank you, Ms. Brocato. Do I have any question? Senator Ellis.
Yeah, thank you, Madam Chair. Thank you, Senator Ellis, for this bill. And I had no idea of the maternal fetal medicine specialist. Are these providers like board certified in a unique area?
Yeah. Many of them have board certified training at this level. They're, I think at heart, most of them are OBGYNs, and then they go on to specialize in various aspects of maternal care.
Yeah, how many do we have in Maryland of
I don't know the total number. I know for our client, we have, I think 112. Yeah.
In Maryland. That's the total number in Maryland?
Right.
Okay. Yeah. And so are all hospitals have access to these specialists when mom go into a hospital to deliver? You mentioned a few earlier that your client have maybe, is it 6?
Yeah, so our client staffs 6 neonatal intensive care units, which is, maternal fetal medicine, but it's also neonatologists and other maternal specialists in that space. And then there are some hospitals that have maternal fetal medicine specialists either on hand or that work in outpatient clinics associated with the hospital. But I don't know if they're at every single hospital, because I know not every hospital has labor.
Because thanks. So there are around 32 hospitals in this space. So if there are 6 that's covered, what do the other hospitals do that deliver babies?
Well, this is just by our clients. Sorry, we only have the statistics. We don't have the statewide statistics. As Mr. Shattuck said, not every hospital has labor and delivery. I don't know if Peggy is here. Oh, she is. So I think there's someone here from the Hospital Association that would be much better able to answer to your question.
Yeah, if you could follow with me offline with that, because it's getting
Thank
kind of
you.
late. Please do.
Yes.
Because there's a related bill coming in later, and I just want to get this facts and straight.
Absolutely.
So, thank you.
Thank you, sir.
Thank you, Madam Chair.
Thank you, Senator Ellis. Any other questions for this panel? Thank you very much. We have 2 people favorable with amendments, Pegeen Townsend and Pam Casemeyer. Madam Chair. I know.
Excuse me. Hi, Madam Chair, members of the committee, Pam Casemeyer. I'm here on behalf of the Maryland section of the American College of Obstetricians and Gynecologists, under which many maternal fetal medicine specialists are. In fact, the chairman of the section for Maryland this year for ACOG is a maternal fetal medicine specialist at Hopkins. But to be real brief, we do think these codes should be looked at. We have a concern about the bill as it's drafted. We've never put codes, specific billing codes in statute before. And we're not even sure if we have all the codes that are relevant for maternal fetal medicine. They may be relevant for their practice, but there may be other services that aren't covered. And then number two, we don't want to tie it in statute to Medicare. Maybe right now Medicare looks higher, although one of the codes in the bill is actually lower for Medicare than Medicaid. So tying it to one particular payer later on, as you know, if you have to go in and fix statutes, it's a lot more complicated. That being said, the problem is very legitimate. As you all know, maternal fetal health, maternal infant health is a huge priority for the General Assembly. Medicaid has not looked at it for a while, these codes, in terms of what they are compared to Medicare, private, or whatever. So we're suggesting maybe just uncodified language that directs the department to look at these codes and report back about what they found and what their plans are to make them at a reasonable level to assure access.
Thank you, Madam Chairman. Peggy Townsend here on behalf of the Maryland Hospital Association. I could just say ditto. The good news is we're really focused on maternal health. It is a significant problem. This is just one piece. There's a lot of other work going on. Let's take a look at these codes and piece it all together. Thank you.
Thank you. Happy to hear that we're looking closely at it. It's been a long time. It's not been good.
Absolutely.
So thank you. Senator Ellis?
Yeah. So when I asked previous question, folks look back to you and you say you might have some answers. So as far as how many practitioners we have in Maryland in the maternal fetal medicine space, do you have an idea?
That I don't know, but I was going to answer about the hospitals.
Yes, please.
So the level of care delivered in a hospital depends on what level of NICU they have. So there are levels of NICU, and not all hospitals have a NICU either. So it depends on the sophistication of a hospital's particular program, whether they would have these folks on staff with neonatologists, or they don't have NICUs and therefore wouldn't have necessarily these folks.
Okay. All right. Thank you. Thank you.
Senator, I don't see any other questions for this panel. Thank you very much. That ends the hearing on Senate Bill 716. And Senator Hedelman, you're back up for Senate Bill 427. And it looks like you have 4 people on a panel.
Okay, we good?
You're
Good. Hi, I'm Shelley Hedelman, Senator from District 11 from Baltimore County, and I'm here to present Senate Bill 427. This is a bill that would create a pilot program for the creation of overdose prevention sites. We know that over 2,500 Marylanders have died from drug overdose from October 2022 to September 2023. The rise of fentanyl, as the hearing 2 times ago pointed out, and waves of new drugs like xylazine are entering our communities. They've created public health crises in which so many drug users aren't even aware of the kinds of drugs that they're consuming. And these are not just numbers and statistics. They're our loved ones. They're our friends, our neighbors, our relatives. I don't know a person that the overdose crisis has not touched in some way. And what we are seeing is that people who are using drugs are not getting the kind of care that they need. What we have done and what we are doing isn't enough.
we need to use all available tools and ones that are evidence-based and have been known to work, employing a multifaceted, multi-pronged approach that will save lives. This committee and the Maryland General Assembly, we've done important work. Have broadened access to treatment. We've reined in the provision of prescription opioids. We've launched educational programs in our schools, expanding naloxone access, as well as medication-assisted treatment. But we could be doing more. And that's what this bill is about. It's about adding another tool to the toolbox. I want to be really clear here. This bill is not a mandate. It is enabling. It only enables local communities to decide what is best for them. Under this bill, if a community organization, a hospital, a local health department, or a substance use treatment center decides that they wanted to offer an overdose prevention site, they'd work with the local health department and they would have to apply for approval to the Maryland Department of Health to get permission to operate. The bill would create a pilot program in non-residential areas, 2 suburban, 2 urban, and 2 rural sites. Substance users would be able to bring their own pre-obtained substances and use under the supervision of healthcare professionals. And there would be a variety of services that would be offered at these sites: wound care, treatment, education, housing counseling, HIV testing, and other services that would be available to people to connect them. There are over 12 countries that host over 150 overdose prevention sites around the world. There have been no deaths in any of them. In almost 20 years of history, one of these sites, an Insight in Vancouver, there have been 0 overdose deaths, and even the crime in the surrounding 5-mile radius around it has been reduced at a substantially higher rate than in other parts of the city. They've overseen millions of injections without a death, and overdoses in the surrounding neighborhoods have also declined. Similar programs have been operated worldwide. I had the opportunity, along with the chair of the HGO committee, to go last year to New York to visit On Point, where I witnessed and visited 2 sites there that are operated by the Department of Health in New York City. In 2021, Rhode Island was the first state in the nation to adopt legislation enabling OPS. And later this year, there's a new OPS site in Providence that is set to open. This is evidence-based treatment. Over 100 peer-reviewed studies have supported the efficacy of overdose prevention sites. They point to isolated drug use increasing the risk of fatal overdose, because somebody who's going to use is going to use in a back alley, in a McDonald's restroom, or in any restroom in any public space. And they're going to do so by themselves. This provides a safe space with trained personnel who get to know people who come there regularly and get to know their habits and get to remove the anxiety of how to use, where to use, so that they can do so in safety and eventually actually be able to help them move to thinking differently about their substance use. One projection found that if OPS opened in Baltimore, the city would see a net savings of almost $6 million a year. And that's not even going to the countless lives it could potentially save. We should be basing our policies on evidence-based policies and using programs and approaches that are effective in decreasing substance use. These are what should be driving our policy decisions. While I acknowledge it would be ideal to prevent drug use from starting, we have been unsuccessful at doing so. And so what we have to consider in light of the persistence of the devastation of overdose deaths is a new and data-driven approach. I just ask that you keep an open mind and that you listen carefully to the professionals and experts in the field that you're going to hear from, and the ton of testimony that was submitted in written format. And please be open to what you hear. Overdose prevention sites aren't a panacea, but they are a really, really important tool that will help us address this crisis and
help us to save lives. I respectfully ask your support of Senate Bill 427. Thank you.
Thank you, Senator. Who would like to go next?
Good evening, everyone. Thanks for staying here with us this late. I am Regini. I am Executive Director of Baltimore Harm Reduction and a founder of Bridges Coalition for Overdose Prevention Sites. In 2017, when I first started doing this work, political leaders across Maryland were not ready to say yes to OPS. Now we have powerful Maryland institutions on board, as indicated by the slate of written testimony before you. In 2021, the harm reduction program On Point NYC brought many folks on board across the nation. Outside of its uniquely sanctioned overdose prevention site services, On Point NYC offers programming very similar to Maryland's 23 syringe service programs that operate successfully across the state. I represent one of those SSPs. In Maryland, certified harm reduction workers like myself, we are allowed to be there for people before they use, with testing strips for fentanyl and xylazine, with syringes and hygienic supplies. We are there for people after they use, with naloxone, disposal boxes, and paraphernalia cleanup across communities. But we are not legally allowed to be there for our loved ones when they, at that critical moment, an overdose can occur, when they actually are using. However, in New York, in its first 2 months alone, On Point was able to intervene 125 times in 2 months, including 19 uses of naloxone. I have dedicated several years to OPS because of the thousands of conversations I've had about death and life, the hundreds of harm reduction workers eager to interrupt overdoses, the people who deserve to access safer ways to consume their drugs, your constituents, the people you are responsible for protecting. While we've been in these rooms debating political risk, over 15,000 of your constituents have died. Former testifiers, my friends, have died while we've debated the political risk. Allow the health department to enable us to add overdose prevention services to our work. We urge a favorable vote from finance on SB 427. Thank you.
Okay, thank you. Bakari Atabi.
Atiba, close.
Okay, well.
You did better than most. Thank you.
Oh, well, hey, I appreciate that.
You did better than most. Good evening. I'm trying to keep y'all too long. My name is Bakari Atiba. I'm the Community Engagement Specialist and External Affairs for Charm City Care Connection. We're a small harm reduction organization located at 1214 North Wolf Street in the 45th District. We've been there since 2009. But we've actually been focusing on harm reduction since 2017, early 2018. We provide a variety of services in East Baltimore. We have a drop-in space where clients and participants can come in, they can take a shower, they can get a hot meal to eat, they can get clothes. We have a clothing closet. We have supportive services with case management if they need help getting their IDs, if they need help with their birth certificates, social security cards, things of that nature. We offer safe use supplies so they could come in and get clean supplies, try to meet them where they're at. You know, we don't force anybody into treatment. However, we have certified peers on staff which allow them to, you know, assist them for those that actually want to have the treatment. We can assist them with that. We also have an outreach team that goes out into the community. We're hitting like 8 different neighborhoods in East Baltimore right now, giving out the same supplies that we do in a drop-in space, but we're bringing it to the community for those that can't actually make it to our physical location. I've partnered with some of the community associations around East Baltimore, and one of the issues that was coming up was the syringes on playgrounds and alleys, even on people's doorsteps. So we've organized a syringe cleanup team. We go out every day into the community and we clean up syringes in different parks, different alleys, and different neighborhoods all throughout East Baltimore, you know, which is a part of harm reduction for us. The only services that we don't provide that On Point provides in New York and other safe injection sites around is the safe injection room. And I think that's very important because naloxone is good, but it's only great if you reach them at a certain point. It would be better if we could find them where they're at the time they start to slip and be able to provide that service and that safety. Thank you.
Zachary Kozinski.
Thank you. Good evening. My name is Zach Kozinski and I'm a Harford County resident, but I grew up in Cecil County. However, I spent most of my adult life in Hartford. Like far too many of my peers, as a young adult, I began using drugs. 7 years ago, though, I finally found recovery. Since then, however, I've lost countless loved ones to the overdose crisis. And many people ask me why I didn't get help sooner or why those I've lost didn't get help sooner. It's because of stigma and a lack of safe, non-judgmental spaces. For years, my priority was not ditching drugs. I needed my next meal, I needed health insurance, and none of the places that I could get those things allowed me to come while I was high or using. So I didn't go. And without those basic needs met, there was no way that my drug use was changing. I was fortunate enough to have a support system, which so many don't, that helped me access treatment, but I firmly believe if my community had an overdose prevention site, I would have done so much sooner. My experience led me to public health, and for most of my 6 years in the field, I worked in Hartford and Cecil, running overdose response programs and syringe services programs that you've heard about today. These programs distribute Narcan, provide tools to prevent safe disease, and it was my experience at these services, which, by the way, already exist in rural and suburban parts of the state. They save and improve lives, but it was also my experience that they don't go nearly far enough. People come to our programs for resources, but then they leave, and when they inevitably use drugs, many overdose and die alone, and no Marylander, myself included, deserves that fate. Overdose prevention sites provide education and monitoring to keep people alive and at every opportunity facilitate access to services that meet those basic needs, which were not met for me. They also refer to higher levels of care. They can and will save Marylanders like me, bringing us back to our families where we belong. As a public health worker from a rural region, I assure you there are organizations ready and willing to expand services in this way if authorized. And overdose is not just a Baltimore City problem, it's a Maryland problem. Rural and suburban Marylanders who use drugs deserve overdose prevention sites too. Thank you.
Nate Spencer.
Thank you. Good evening, Madam Chair, Vice Chair, and members of the committee. My name is Brittany Spencer. I'm the Director of Opioid Overdose Prevention with the Baltimore City Health Department, here representing the Baltimore City Administration to voice our support for Senate Bill 427. Allowing community-based organizations to establish an overdose and infectious disease prevention services program will provide safe spaces for people who use drugs to consume pre-purchased substances in a supervised setting. Staffed by healthcare workers, case managers, and peers, consumers will have access to wraparound services to address their needs. In Baltimore City, overdose deaths occur at 3 times the rate of homicides, largely because of the powerful opioids like fentanyl. Baltimore alone sees nearly 1,000 residents lost to overdose deaths per year. There are over 200 overdose prevention sites in 14 countries. Many have been operating since the mid-'80s. Not one of those sites has ever had an overdose death. In 2021, New York City opened the first overdose prevention site in the United States. Since then, they've reversed more than 1,300 overdoses. That's 1,300 lives saved at their 2 locations. To date, they have not had 1 death at their locations. Over 100 peer-reviewed studies have shown the positive impacts of overdose prevention sites, which include oxygen and Narcan readily available to avoid and reverse an overdose, a reduction in HIV and hepatitis C transmission, increased engagement in treatment services, access to social, mental health, and medical services, a demonstrated reduction in individual drug use, increased public safety, reduced syringe litter, and overall cost savings for the medical systems and taxpayers. Substance use disorder is a chronic disease that requires comprehensive care and a range of solutions. Overdose and infection prevention sites are not only evidence-based, but a natural extension of harm reduction for our communities and have the potential to save hundreds, if not thousands of lives.
Thank you. We have, I think, one more person on the panel. No, everybody's spoken. Do I have any questions for this panel? Senator Hershey.
Thank you, Madam Chair. Senator, we've had an awful lot of bills into here today that deal with Medicaid and fiscal notes and things of that nature. MDH's role in this is simply to approve the program. Is that all that they'll do?
They'll review the applications and approve.
Okay. And there's not a letter in here from them. Are they supportive of this, or where have they been on this, either this year or in the past? Do you know?
They have, did they put it in a letter of information?
I did not see it.
Okay.
I've seen them all day.
To be honest, I did not solicit one from them.
Okay.
I know that they are very committed to harm reduction. I will say that. I don't know what their position is on this bill
Okay.
per se.
So then the cost of these programs then falls to the local health departments?
So the cost would be borne by local and by private. Right? It's still federally not okay to do this. So it wouldn't be supported by any kind of federal funds, and it would have to be state, local, or private money. And that's how it is in New York. And I believe that's how it is in Rhode Island as well.
Okay, so we don't really know then the fiscal impact of doing this for the 6 locations?
Well, it is what it says it is in the fiscal note.
Doesn't say anything.
Yeah.
Or I'm not seeing it.
If I may, Senator Heddleman,
Sure.
said I could say something. So I just want to name with the fiscal, it's a good question. And their previous fiscal note conversations we've had, I'm just referring to the Department of Legislative Services had advised that MDH can likely implement the bill's requirements with existing resources and staffing levels. So the Maryland Department of Health offers this access program. It's called Access, that actually funds the syringe service programs. So all of that work, which is already legally allowed for us to do, all of that is funded. It's really just that one moment when someone is standing in front of me using drugs and I am supervising them. That is the only moment that cannot be funded by our existing funds. So that moment, that labor, that staff time for my 5 to 10 minutes could be by private foundations. Open Society Foundations is an example of a group that has been funding overdose prevention sites around the world. So they are very eager. And I will say, while there isn't a letter from MDH of information this year, we have very strong relationships with the Center for Harm Reduction Services and Maryland Department of Health and the former the opioid response program as well, that are very interested to see how this could move forward. So
Okay, I appreciate that. It wasn't a knock on your program. It was just, like I said, we've had a lot of bills that MDH has decided to participate in giving us their opinion on things. So
I understand. Thank you.
Just trying to figure that out. So
It's
thanks
good-
very much.
Good clarification.
Vice Chair Klausmeyer.
Senator Heddleman, have you talked to anyone in the governor's office or the governor himself just to see what he thinks? And I only say that because you put all this work into this project, and I get it and I understand it. But if he would just say, I'm not going to do this, I'm going to veto it.
So I haven't had a conversation about that per se. I have spoken with Emily Keller, his opioid, point person. So we've had those conversations. I haven't really come out and asked him if he would support it.
Okay.
Senator Mounts.
Thanks, Madam Chair. Just 2 quick questions. Because in the original testimony, they were talking about where these have operated in other countries and there were no overdoses and no issues. But then there was another testimony that in New York, there was like 125 overdoses and we treated them right away. Can you just clarify for me?
So is that there have been no overdose deaths in any of the over 200 that have operated. People will experience an overdose, and that's where naloxone comes into play, or oxygen. So an on point when a staff, that's really the point of having this site, right? So as a harm reduction worker, if I'm seeing someone, I know the signs of overdose. If I'm seeing, or really all of us do, because we do this, we reverse overdoses. We see somebody kind of going into that mode. Then we can administer oxygen or naloxone, and that's what it means by to intervene or reverse. So that's what I was referring to, is an on point. They witnessed 125 moments in those first 2 months of someone going into overdose mode, and then they were able to reverse it with oxygen and naloxone.
I was surprised with the original testimonies that there has never been an overdose
Yeah.
and there was nothing, in all these other places around the world, but that's not the case. There are overdoses.
Well, overdose deaths
Right.
is what we're talking about when we're saying there has been no overdose deaths in any of the OPSs.
Yeah, but the testimony was there was no overdoses, but they were just treated, which is.
There's a distinction, yes.
Yeah.
To be clear, there were overdoses, yes, but they're not fatal.
And in talking about the insurance and covering this, in the other countries, I'm not sure how their insurance covers it, but is it envisioned that private insurance would be covering some of the costs of the program?
Go ahead.
In New York, it is not private insurance. It is actually just fully funded workers. So it's not necessarily, it really depends, you're right, around what countries have, right? We have universal health care in other countries. But in New York, they are not utilizing the public funding.
Okay. Yeah,
Insurance
and
coverage.
in the bill, it does, it calls for 6 locations, right? 2 rural, 2 suburban, and 2 urban.
Correct.
How did that come up? What was that?
Well,
recipe?
it's, I mean, this bill, we've introduced this for a number of years now, and honestly, it was just so we are not concentrating them in particular areas. And we think this issue doesn't discriminate, right? So it exists, and there are people who are suffering in all parts of the state, and we want to make sure that these opportunities to help are available in all parts.
So how do
And
you-
again, no one is going to say they're going to be here, here, and here. The effort to create one has to come from the community.
I'm just trying to understand how conceptually sort of the narrative of how it plays out, because this is a statewide program.
Correct.
And so you've got the 6 locations, but then you also have this mobile application.
That would be an option for a local community to do if they wanted. It's not something that is separate and apart from.
So that would be in
6.
addition to the 6
It would
locations.
be part
right?
of one of, I mean, it could be part of one of the 6,
Right.
yeah.
Well, I don't want to, it's late in the day. I could go on asking about the mobile and the hypotheticals. But so you'd have 6 locations and then you'd have an option for mobile
That could be
uses.
one of the 6.
So it is one of the 6. So-
It could be if that was what the local community chose to do.
Okay, thank you.
May I add to that? I think, okay.
Senator Reedy.
Thank you, Madam Chair. So, Senator Hellman, I know there's some philosophical issues that some of us have with the idea, but at the same time, I do think we want to look at results and we want to look at how things can be helpful with this obvious tragedy and crisis that we're in. Can anybody, and one person answer, but can anybody on the panel talk about what the data shows as far as this improving rates of addiction in other places that it's been tried in the country? Like I was trying to look in New York and I didn't see any stats related to that just in a quick search, but they have it in New York, they have it in Washington State, I think, right?
In British Columbia.
British Columbia.
Or
I think
Vancouver, rather.
and in California has it, correct?
No.
Not yet. Okay. I mean, do we have any, what does the data say? Are we getting people in, I mean, I'm sure we get some people into treatment, but are we getting people are we seeing rates of addiction drop in Vancouver or, I mean, yeah.
Well, so it's an excellent question. I would say it's really hard to evaluate addiction dropping, right? So the metrics that we do have are treatment uptake and also treatment sort of sustainability,
Yeah.
right? How people, recidivism throughout.
Once you're addicted, you're always addicted. So it's always, even when you're in recovery, I understand that.
Yeah. And so the type of data we look into is what we know is there are in 2017 and 2021, there were literature reviews of the hundreds of data studies that exist around overdose prevention sites because they have operated for 30 years. So there's been a lot of evaluation of them. So in recent literature, systematic reviews of these studies, they've noticed that by and large, there's a treatment uptake. So in different regions, there will be a different number, right? But it's always consistently an uptake in people both entering treatment and staying in treatment. It also reduces, there's research that is shown from Insight as well as New York, that the number of times that people go in and out, sort of that, what is considered this revolving door of treatment, it reduces, right? So people, once they really feel more ready, which often comes with conversations and support from overdose prevention site staff, they would go into a treatment facility and typically stay longer than otherwise. So that's the type of data we do have that can speak to that.
Okay. And then one final question would be, what is stopping an organization like is operating in Baltimore, which sounds like you guys are doing really great work in trying to help the community and clean up the community and after with things. What stops someone from doing this now? I know it's illegal drug use, but are we trying to this bill is pretty trying to set up a licensing regime through the Department of Health, correct? So what would stop a group from operating now and doing this without, I mean.
If I can answer that, The only thing that's really stopping us now would be some type of resolution from the city or some type of approval from the health department that they would support this and that they wouldn't shut it down once it got started, right? That's really the only thing.
Because they would find out because it would.
Yeah, it would be transparent.
Obviously.
It would be transparent. It would be public, but we don't want to move forward without that type of support and without that type of agreement between the community and maybe the health department and the city or the state.
Okay, and just one final conceptual question, then I'll stop, Madam Chair. Thank you. The struggle here is that you're encouraging the activity to happen, which it should not happen. And I know the argument, I understand, you guys have all presented the side of it that I know you believe. I know they've prevented overdoses, but you're gonna have people that come in there and die. I mean, I'd be very concerned about incentivizing people to continue, to giving a veneer of it's really okay to do this because you're in a safe place. You understand? That's a concern that a lot of us have. It's why we have a reaction. Part of the reason I believe if you tell people that it's okay to do something, you get more of it. And so I know that someone who's been in addiction will say, well, the shame was what kept me from. So it's a balance here, but can you just speak to that?
Yeah, and that's a good point. And I understand that. The thing is that we're not really incentivizing it because it's already occurring. And the services that we're providing, they're already accessing those services. So we're not saying if you come here, we're going to give you something extra than what we're already giving you. Even without the safe injection rooms, they're still getting clean supplies. They're still getting clothes. They're still getting showers. They're still getting their laundry done, right? They're still getting food. So it's not an incentive. What we're saying is we don't want you to die. We have evidence that no one has ever died in an overdose, a safe injection room. We're saying like, listen, we already know what you're doing. We're trying to meet you where we at so that we can support you and make sure that what you're doing it as safe as possible. We want you to connect to our supportive services team and our peer recovery specialists. So once we have that trust built, once we have that relationship, when you express the desire to get into treatment, we have those services ready for you. And if they're not coming to us, that's less people that's even accessing treatment. And we're trying to reverse that and prevent that.
Thank you. Thank you, Madam Chair.
Thank you, Senator. And Senator Washington.
Thank you, Madam Chair. And Senator, thank you for the bill. We've seen many iterations of this bill over the years. The thing I see that many times this bill gets held up is because of the safe injection rooms and the optics of them, or even the free syringes or giving away the free things, right? Would you as a sponsor of the bill be amenable to removing those from the bill as possibility to get the bill passed? Because there seems like there's other things in here, like the education, the opportunities, the other things that are in there that seems to be really laudable, like something that we actually really need. Is that a friendly amendment or something that you considered before?
I guess I hadn't considered it before and I haven't really thought about it and I don't really understand why we would do that. I mean, these are things that are available right now. And I think they prevent deaths. Okay. So, right. We don't want people using dirty needles. Right. So I guess I'm not understanding what the link, what you're trying to get at by doing that.
I mean, I guess the question would be then there's been many folks in our communities and, urban communities, Black and brown communities where the folks that live there don't want to live next to a place that gives out free syringes.
Totally get it.
Right. Or there's a safe injection room for you can take the drugs there in a safe manner. It just sends a negative message. So I'm trying to, I wasn't trying to say that, but that's literally what the problem is and what I've heard from other legislators. And so I would love to move the needle on the other pieces that are in here, but there's always this optics of safe injection rooms, free syringes, as much as we know those are going to work, but it's difficult. So I'm trying to find another way to help get to your means.
So that's why it says in there that they can't be placed in residential areas.
Okay.
Right. So I get what you're saying. And the perception is that, that somebody wouldn't want that near their home. And, that's why that protection is in there. Okay. So that's a really important point.
Fair enough. Here. Okay. Thank you very much.
Thank you, Senator. Do I have any other questions for this panel? I do not see any other questions. Thank you.
Thank
Sarah.
you.
Next, we have two additional favorables, Morgan Carroll and Charles Richardson. I think. Morgan Carroll and Charles Richardson. You must be Morgan.
I am.
You
Yeah,
don't look like Charles.
I'm not Charles.
Thanks.
Good evening. I grew up in Anne Arundel County, and when I was 9 years old, my dad suffered a traumatic fall at work. He ended up in shock trauma and was eventually discharged in a full body cast with rods in his back and a prescription for Oxycontin in his hand. My dad wasn't always addicted to drugs. And then one day he was. 1 year ago, my father died of a heroin overdose and forever lost his chance at recovery and redemption. Over those previous 20 years, I watched my dad struggle with this addiction before finally succumbing to it, as many have before him. My dad was not just a drug addict. He was one of the most generous and kind-hearted people to walk this earth. He would give the shirt off his back to anyone who asked for it. My dad taught me how to drive. He taught me how to paint a mailbox. He promoted an unwavering work ethic and was the first person to tell me that if you aren't early, you're late. My dad ran his own small business and will get up at 4 a.m. religiously to pick up all his employees who couldn't get to work on their own. My dad was a loving and devoted father, and he was also addicted to drugs. It's not the result of moral failing. People who use drugs don't always get addicted, but sometimes they do. This game of chance is the difference between life and death. My dad's death was not natural, and it was incredibly preventable. And if this bill had passed in previous sessions that it's been introduced, my dad might be alive today. He may be safe. Of course, I didn't want my dad to be addicted to drugs. The only person who wanted my dad to stop being an addict more than I did was my dad. But at the end of the day, the most important thing to me was that he stayed alive. Next year, I will marry my fiance, and the first man I ever loved won't be there to witness it. I will also graduate with a master's in social work next year, and he will also not be there. I wanted my dad to stay alive, and he didn't. But you have the power to make sure that someone else's dad does. Thank you.
Morgan, thank you for that testimony. Do you have any questions at all for this witness? Thank you very much. And thank you for staying and testifying. It was very compelling. I have an unfavorable Vince McAvoy, if he's here, but in person. Is Vince here in person? I don't see him. I thought we were finally going to see Vince in person. And then our last person to testify tonight virtually is Ashley Toller. Ashley, you need to unmute. We're ready to hear your testimony. Thank you.
Thank you. Sorry. Hello, Madam Chair and members of the committee. My name is Ashley Toller. I'm the Policy and Advocacy Associate with Maryland Coalition of Families. We are testifying today in support of Senate Bill 427. Submitted is also our written testimony. Last year, we served nearly 5,000 families of a loved one with a behavioral health need, including 20% of families with substance use and co-occurring disorders. Only a few months ago did we serve a family whose adult child struggled with substance use disorder. This young adult ended up leaving the state only to be transported back home to be buried by her family. Stories like this are only one of many. Overdose prevention sites provide an increased opportunity to life-saving interventions by facilitating connections to support, enhancing access to other systems of care, and providing a safe site to assist in the event of an overdose. This harm reduction approach can aid in improving the well-being and health of an individual in active drug use, as well as reducing stigma many individuals face related to substance use. We urge a favorable report, and thank you for letting me testify today. And that is all.
Thank you for your testimony. Do I have any questions for this witness? Thank you, Ashley. That ends the hearing on this bill. And our next and final bill is Senate Bill 506, State Board of Physicians Discipline Administrative Expungement. We have Senator West with us, and I think you have Natalie McSherry and Steve Wise with you. or somebody else?
Yes, I think I've got Steve Wise, Natalie McSherry, and Peter Bells will sit next to me to answer questions if questions come up.
That's good because he's not signed in.
I know.
Thank you.
So before I begin, let me just say about an hour ago in JPR, we had Vince McAvoy testify. And so we saw him on Zoom, and the parts of his face that were not obscured by his mask, his headphones, and his microphone were visible to us. So with that as a predicate, let me present Senate Bill 506, and it's a pleasure to be here, albeit late in the afternoon. So under current Maryland law, a physician practicing medicine in the state must be licensed by the Maryland Board of Physicians. In the event of misconduct that violates any statutory disciplinary grounds, a disciplinary panel of the board may, by majority vote, reprimand, place on probation, suspend, or revoke the license of a licensed physician. So many years ago, a well-regarded doctor who's one of my constituents, Dr. Lisa Satterfield, Peter Bell's wife, was investigated by the Board of Physicians and was asked for certain patient records. Dr. Satterfield has 3,300 patients. She referred the request to the vendor managing our country's patient records files, and the vendor then made a mistake and provided the board's investigator with what amounted to patient cover sheets rather than complete patient files. My constituent had the complete patient files in her possession, but the investigator never asked her to provide those files for the board. The peer review physicians working for the board therefore never saw the extensive patient records, only the relatively skimpy cover sheets. As a result of this mix-up, Dr. Satterfield was critiqued as having kept inferior records of her patients. Rather than demand a lengthy and expensive hearing before an administrative law judge, Dr. Satterfield entered into a consent order, placing her on probation for inadequate record keeping for a period of time. Years have passed since the period of probation ended. There's been no further accusation of inferior record keeping, and indeed Dr. Satterfield's record keeping in the first place was completely professional, as the peer review physicians would have known if they'd only asked Dr. Satterfield for her complete patient files. Because the probation is visible to people who look up Dr. Satterfield's record with the Board of Physicians, every time Dr. Satterfield's license to practice medicine comes up for renewal, she has to disclose the prior probation. And this in turn puts the renewal of her ability to prescribe medicine in peril for months at a time. Aware of this situation, MedChi approached the Board of Physicians some years ago and asked the board to draft regulations that would enable physicians like Dr. Satterfield, who've been placed on probation for committing minor infractions of the board's disciplinary grounds, to get their probations expunged. 4 years ago, in February 2020, the executive director of the board reported to MedChi that the board was working to develop recommendations on how to implement such an expungement process. Over a year later, in March 2021, the board drafted proposed regulations along these lines. 9 months later, in December 2022, I corresponded with the Department of Health and was advised that the department was engaged in an internal review of the draft regulations. 9 months later still, last August, MedChi once again inquired about the status of the regulations. This bill is being introduced in order to bring an end to the delays and to put appropriate language into law, providing that by the end of this calendar year, 10 further months from now, and 5 years after this process began, the board, quote, shall adopt, close quotes, regulations enabling physicians like Dr. Satterfield to expunge ancient probations from the public record. So, Senate Bill 506 would require the Maryland Board of Physicians to adopt regulations authorizing a licensed physician to file an application for an administrative expungement of certain limited disciplinary actions. The bill defines administrative expungement as the classification of a record by the Maryland Board of Physicians as confidential, not for public release, and removed from a licensed physician's public individual profile. This means that the prior disciplinary actions will still be visible to the board and may be used by the board for any regulatory purposes. Further, the bill provides that such prior disciplinary actions may also be released to law enforcement or another governmental body as authorized by law. So this is essentially a shielding bill. Senate Bill 506 is also narrowly defined, with only 4 types of disciplinary actions eligible for expungement. These consist of 1, failure to complete continuing medical education courses, 2, failure to renew a license on time, 3, failure to notify the board of a change in name or address, and 4, any offense in which probation was imposed and successfully completed. Furthermore, the bill stipulates that there must be a 3-year gap between the disciplinary action and the application for an expungement. Thus, this bill is a modest attempt to bring an end to the misery endured by Dr. Satterfield and other Maryland physicians who have completed their terms of probation and want to be able to once again walk out into the clear light of a clean disciplinary record. In this regard, last week, I received an unsolicited email from Dr. Dan Morheim, who many of you, I'm sure, know. I'm going to read it. It's just in relevant part. He says, thanks for Senate Bill 506, which MedChi supports. I got a call recently from an ER doctor who, during working in the COVID pandemic, made an addition error in documenting her CME, continuing medical education hours. A random survey caught that, and she was fined $1,000. Now that's on her record forever, including to the National Physician Data Bank, unless your bill passes. Meanwhile, she's been an outstanding doctor for over 40 years. She'd have an easier time expunging a criminal conviction. That was Dr. Morheim's statement to me. Now, the Board of Physicians has submitted an opposition to this bill in which it makes several points. First, it states the Department of Health is still reviewing the proposed regulations and expresses confidence that the department will review them, quote, in all due course, close quotes. This is after 5 years of reviewing the regulations. The entire reason for this bill is to finally produce expungement regulations that will provide relief to Maryland physicians. Second, the board notes that it's required under federal law to report all disciplinary actions to the National Practitioner Data Bank. But presumably, such reports are filed at the time that probation periods are imposed. Years before, under this bill, physicians will be empowered to apply for expungement. The enactment of this bill, therefore, should not in any way impede the reporting of such matters to the data bank. And thirdly, the board complains that Senate Bill 506 will perhaps allow for the potential expungement of serious offenses. I have 2 responses to this argument. First, if the offenses were indeed serious, one wonders why the penalty imposed by the board was only a probation and not something more serious. But second, if indeed there are serious offenses that only received a probation, but that should not be expunged, I would be happy to work with the board to develop an amendment to this bill exempting such serious offenses from potential expungement. In this regard, I note that the draft regulations produced by the board do not single out any such serious offenses and exclude them from the expungement process. And with that, I appreciate the committee's consideration of this bill. And sitting beside me, or two people over, is Steve Wise, who you all know. Sitting next to me is an old friend, Natalie McSherry. She and I were employed as first-year law students in 1973 in the same law firm. So I've known Natalie for over 50 years. We've been good friends. She's a partner at Cramen and Graham today, and she represents lots of doctors in their interactions with the Board of Physicians. With that, Steve, why don't you want to go first?
Sure. Steve Wise here on behalf of MedChi. I think Senator West did an excellent job of laying this out. I'll second his comment that if the term probation in the bill is too broad, we're certainly open to tailoring that. It's not our intent to in any way have serious offenses hidden from patients. But from the start of this, we've felt like a doctor who failed to complete their CME on time and corrected it should have the right to clear that from their public profile. And that's not something that a patient is going to find so offensive that they would choose to go to a different physician because of it. Our real frustration when Senator West informed me that he was putting this bill in is, that this has been 3 years since the board voted to approve these regulations. So it's not like we're asking the board to approve them. They've already done it. But under both, to be fair, under both the Hogan administration and the Moore administration, these regulations have not advanced, and we've asked on each occasion, at least once, that they do so. So that's really where we're trying to get. Thank you.
I was going to say good afternoon, but it's probably good evening. As you've heard, my name's Natalie McSherry, and since the 1990s, I have been representing physicians before the Maryland Board of Physicians. I recognize that patient safety is the primary purpose of the board, but the scope of Senate Bill 506 is limited, and the regulations already drafted by the board and referred to in the fiscal and policy note are extremely narrow and do not involve issues of patient safety in any way. The bill would allow for expungement of only specific categories of offenses that are truly administrative oversights for the most part. Senator West has already listed them. I won't do it again. What I do want to say is that being placed on probation, even for such administrative matters, creates a permanent record for a physician. It is available to the public forever on the board's website. But probably more importantly, from a practical standpoint, being placed on probation can have serious collateral effects on a physician with their hospital privileges, with their board specialty certification, with their participation in third-party health insurance plans, and other aspects of their professional lives. Administrative errors should not have such a permanent reaching consequence. And I gotta correct Mr. Wise a little bit. This issue has been wandering around in what I would call a black hole of administrative whatever, actually since Governor O'Malley's time when I served on his, in 2008, task force on the discipline of healthcare professionals. That's when we first started talking about the possibility of expungement of these minor offenses and probation. The board has opposed a probation earlier that would have provided for a mandatory expungement of reprimands and probations after 3 years. And that actually would have covered Dr. Satterfield, but the board opposed it. It didn't pass. The present bill, Senate Bill 506, is far more narrow. It is not mandatory. It does not provide for a process to require expungement of reprimands and significantly does not limit the process to serious. I'll stop there. I had a few more things to say, but I didn't talk fast enough. What I would say is that this is a very small step toward a remedial measure for physicians, and I ask your support for Senate Bill 506.
Thank you, Natalie. Senator Ellis, did you have a question?
Yes, yeah, thank you, Madam Chair. So I'm curious, Senator West, and if we pass this bill, will we have to come back in a few years and unpass it like juvenile justice reforms that we look at?
I hope not.
Can't imagine why.
I think it's a good bill to begin with. I doubt you're going to need to repeal it in a couple of years from now.
Okay.
But thank you for the question.
Just one.
Do I have any other questions for this panel? Gee, imagine we have 2 unfavorables.
Thank you.
Thank you.
Matthew Dudzik and Lisa Robin. And you are our last 2 witnesses for the evening.
Let's make it good.
Good afternoon or good evening, Madam Chair, Madam Vice Chair, members of the committee. Thank you so much for staying with me. Matt Dudzik with the Maryland Board of Physicians. You have my written testimony, but I do want to emphasize that we're really looking at 2 separate issues here. On the one hand, we have creating a process for the expungement of non-disciplinary administrative penalties. And then on the other hand, we have the expungement of disciplinary cases that resulted in probation. The board has no issue with the expungement of these administrative penalties. In fact, as the sponsors have discussed, the board has drafted regulations. They've been submitted downtown. We've been working very hard recently to follow up with the administration. We've gotten some confirmation as of literally today that they're if we bring it back before the board, on our next board meeting, we can hopefully get some movement on these regulations. So we are working very hard on this. The second issue, though, is where we particularly have concerns, because probation, I think a lot of people think of probation in terms of like a criminal justice context. And that term is not really used in the same way when it's talking about probation that we issue. First of all, probation is never issued for solely administrative penalties, as in penalties that are not disciplinary grounds. The only time the board can issue probation is for a violation of one of the 45 disciplinary grounds. So things like continuing medical education, failing to complete that, failing to renew on time, failing to update change of name and address, those are actually not one of our disciplinary grounds. The board cannot give probation for those cases. Probation is the primary means in which the board places terms and conditions upon a license. And cases that can result in probation include prescribing or administering drugs for illegal or illegitimate purposes, gross overutilization of healthcare, certain sexual violations can result in probation. So these are serious issues. Again, we're happy to move forward with the administrative, non-disciplinary portion of this, but we do have concerns when it comes to expunging probation.
Okay, thank you and good evening, and appreciate the opportunity to provide a few comments. I'm Lisa Robin, the Chief Advocacy Officer for the Federation of State Medical Boards, and I speak in opposition to the bill, but I'm only going to speak to the area of probation, not to the administrative actions or non-public actions. But the Federation believes that this bill could hide important disciplinary information from the public, information that consumers should know when selecting a physician for themselves or their families. And for us, the impact of the bill really extends beyond Maryland and could impact patients and medical boards across the country. The bill would make it easier for a physician with professional conduct issues to leave Maryland and obtain a license in another state without giving the receiving board sufficient information to determine whether that physician would be qualified to practice in their state. The mission of state medical boards is to protect the public, and the availability of complete disciplinary history is critical. Boards, including the Maryland Board of Physicians, carry out this statutory mandate by evaluating not only education and training, but practice history, including reports of prior discipline, sanctions affecting hospital privileges, among other qualifiers. SB 506 would limit the availability of this information to boards as well as to patients, who have the right to know whether their physician has been sanctioned for a potentially serious case of professional misconduct. Disciplinary actions which result in probation around the country are based on the severity of the misconduct, and therefore the board deems them necessary to protect patients. SB 506 would permit a licensee to pursue the expungement of a probation disciplinary action after only 3 years, and would make Maryland the only state in the country to allow such. And lastly, SB 506 conflicts with the provisions of the Interstate Medical Licensure Compact.
Thank you very much for your testimony. So there's a happy medium here somewhere between administrative issues, like our doctor that just didn't have the correct information submitted, and a disciplinary action that any patient would want to know about. So we need to find that happy medium. So if you can submit amendments that would help us.
Certainly, we would be happy to.
My other question is, why is this floated around for 3 years?
Way more than that.
I can only speak to, what the board's role in it, because with the regulation, the promulgation process with regulations, it involves a lot of moving pieces. As the sponsors mentioned, this was originally something that the board agreed to in 2020. We developed those regulations internally, discussed at board meetings, posted to our website for public comment, and so on. That was approved by the board, though, in March of 2021. At that point, we prepared it, sent it downtown to the department for approval from there. Beyond that, I can't really speak to why it stalled out. I know that for a pretty significant portion of that time, there was a regulatory hold on non-emergency regulations because that was during COVID. When that hold was lifted, there was a significant backlog and it took a lot of working through. Regulations have started to move, but there's still quite a few that are.
But Matt, you know, if you keep this done, we don't need a bill. I mean, we're still time before April 8th, so.
The board absolutely would support these regulations moving, and if this bill is what it takes, or if we can get it done without the bill, then that is certainly something that the board would be very happy with. But yeah, it's we agree that there are places to move forward with this.
Thank you. Senator Hayes, you had a question?
Yeah, thank you, Madam Chair. I could totally empathize with Senator West. There's nothing like getting agencies to move like introducing a piece of legislation, right? And so it sounds like what you're saying is the administrative part should be completed sometime soon.
It is not within the board's control, so I don't really want to make any guarantees. But we have gotten some promising feedback from the folks that are
Has the board completed this portion of promulgating the regulation?
Yes, the board has completed.
You've completed, and so is now on to the next thing. Now the probation part sound a little bit. I'm glad you helped separate the two because that sounded like a little bit more problematic. So, but the bottom line is, say we weren't going to do anything on the probation part at all, but we were looking at supporting the senator with getting the regulations done, we wouldn't, and if that was the case, we wouldn't need a bill.
I don't believe a bill would be needed. We already have the authorization to draft those regulations. We just need them to be approved.
Gotcha. Thank you. Thank you, Madam Chair.
Any other questions for this panel? Thank you very much. Thank you for staying. It's only 6:40. Thank you. So, committee members, thank you all for being here and staying tuned. And tomorrow's going to be a little better. Tammy, can we are we